Give you a brief layout of it will be a 2-day event here at Comstech. We will start with the inaugural session. Then we will have technical session with distinguished speakers giving us the lectures, followed by a closing remarks session. For our inaugural session here today, we have Coordinator General Comstech, His Excellency Professor Dr. Mohammad Iqbal Chaudhry here. We have Vice Chancellor, Health Services Academy, Professor Dr. Shahzad Ali Khan. Keynote address will be given by Dr. James Blanchard, who will be here with us online. Other than that, we have our dear chief guest, Dr. Palitha Gunaratna Mahipala, with us here today. And we have Dr. Tariq, who is also the focal person for this event. And lastly, we have Dr. Abdul Rashid, who's consultant, Comstech. So I would like to formally begin the event with the recitation of the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان صدق الله العظيم.
Firstly, I would like to invite for his welcome remarks, Coordinator General Comstech, His Excellency Professor Dr. Mohammad Iqbal Chaudhry.
Bismillahirrahmanirrahim. Assalamu alaikum and good morning, ladies and gentlemen, brothers and sisters, boys and girls. There is whole range of ages, from an old person like me, some literally very, very young people. And also online, we have about 70 people online. And it's going to be a major event because this course is extremely popular and we have received several hundred registration for it. So I'd like to welcome a very distinguished chief guest, Dr. Palitha Gunaratna Mahipala, an extremely active representative of World Health Organization to Pakistan. He has been right at the forefront of COVID-19 war, struggle of our nation against this global pandemic which affected our country in a very profound manner. I'm very proud to have association with him. He has been a great support to many of our activities. My very dear brother, Vice Chancellor of Health Services Academy, which is a premier organization of Pakistan in the field of public health, Professor Dr. Shahzad Khan is here with us. And of course, we have many other distinguished guests, including young man Tariq, who has been taking care of many programs of Health Services Academy, my colleague, Professor Dr. Abdul Rashid, head of the delegation of Nigeria, Sister Dr. Asabi Mustafa, with very distinguished group of people visiting us from Nigeria. Professor Dr. Mukhtar, my dear brother, who is the Vice Chancellor of National Skill University, a very distinguished academician. Dear sister Asmat, I call her because she's the younger sister, and she is heading Pakistan National Accreditation Council with excellence and perseverance. And we have Mr. Yazdani, country representative of Islamic Development Bank, with us also. Along with this, we also have representatives of many diplomatic missions, including Sudan, Indonesia. And brother, you're from? You. Oh, okay. Kyrgyz Republic, and let me tell you this, with Kyrgyzstan, we are actually celebrating a major event in April, celebrating the national heroes of Kyrgyz science and technology. With this, I would also like to welcome all of you for your presence here. We have a very distinguished group of panelists who will be presenting lectures in this very, very important event. You see, I would not really go in depth of many of these issues because I'm generally related to more of the R&D side, but we all know that this course is extremely important. It has lots of meaning and impact. And Pakistan and many OIC countries, 57 of them in 4 continents, suffer from multiple disease burdens. Infectious diseases, metabolic disorders, congenital disorders, cancers, mental health disorders, you just name it. Every disease on the face of earth is actually there in the developing Muslim countries. And healthcare systems in these countries also suffer from improper management, inadequate funding, lack of policy, lack of infrastructure, whole range of limited factors, which are the major impediment in effectively utilizing them for the public welfare. Improper management of hospital and other healthcare facilities leads to decreased healthcare access and compromised quality that we have seen all around us. This course is designed by highly trained professionals of Health Service Academy as an effort to at least partly fill this gap. In COVID-19, we have learned lots of lessons. Of course, we have learned that science can deliver. Science has been one endeavor which delivered and helped in saving the humanity in a major way. But we have also learned many hard lessons. And one of the hard lessons was that health and nutrition has to be on top of the national development agenda. If we don't do that, we'll not be able to survive the next pandemic. Next pandemic is going to be much more vigorous, much more ferocious. And this is therefore important that we place health right on top of the development agendas of every country. However, at the same time, this global pandemic has shrunk the economies. We see the impact of it, of COVID-19 in every sphere. You know, we see melting down economies, food inflation, supply chain disruptions. Very limited funds are available for the priorities which we need to set for the new world. Unfortunately, this is not happening. And in that case, it becomes even more important to properly and efficiently manage whatever the little resources which we have in our disposal. And that is the reason why such management skills are extremely important. Pandemic has also taught us a lesson that we need to develop our healthcare systems for future preparedness and for dealing with the healthcare emergencies of the future. Resilience in healthcare systems are extremely important component of our survival in future pandemics. I'm a biochemist with some background in virology. You can see that next pandemic is coming between 1926 to 2026 or 2027. Predict it, write it down. It is going to happen. And therefore, it is extremely important that we slowly and gradually build our capacity in every aspect of healthcare management. And of course, health and hospital management is a very, very specialized field in which we need to develop the skill set of people in all kinds of disciplines, from communication to financial, from public dealing to communication with the patients, doctors, human resource development, quality assurance, different types of skills which are actually required. And as you would see in the program, most of them are actually covered. The co-organizer of this event, Health Services Academy, is a premier organization. It's one of the top institutions in the field of public health and is also a very proud partner of Comstech Consortium of Excellence, which is an emerging network of top institutions in the OIC world. I'm very proud to be partnering with Health Services Academy and many intra and inter-OIC initiatives. I would like to acknowledge here a very special person, a dear friend of mine, younger brother, Professor Dr. Shahzad Ali Khan, for his contributions, his vision, and his willingness to contribute towards improving the healthcare in OIC member state, and also to contribute towards building a soft image of Pakistan by presenting the excellence which exists in this country. There are so many distinguished speakers today, and among them we have Professor Dr. James Blanchard from Manitoba, Canada. He was supposed to be here physically, but because of reasons which Dr. Shahzad will tell you, he wasn't able to come. He's a frequent visitor of Pakistan, a very great friend of Science and Technology, Health Services Academy, and Pakistan. And we hope that he would be able to visit us in future. We have many speakers, and we are looking forward to learn from their experiences in this very important area of healthcare. Let me very briefly tell you about Comstech. Comstech was established in 1981. It's a premier organization of OIC system, being a steering committee, ministerial standing committee. It is among the top brass of OIC institution. Among 39 OIC institutions, these standing committees stands very high in OIC system. And our mandate is to promote science and technology, which include healthcare in OIC countries, 57 of them. So we have a whole broad canvas of helping countries in many different areas and in many different regions, many different economic conditions, and many different constraints under which we work. Comstech's programs, the whole range of programs, are very happening place. You will really find Comstech busy all the time with a wonderful team of people generating activities, doing meaningful activities, both in the country and outside. And let me tell you a few about some which are related to health and nutrition. Health Africa program, which is a signature program of OIC, we are the responsible of it. So we have been assigned the responsibility of working in Africa, especially in LDC Africa, to improve the healthcare systems, to build the capacity of healthcare professionals, technicians in hospitals. So we have a program in ophthalmology, we have a program in neurology. We have been going to different countries, especially in Sahel region and West Africa, and providing them opportunity of not only benefiting from the experts in terms of treatment, but also to conduct a training workshop for the professionals working on ground. And these programs have been widely appreciated. We had a program in Niger, we're going to have it for Chad, and we're going to have it for Burkina Faso, Mali, and Nigeria. We have a capacity building program with Health Science Services Academy in public health. medical and biotechnology program with the University of Lahore, and healthcare research program with the International Center for Chemical and Biological Sciences in Karachi. We have initiated a major program with biopharma in training of professionals in the field of virology and vaccine. Biopharma host OIC Center of Excellence in Virology and Biotechnology in Indonesia, and we have initiated this program also. Along with this, we also have a program with International Center for Genetic and Engineering and Biotechnology. 5 years, we have set aside about $1 million to conduct various capacity building, research project, as well as training workshops in different regions, which are common between ICGB and comstech. We have a program with the Islamic Organization for Security, which is related to mostly food security and halal food and a whole range of different breeding technologies and others. And of course, CIMIC, which is OIC's institution for halal standards. We are working closely. We're going to have a next event in Uganda and then the next event in Bangladesh. So a whole range of activities are actually planned. Along with this, we are constantly organizing lots of events, including exhibitions of biomedical devices, application of artificial intelligence in health, and other events, training courses of different kinds. This is just a glimpses of what comstech is trying to do. And of course, we can't do it alone. We have to develop partnership. We have already developed partnership with the OIC institution and beyond. But of course, we will be building partnership with many more. I invite you to take part in these activities, benefit and contribute towards the mission, which is a shared mission. I'm extremely grateful for your presence here. I'm once again extremely grateful to the chief guest, who's a very dear friend of ours, for his presence here. And thank you very much for attending this inaugural summit. Thank you.
Thank you very much, sir. I would like to give a brief introduction to our next speaker. As Professor Dr. Iqbal mentioned, Professor Dr. Shahzad Ali Khan, he is the Vice Chancellor of Health Services Academy, Islamabad. He holds fellowship through distinction from Royal College of Physicians and Surgeons, UK, and fellowship of Royal Society for Public Health, London, UK. He has 28 years of work experience, ranging from peripheral level administration to management of tertiary care health facilities. His research work is extensively disseminated through more than 183 peer-reviewed publications in national and international journals. I would like to now invite Professor Dr. Shahzad Ali Khan for his remarks. Please.
Thank you. Bismillahirrahmanirrahim. Assalamu alaikum. It's an honor to actually be at the inaugural of a very important area of public health by the name of health and hospital management. And I'm very much thankful to Comstech for providing all the logistic support and taking this initiative with Health Services Academy. We are a partner institute, but always whenever there is a partnership, someone has to take the lead. The Health Services Academy is already doing a lot of academic things, but Comstech, with its outreach and its linkages, and with so much professionals working here, and the infrastructure which they have, and you can see one of the best auditorium I have visited in Islamabad. So they have all this very high level of assets and infrastructure. I'll just talk about briefly why a public health institute is working in hospital management or health management. You have seen that the public health has traveled in Pakistan mainly because of polio surveillance, a polio response. Public health is needed to eradicate communicable diseases. Number two, you know what happened when dengue came, and then COVID-19. So I will attribute some of the advancement in public health in Pakistan, not to individuals or institutions, but because of these three health problems, which created a vacuum, which created a demand, and the government responded to that. And because of polio, because of dengue, and because of COVID-19, now the focus is on public health. It was a demand since decades. We were not taking care of a lot of things, but because of by hook or by crook, I'll say, because of this need and this emergency and disaster in the name of COVID, we had to assemble ourselves and respond to such a calamity. And this has resulted in a lot of advancement, as well as I will say growth and improvement in the public health system of Pakistan, which still needs a lot more to be done, and hopefully it will be developed more in the future. We have seen the journey of movement from a community medicine perspective, from community medicine to public health. So by lab-based models of insects and incubation periods and infectivity, and a lot of lab-based systems, and then community-based health awareness sessions, that was the hallmark of community medicine. But now you see public health taking care of a lot of things which were not even dreamt of by the past by the community medicine professionals. Why this is important? Because public health needs a lot of diversified skills. You know, those who do MPH or MSPH or DPH or anything in public health, the area of management is missing in them. And we expect these MPH or MSPH professionals to lead organizations and take leadership positions and manage institutions, which is a little bit, to me, a far cry, or maybe it's too much, because they are trained in epidemiology, biostatistics, research, and a lot of other things, but not much is given to them in the form of training in the name of this management. So this was realized by HSA, by our seniors, by our colleagues around, say, 1 year ago. And then I met the Professor Mahipala. He's also a hospital management doctorate. He holds a doctorate in, and I came to know at that time that he is a hospital manager. He headed one of the best hospitals in Sri Lanka, and he had been teaching at various places. And you have to be an MD or a PhD to head a hospital in Sri Lanka. So we shared a lot of ideas, and we came up with this diploma of hospital management, which the second cohort is now going on in HSA. Palitha and myself, we are also teaching, and a lot of you, the faculty sitting here, they are also participating. So this competence of leadership, I think this is something which is needed, very much needed in most of the developing countries. We have all the inputs, we have HR, we have funding which is given to us, we have medicines, drugs, logistics, supplies, we have all that, but we can't govern, we can't manage the organizations. With the same inputs, with the same set of inputs, one hospital is flourishing and doing wonders, and the other hospital is barely surviving. That is the issue of governance, that is the issue of stewardship, and that is the issue of management. So it's the man behind the machine, not the machines itself, which are important. So to us, I think Pakistan producing one of the best doctors, I call it export quality doctors, are produced here, but we don't train them as managers. So when they go into hospitals within this country, you know how pathetic and how bad the management becomes, because they were never trained in management. So that was a missing area. That was an area which was very much highlighted by many of our seniors and colleagues. And similarly, when we discussed with WHO, so they graciously provided us a lot of support in development of the course, in development of materials, reading materials, references. And then ultimately we started, we launched, and now it is continuously, automatically going on. Every year, around 100 managers will be trained in the field of hospital management. And hopefully, it's not just doctors, it's doctors, nurses, anyone who's it's a postgraduate diploma, so anyone who has a graduation degree is eligible. This is something which is done for the first time, number one. Number two, because of its hybrid content, online plus on-site training, we have more outreach. So people in Balochistan, people in Sindh, people in KP, AJK, GB, and merged districts, if they have internet and there is a place where the internet facility is available, they come to that place and the classes are held. And remember that although the science of public health to all of my students here is talking more about prevention, but what happens when somebody gets sick? So you try your best to prevent the disease as a public health professional. But when it comes to when somebody gets the disease, it is also the job of a public health manager or a public health professional to provide the best quality of care, to ensure that the best quality care is provided. So hospitals are working with good quality care. The cost is minimal, the efficiency is there. Quality is good, cost is minimal, the efficiency is there. And definitely the coverage of facilities is there. So many lives can be saved. And if you see what we did in COVID, Dr. Mahipala was at the forefront of response, and he saw it himself. And there are so many statements of WHO Pakistan as well as WHO headquarters that Pakistan response was very good. Why? Because we responded to that moment, and we tried that even if someone gets sick, he or she will be able to get good quality services. Health Services Academy, being a public health institute, why it should be moving into hospital management? We did it in COVID. We trained more than 10,000 health workers of Pakistan through the support of Asian Development Bank, and with the course of Chinese Medical University. We adopted that course. The CPSP trained intensive care specialists. They trained the people. They trained those staff. So they were certified trainers. Their course was also designed by one of the best universities of Hong Kong, Chinese Medical University, Hong Kong, and it was delivered and managed by Health Services Academy. So we did it very nicely, and we hoped and we anticipated, and actually it happened that the care improved with the first wave, to the second wave, to the third wave, and the fourth wave. So gradually the care in the hospital increased, and the fatality ratio came down a lot. So we have the figures of the first and second and third, and subsequently we can write a paper on that as well, that how hospital critical care improvement or critical care training impacted the outcome of COVID-19 cases in Pakistan. The world was surprised, they were not believing in the numbers. I also sit in NCOC as a member. Health Services Academy is a permanent member of NCOC, and there were so many, reservations of global audience, that why a 220 million country only has, say, at that time, 20,000 deaths or 25,000 deaths. They were always raising their eyebrows. And then we provided them with all the data, and we also provided them the data of the graveyard even. They were not, they were thinking that maybe we are not counting the deaths or something like that. But ultimately, they realized that this is something which has happened, and we are a resilient nation. You know that, you know it, and I know it. We are more resilient than any other country. The way we are suffering and the way we survive since childbirth to age of 70 and 80, the way we fight with our lives and with our so much problems in the world. We are resilient, but there was a system response, and there was a lot of family support, there was a lot of community support, and there was a lot of development partner support, like Palitha is sitting here. So there was there were guidance, and there were a lot of support from the world as well. Important thing is you manage that. This is something which is another pillar which was missing in public health. Public health was always talking about prevention. They were not doing anything when it comes to managing the cases. So that is something which we need to do better, because if someone gets sick, he or she needs a best quality or a good quality treatment. Skill set, if you see, management, leadership, it's a science now. Although it's a little bit of arts as well, the personality matters, but most of the skills can be acquired. So what we have thought is to develop a sense of some confidence, innovation, creativity, motivation, which is very much missing in Pakistanis nowadays. We are mostly demotivated. So we want to train the managers, make them motivated with minimum resources. How can you increase the output? So there is a lot of there is a lot of space in this. If people get training and if they get on job, they can deliver much better, and they can save more lives than the doctors which are currently doing. Coming back to Health Services Academy, as you know, it was established in 1988, but there is a long passage of being a subject or the attached department of Ministry of Health to an autonomous organization in 2002, and ultimately a degree awarding university level institution in 2018. So since that, we have progressed into something which is now taking care of most of the health related challenges. It's not just trainings. We are doing three things. One is capacity building training, which is usually in the form of short-term trainings like this, 2 days, 5 days, 1 month, or even a diploma. And there are long-term trainings like we have an MS in public health of 2 years. We have a FCPS community medicine, 3 to 4 years, and we have a PhD in public health, which is 4 years. And we have a BS in public health, which is also 4 years. We are starting some new programs as well. Midwifery training is one through the support of UNFPA and of course Ministry of Health. We are doing a lot of other trainings like health insurance management, like other leadership courses. So there is a space which is available in the country, and people want those skills to improve health system of the nation, health system of Pakistan. And inshallah, we hope that we will be able to contribute something more in the future as well. Coming back to our partnership with Comstech, Iqbal Sahab was very welcoming. When I first met him, he was very ambitious and he talked about health issues. He said this is something which is missing in OIC interactions. We have had several meetings since then. We have entered into the Charter of Excellence and Center of Excellence for Public Health of Comstech. We have developed a lot of linkages with other Muslim countries as well. Out of 57 Islamic countries, 28 are in Africa. So his first priority was that HSA, if it is doing something for OIC, you should start with African nations and more deserving and developing nations, like where we can support. And if we can support the African nations, then we can get support from those developed Islamic countries like Indonesia, Malaysia, and Turkey. So HSA should be delivering downward to all those who are in need, much more need than Pakistan. And Pakistan can contribute something. So these are 28 African nations. And then we will get some support from the leading Islamic countries who are well developed and they are good in health and health system. So this is something which we have started on. We have recently signed another fellowship award for Yemen. We worked for, when this post-US withdrawal from Afghanistan, we did some support for Afghanistan as well. Next month, I think Rashid Saab may inform that we are moving to some of the Central Asian republics where we will be delivering the same hospital management trainings and courses. HSA will be leading, and in some of the Central Asian republics, Kyrgyzstan, Kazakhstan, Azerbaijan, in those countries, we will be supporting initiatives of public health. We can do some online and some on-site trainings. HSA can go there, our faculty can go there, and we can bring on their people. So Uganda, there is an International Islamic University in Uganda. We have met the Vice Chancellor twice. A lot of things have happened, and our team will visit Kampala, and hopefully we will start something, our joint collaboration with that as well. And we, as Public Health Premier Institute in Pakistan, are connected with one of the most developed universities in the world. Right now, as of today, 2 of my teams are signing an MOU with University of Manchester and Liverpool University for public mental health. So hopefully we will be launching a very robust, not only a community-based program, but also a diploma program in public mental health. Not everyone can do FCPS or FRCS in psychiatry, but all of us can do something in mental health, which is the need of the day in Pakistan. You know how much stress is there, and we can still manage some of it. So we will be training managers in public mental health, and the university, Manchester University and Liverpool University Department of Mental Health, both of the universities, they have signed an MOU with HSA, and hopefully we will launch those programs. You will see the launching and start of the programs. In fact, I'm not too much into this celebrations or launching ceremonies. I just want that when we can start, like this is the inaugural, and we will be teaching straight away. We will be coming to the business right after a cup of tea. So we will have this training. Similarly, in public mental health, we have several short-term and long-term courses, a lot of courses which anyone can do, and a lot of courses which can be done by the health professionals. And I will keep Comstech in the loop, and we will do it together, inshallah. And in all the Muslim countries, we will bring in those skills from the developed nations, and then we can transfer the skill to our brother nations. Another one is we are working with Harvard, we are working with Johns Hopkins with a lot of health communication and health system strengthening courses. We have partnered with a leading organization in Pakistan for family planning and population welfare. We have a center of excellence in MNCH. Dr. Fareed Middat is a renowned name. You just Google Dr. Fareed Middat and you will find MNCH all over. All the mortality, morbidity survey are done by Fareed Middat Saab. He's a professor with us now. So most of the, and if you talk about pharmaceutical sciences, pharmacy, clinical pharmacy, Rashid Saab is sitting there. He's comstech consultant, but also a faculty with HSA. So this is something which has happened in the last 1 year, thanks to, I'll say, a lot of friends, a lot of partners, definitely a lot of my team and my colleagues. So there is a lot to be done in Pakistan. And instead of raising sort of voices and shouting and identifying blames and identifying negative things about Pakistan, I will suggest that we start doing something. Inshallah, with you and with all of my friends, we will be doing a great job in the future. So thank you very much.
Thank you so much, Professor Sadat. Up next, we have our keynote address by Dr. James Blanchard. He will be joining us virtually. Dr. James, can you hear me?
Yes, I can hear you. Can you hear me?
Yes, sir. Very briefly, Dr. James Blanchard is a professor in the Department of Community Health Services, Executive Director of the Institute for Global Public Health at the University of Manitoba. He's also a Canada Research Chair in Epidemiology and Global Public Health. Sir, you can begin your address.
And one more thing, James is attached with Health Services Academy. We have a Center for Global Health at the Health Services Academy, and he's a partner. You were supposed to be here, but we missed you.
Yes, it's my loss. I'm sorry I can't be there. Would it be possible for me to share my screen? Is there a possibility for me to share some slides?
Go ahead, go ahead.
Let me see if I can do that. 1 second.
Yes, sir, it's visible.
Is it visible? Wonderful.
Yes.
Terrific. First of all, I wanted to thank the organizers of the meeting and Comstech for this opportunity to share some thoughts today. I really wish I could be there, and I was planning on being there, but there was some last minute changes in schedules and I wasn't able to be there. But I plan to come to Pakistan, as I do quite often, and hope to be with some of my colleagues and friends, including Dr. Shahzad, who has been such a great colleague and partner in a lot of our work. And I wanted to thank him personally for inviting me to be part of this, this session today. And I thought that Dr. Shahzad's initial presentation or remarks really were a good introduction to what I want to talk about. My background is in public health, and I think we've really experienced the great impact of public health on all of our institutions, and we've understood how public health doesn't happen in isolation from the hospital sector. And so I want to talk a little bit about leadership in health, and I'm going to try to focus on the role of academic institutions in health. I think we quite often think of academic institutions more for what they're doing in the areas of research and training, but not necessarily thinking about the kind of vital role that they can play in improving health overall in a leadership role within the health system. And I think as Comstech is assessing the potential role of institutions in Pakistan and in other Islamic countries and their potential contribution to other countries and in other lower middle income countries, I think thinking through the role of academic institutions and articulating that and expanding the role of academic institutions in improving public health is going to be a critical opportunity going forward. And I'm going to talk about that in my remarks this morning. So I think it's important for us to think a little bit about the context. And importantly, if we look anywhere in the world right now in the area of health, countries are thinking very deeply about the Sustainable Development Goals for health, and more importantly, how they're going to achieve their Sustainable Development Goals. These, of course, follow up on the Millennium Development Goals, but with a much broader sweep. And I would say in my decades in global health, I would say that the Sustainable Development Goals have really animated policymakers, leaders at the global level and at the regional level and at the national level. And so I think that we have to really think about the achievement of the Sustainable Development Goals for health as one of the critical aspects against which we should measure our success. And we should align our efforts to try to think about how they're going to help us achieve Sustainable Development Goals for health. If we think about the Sustainable Development Goals for health, the SDG health targets are not really new, but I think that the important thing is that they're broader than where they were before. They're broader than the Millennium Development Goals. And they include areas that such as health throughout the life course, both communicable and non-communicable diseases, and also looking at risk factors, emphasizing environmental diseases. And I think importantly, and particularly for the considerations over the next 2 days at this comstech gathering, the importance of thinking about health systems and the strengthening of health systems. And I think that the strengthening of the health system is really going to be a critical aspect of the success and the challenges for the Sustainable Development Goals. And I think if we think about the health systems and the role of the health systems, universal health coverage has really been brought in as a core theme. And universal health coverage has been defined by the WHO as ensuring that all people have access to the needed promotive, preventive, curative, and rehabilitative health services of sufficient quality to be effective, while also ensuring that people do not suffer financial hardship when paying for these services. So I think we can see here that the concept of universal health coverage isn't restricted to public health or communities service platforms, but also brings into play the importance of the curative and rehabilitative health services, and in particular, the importance of bringing in the sufficient quality of services to be effective. And I think this is where we start to see a real intersection between the public health goals as articulated in the SDGs, along with how we improve the hospital sector and the facilities that are providing curative and rehabilitative health services. So if we think about achieving the SDGs and think about it in the context of universal health coverage, if we want to achieve the SDG goals, we really need to think about the access, the quality, and utilization of key health services. And so if we think about this through the lens of health service packages, we have to really think about them in detail in terms of how are we providing access, how are we providing high quality, and how are we ensuring that those services can be utilized. It's also important for us to make sure that we achieve greater equity in outcomes. And so we need to make sure that critical services are accessible to those who are socially and economically marginalized, and those who are living in areas that are previously underserved. And so how we plan the health system and the distribution of resources is really going to be critical. Now, one way that has been looked at to think about a pathway towards universal health coverage is thinking of it through this construct of effective coverage. Effective coverage was a concept that was identified early by Tanahashi back in 1978 in a publication, the Bulletin of the World Health Organization. And he defined the different components of coverage and how they contributed to or constrained achievement of health goals. So if the way we can think about Tanahashi's framework is we can think about different components of coverage and the different gaps in that coverage. So for example, if we think about the first stage of potential coverage, it's really about the availability coverage. How do we make services available to people? Accessibility coverage, can people use those services? Are they affordable? Are they in places that are reachable? Are they at timings that are convenient enough? And do we have acceptable coverage? Are people willing to use these services? Are the facilities accessible? Are they acceptable? Are they well managed? Do they have streamlined services? So the acceptability of coverage is really defined by whether people are willing to use a service. Whether people use the service or not is another critical component. And so this has been defined as contact coverage. And finally, I think when we think about effective coverage, we really think about whether people are receiving effective care. And that relates to the quality of the services that are being provided. So if we think about these components of the coverage cascade towards effective coverage, you can see that at each stage there can be gaps in coverage. And it's really the combination of those gaps that constrain our ability to achieve effective coverage and ultimately improve health outcomes. And so the goal of health system strengthening and of all of the work that we do in the community side is really to close these gaps, improving availability, accessibility, acceptability, utilization of our services, and the quality of those services. If we think about it in a more specific framework with respect to the hospital sector, we can really think about the different opportunities that we have related to different components of the effective coverage cascade. So if you look at the green bars here, we really are looking at three areas where good hospital management are going to be critical at driving effective coverage. First, if people visit a health service, are they visiting a health service that's ready? In other words, are they going to come to a service that has the necessary equipment, personnel, and capability of providing that service? Did they receive that health service when they come, or are there delays, long waits for surgical services, for example, or other kinds of services? And then, are they receiving that health service according to high quality standards? And so, are we making sure that the service process is high enough to give good quality and quality adjusted coverage? So these three dimensions, which are situated within an overall effective coverage framework, are really critical aspects of improving hospital management. So if we think about the key elements of effective coverage from the supply side, we can think about it in terms of focusing on availability coverage. Are facilities distributed efficiently to provide access to populations in need? In other words, do we have the facilities where people need them? And if they're there, are those services ready to provide services? The other dimension of effective coverage that's really critical is the quality adjusted coverage. Are the services being provided according to clinical standards? And are referral and specialty services well organized to provide higher levels of care when needed? So if you think about the more specialized care, how is that organized? And are there efficient ways of having people access it, either within a facility or if they have to move between facilities? Do we have efficient referral mechanisms to provide specialty services when necessary? So here's an example. We've done quite a bit of work. Those of you who know our institute know that I'll often give some examples from a very large project that we've been doing in North India in the state of Uttar Pradesh, which is the biggest state in India with about 240 million people. It's like one of the largest countries in the world in terms of scope. And I just want to emphasize a couple of features from that work. This is an analysis that we did where we looked at the facilities around the state. So we mapped all of the facilities, and then we did geocoding, and we looked at population centers and villages. And you can see here that we have over 107,000 villages in the state, and each of the villages is a small dot. And there's 161 facilities. And what you can see is that the villages that are distributed across the state, some of them, the ones in the lighter blue, are at more than 50 kilometers away from the closest facility that can provide comprehensive services. So you have these zones within the state that are underserved. And so those zones are going to be not able to provide the kind of effective coverage that are necessary. So for example, if you look in the northwest portion of the state, you can see there's a zone there that has a very large cluster of population and villages that don't have, that are more than 50 kilometers away from the nearest comprehensive first referral unit health facility. So this is a way of thinking about the macro level planning of the health system and thinking about, are our facilities situated in such a way, and particularly the specialty services, the referral services, are they distributed in a way that will efficiently provide service to the population in need? If we think then beyond that macro level coverage, we also need to think about the role of the facility sector in terms of providing the quality of care. And this really relates to whether or not the facilities have the infrastructure for providing clinical services. Do they have the right physical buildings and layout? Do they have equipment and drugs? But also, do they have the quality of care? Do they have the human resource available and the quality of human resource? Do they have good policies and procedures for delivering care? And do they have inbuilt quality improvement mechanisms? A third dimension here, which is very often forgotten within the hospital sector and within the health system sector, is the importance of vertical integration and networks of care. By vertical integration, what I'm referring to is the linking of levels of facilities from the primary care to the secondary care to the tertiary care through efficient referral networks. So in systems that don't have good vertical integration, you have a lot of chaos in terms of the transition of people who need to go from lower levels of care to more specialized levels of care. And many people get lost in that, patients get lost in that whole process. So it's really important to have good vertical integration within catchment areas. Related to this is the concept of networks of care. Networks of care are really about how different facilities interact with each other, and as an aggregate, as a collaborative, as a network, how they improve the overall healthcare delivery and outcomes within a catchment area, and how they link to community processes. And I'll go into a little bit more detail about networks of care as a concept in subsequent slides. So if we look at this, the network of care has been defined as a group of public or private health service delivery sites that are interconnected through an administrative and clinical management model. So here you can see that a network of care is really about an aggregate of institutions. It's not about managing a single institution, but it's about how an aggregate of institutions within a concept, within a context is being coordinated. And I just want to talk a little bit about the domains of a network of care. Let's see if it's here. Yeah, so the first domain is getting agreement around an enabling environment. So making sure that there's an agreement between institutions around policy, financing, getting purposeful arrangements between facilities, and getting trusting relationships between different facilities. The second domain is around operational standards. What will be the standards around defining when to do referrals, what types of referrals? How will there be monitoring of interaction between facilities and how they work together? Is there going to be standards around supplies and infrastructure between the institutions within a catchment area? And how is the workforce distributed across different facilities? The third domain within a network of care relates to quality, efficiency, and responsibility. How is care coordinated between facilities? What kind of clinical guidance, documentation, and review is provided, not just within facilities, but between facilities? And how much benchmarking will there be between facilities in terms of skills and how and skills improvement? And the fourth domain relates to learning and adaptation. And I think what's really important here is to what extent are there feedback loops within the system to look at both patient experience, but also the flexibility of systems for patients and evolving mechanisms to improve the healthcare delivery systems. And I'll give you an example of an initiative where we've really brought the academic medical sector into a coordinating role for networks of care. In UP, starting with the 25 high priority districts, which had about 30% of the population, or about a total population of about 70 million people in these districts. What we did is we worked with a network of medical college faculties to provide mentoring at first referral units within their region. So you can see here in the color coding, each one of these color codes represents a cluster of districts, with one medical college providing a mentoring and supportive role to them. So these 8 government medical colleges provided training and clinical mentoring of government doctors posted in those FRU health facilities. We focused on managing complications of pregnancy, but we're looking at this for pediatric care and a number of other care areas. The idea is that the faculty members of these academic institutions can really help the healthcare providers in these facilities to upgrade their skills, but also to think through their networks of care and their referral mechanisms. It also provides them with an apical institution whereby there can be on-call advice about complicated cases as required. So really trying to bridge the gap between the academic medical sector and the public health sector was the point of this initiative. It's been extremely positively received, and now it's been extended and supported across the entire state. And you can see here, now all of the state is being covered by a group of 16 different medical colleges, each one assigned to a region within the state. And this is basically the approach that we took. So the first step was to map all of the FRUs according to the list, looking at signal functions, human resource, equipment, and drugs. We identified key gaps in the FRUs and finalized the list of FRUs for support. We identified catchment area medical colleges for groups of FRU for mentoring from the medical colleges. We actually had signed MOUs with the medical colleges to train the medical college staff and for them to train the FRU staff, and then developing a systematic mentoring plan and ensure regular visits to the FRU to continue to strengthen the facility service delivery. And you can see that one of the core aspects of what we did is we also have been tracking both the skills and knowledge of the healthcare providers as well as the clinical practices. And you can see here that over a 2-year period, we've been seeing a lot of the facilities moving from lower levels of skill and knowledge of their healthcare providers and lower levels of practice into better levels of practice. And so this is something that we've been doing is doing these regular facility surveys to try to look at how quality of care has been improving. So I'm going to conclude with these 3 points. One is that I want to emphasize that enhancing the effective coverage of hospital-based clinical services is a key element of reaching the SDGs and universal health coverage. Organization and strengthening of the hospitals and strengthening of the hospital sector requires both health system planning at the macro level, but also really well-embedded clinical quality improvement approaches. And the third point I want to make is that we need to think about how do we get the academic medical sector to play a major role in improving the coordination and quality of hospital care. I think it's a real opportunity lost if we're not able to really bring the academic medical sector into that kind of supportive and training and mentoring role within the health system. I'll stop there and thank you for your attention.
Thank you so much, Dr. James. And now I would like to invite our chief guest for the event, Dr. Palitha Gunarathnam Mahipala, who is a World Health Organization representative in Pakistan since April 2009. Please, sir.
Good morning to everybody. Honorable Professor Iqbal Chowdhury, the Coordinator General of Comstech, Professor Shashad Ali Khan, Vice Chancellor, Health Service Academy, Dr. Abdul Rashid, my friend from Health Service Academy, all the distinguished and esteemed academia who are present here today, distinguished participants, colleagues and friends, ladies and gentlemen. I'm deeply honored, privileged, pleased and delighted to be here today to join this wonderful occasion. Another academic exercise started by Comstech jointly with Health Service Academy to enlighten the medical administrators or healthcare managers in Pakistan and some other countries as well. Ladies and gentlemen, it's always good to come as the last speaker because your role is very easy. By the time you come to speak something, most of the things have been already said. So my role is extremely easy. But let me still touch upon few areas which I consider as important. Health sector management is a very complex area, but an important area. And some countries, we have trained health sector managers. Some countries, they go by their general knowledge and wisdom. But it's always good to have a discipline on health sector management. We need to have a curriculum and train personnel to manage health sector. If you look at the investment globally on health sector is 8.4 trillion US dollars. You can imagine the amount of money spent on health sector. During COVID-19 pandemic, it was predicted that the amount spent on healthcare will come down because the per capita income in many countries have come down. But we have not seen that across the world. Still, the commitment for health sector is remain 8.4 trillion US dollars. So when you have such amount of money, you need to have a special discipline to manage. So I don't want to reiterate the importance of having this kind of courses to enlighten the health sector managers to go beyond the usual way of managing, but look at objectively and ensure that whatever the resources available, utilize more efficient and effective way. If you go by the general definition of management, which talk about the utilization of available resources efficiently and effectively to achieve the organizational objective in a changing environment. If you look at this, efficiency is output versus inputs. How much you can gain efficiency by doing your interventions. Then effectiveness, where you look at the intervention, whether it is right or wrong. Sometimes you can have an efficient intervention, but it is not effective because it is not the right intervention. Then of course, your resources are limited. You don't have unlimited resources. So if you invest on one area, you have opportunity cost. You lose intervention and investment on another area. So you need to really work on prioritization and how to prioritize. You need to have the knowledge on that. And then, of course, our environment is changing. If you look at last few decades, the entire world is subjected to many transitions. You are fully aware about the demographic transition and the population aging is changing. And over the last 2 decades, there's about 8.5 additional years added to our life expectancy. And from 60s gone to 70s, 70s gone to 80s. In Japan today, the average life expectancy is 85.5 years. In Australia, the second highest, 84 years. So people live much longer. When people live longer, you have to provide care and they get chronic diseases. So, population demography has changed and we need to manage it. That's one challenge we have to really manage. And then, of course, we see epidemiological transition. Disease patterns are being changed now over the years. We used to see CDs as the most prominent diseases, but now it is changed. Earlier, if it is malaria, diarrheal diseases, treatment is very straightforward, low cost, and you treat once, that's enough. But if you get hypertension now, the non-communicable diseases, the heart diseases, the diabetes, it's lifelong illnesses, chronic illnesses. You have to have lifelong treatment. Interventions are different. So therefore, your cost going up and you need to manage it efficiently. So, all these transition, economic transition, people have more desires now. People expectations are much higher. And earlier, we go to a hospital, what we expect from hospital is completely different now. Even if you have a headache today, you want to get a CT scan done, you want to do MRI scan, you want to get all the sophisticated investigation. Is it needed to do it? So all these a judgment of the hospital director. So therefore, you need to have all this, background information and knowledge about health sector management. And then the lifestyle transition. People have changed. And now many people work with the computers and work. And their lifestyles are changed. Earlier we used to walk. People hardly walk now. So therefore, again, you subject to different kind of diseases. So you need to address all these challenges, for which, of course, you need to have a health sector management as a discipline. I think this is very important. And let me talk a little bit about the recent experience, the COVID-19 pandemic has given so much of experience to different countries. I'm always so much happy and proud about how it was managed in Pakistan. I always tell the response by the government of Pakistan to COVID-19 pandemic is unified, outstanding, and unique. You can't see that in any other part of the world. Many countries can learn from that. And respond to any emergency, you need to have three major areas to be focused. One is coordination and governance. Second is science and epidemiology. Third is communication. If you have these three pillars at the right level, you can respond to any emergency. So if you decide your decisions based on science and epidemiology, then you have the right decision. And this is what we have learned. So therefore, responding to emergencies, you need to have these kind of skill mix in our health administrators or healthcare managers, the skills of coordination and governance, skills of using scientific evidence, science and knowledge for the decision making. Sometimes you have all the evidence, you make a wrong decision based on some influence, but you have to go by evidence based decision making. That's very important in health sector, as health sector is very complex. And finally, I would like to touch upon few of the important challenges we are facing today. As I said, the disease pattern is changing so that non-communicable diseases are coming up as a major issue. And why people are talking so much of NCDs. And today, if you look at the global number of deaths, it's 55 million, out of which 45 million deaths are due to non-communicable diseases, heart disease, strokes, diabetes, and cancers. And it is predicted by the World Health Organization in time to come by 2030, number of deaths due to cancers are much more than number of deaths due to heart disease. At the moment, 17.5 million out of 41 million deaths are happening due to heart diseases, and cancers are around 9 million. But that trend will be reversed because of the food we eat, because the environment we face today. So therefore, we need to manage a very complex situation, and therefore we have to face this challenge. So one is the non-communicable disease. As I said, why people are worried? People die anyway. And I remember when I said, NCDs, people die, and people ask me, why you are worried? And some days somebody has to die. We are not immortal. What is the fact there? The premature deaths, out of the 41 million deaths, 15 million people die before they reach between 35 years to 70 years. You look at a professor of medicine in our country, where government has spent so much of money, he reached the best time of his life in 45 years. If he died due to heart attack, what a loss to the country. So that's why we are very much worried. Number of premature deaths. So how to avoid it? So all that is health sector interventions, for which of course we need to have all this knowledge about what should be the right intervention to go on. And looking at finally what is said by Professor James. That's why I said it's very easy for me to talk, because he has talked in length about universal health coverage. This is the topic today we are talking so much. And when it comes to healthcare delivery, we are talking about two major central elements. One is equity in access, and the other one is quality in delivery. Now, of course, there's another component added, quality and safety. Patient safety is extremely important. If I highlight one example, which I show, few months back, comparing different events. They were comparing, if you travel by air, the chances of meeting with an accident and become a harmful event is very much less, less than 1 in million chances. If you travel by sea, chances are a little higher. If you travel by road, you know how many road traffic accidents, how many people die. And if you go for scuba diving, risk is more, chances of getting accidents is more. If you climb mountains, climbing Everest, you know, it's risky. And then getting to a hospital is more riskier than that. If you compare all these events, getting to a hospital is more riskier because of nosocomial infections. People go with one disease, die due to some other disease. So therefore, we have to ensure that patient quality and safety as a new component. And there's so much of discussion on that, and Professor James also highlighted. So when it comes to healthcare delivery, we need to talk about this. We need to have our knowledge on this. We have to have ideas on this. Access is very important. As said, universal health coverage. We talk about access. Access to needed, promotive, preventive, curative, rehabilitative, and palliative care. The gamut of services we need to provide is the universal health coverage. How we provide all these promotive, curative, preventive, rehabilitative, and palliative care in a qualitative manner, in a comprehensive manner, in a patient-centered manner, in a patient-accepted manner. This is the task in front of all of us. So if you just go by our common sense and wisdom, can we manage the health sector? It is not so possible. If you look at many countries, the amount of money spent on health is very high. America, it is 16.5 to 17.5% of GDP is spent on health, $2 trillion. If many countries in Europe, 10 to 11% of GDP, though Pakistan is close to 1%, many countries spend, the amount of money spent on the health sector is very high. Therefore, we need to have all this idea. We need to have concepts on ideologies on economic management, the efficiency, productivity management, all that. Therefore, I think this is a very timely course you have engaged in. I'm very much happy and delighted that you have started this jointly with Comstech and Health Services Academy. WHO remains committed to support you. Whatever the need you have, we will come forward to support you. And this is very, very much important. And there are some countries, as he said, to become a health sector manager is not easy. You have to do a master's in hospital management, it's 2 years. You have to do a MD in hospital management. Then only you become a fully fledged health sector manager. If you look at globally now, most of the countries, developed countries, they have MBAs who managing the health sector. But of course, there are many issues coming up. They manage the accounts very well, but they don't manage the patient safety well. They don't manage the clinical governance very well. And now the trend is getting doctors trained in health sector management. So therefore, I think this is the right direction, right step. Thank you so much for inviting me. Thank you so much.
Thank you so much, sir, for your words. This marks the end of the inaugural session. We will have a break till 11:30 and then resume with the technical sessions. To the participants, please stick to the time and be here 5 minutes before so we can start the rest of the event smoothly. Right now, we'll move for a group photo outside. Please use both exits. You leave the auditorium and you take the left exit and we'll have a group photo followed by tea, which will be served in the lobby. So please, if you can make your way for the group photo. So okay, we will begin now the first session. So for the technical sessions, Dr. Tariq Mahmood Ali will be the moderator. I'll briefly introduce Dr. Tariq Ali. He's an associate professor of health economics at Health Service Academy, Islamabad. He has served in the public sector in various capacities over spanning more than 20 years. He has vast experience both at university and college levels. He has a PhD in economics from University of Manchester, UK, and FUSAT Islamabad. He has won competitive research grant from national and international level. He has published 14 research papers, international and national peer-reviewed journals. So, Dr. Tariq Mahmood Ali, please.
Hello. James, can you hear me?
Yes, I can.
Thank you. This is Dr. Tariq Mahmood Ali. Thank you very much. This is Dr. Tariq Mahmood Ali. Thank you very much, Hasib, for introducing me. Now, without any wasting time, I request to Jamie, Dr. James, please start your presentations.
Can you, is my presentation visible to you?
Yes, sir, it's visible.
Okay, wonderful. Well, thank you again for this opportunity. I'm going to extend my theme from my keynote address to talk really more about leadership in global public health. In this regard, I'm going to go back to some of my areas of expertise and roots, but again, try to focus more on the role of academia, and particularly the role of academia in global public health. And this really has built on quite a bit of experience. Much of the experience is based on the partnerships that we've had in Pakistan, as I'll explain as we go. And I'm going to be taking a bit of a sweep of history here. Now, when I say a sweep of history with respect to public health, it really is history of public health that's predominantly through the lens of people in Europe and North America, and not other regions of the world. But it's taking a sweep of history of global health and where we are today, based on where I think a lot of the academic discourse has been around public health over the past decades and centuries. So here's a bit of an overview of what I want to talk about in this lecture. First, I'm going to talk about public health writ large and try to trace out a brief history of ideological perspectives and how we've gotten to where we are today in terms of how we think about public health. Then I'll talk a little bit about what I see as new horizons in global public health, and particularly the opportunities. And here I want to emphasize the potential role for collaborations across countries with respect to global public health. And I want to zone in a little bit more specifically about the role of academic institutions in global public health. And I'll take this opportunity to give you a little bit of exposure to how our institute has been focusing on our role in global public health, partly because I think it reflects a somewhat different approach to public health than some academic institutions have taken, and one that we think is an important part of how we've been partnering with the Health Services Academy and other institutions. So let me start back in the 19th century. Many of you might know, and if you don't, then there's a very interesting history to public health and a great paper by Terrace back in 1985 that talked about the early days of public health as we know it. So if we think about public health in the 19th century, it was at that time really an ideological battleground. There was a very strong contention between what were called contagionists and anti-contagionists. Now, the contagionists had an implicit emphasis on, quote, contagious people. How do we keep people safe from people who are unsafe? And if we envision what's happened during the COVID epidemic, we've seen a strong emphasis on that. And the contagionists back in the 19th century, they really leveraged quarantine as a tool for bureaucratic control and exertion of state influence. So it was something that wasn't just around public health, but it also had a very strong political and bureaucratic dimension to it. The anti-contagionists back in the 19th century tended to be liberals and radicals. They opposed state control and power structures, and they really were focusing on a scientific worldview that showed the link between places, poverty, and disease. These were people who were really at the very early stages of thinking about the role of social determinants of health and the link between poverty and disease. And so you had this battleground back in the early days in the 1800s. And these two sort of schools of thought or political dimensions came from somewhat competing paradigms. And at that point in time, the competing paradigms were miasma and germs. I'm simplifying things, but I think you could sort of summarize this contention or this competition between the paradigm of miasma as the cause of disease and germs as a cause of disease. Now, miasma literally means bad air or night air. And it was an ancient theory, and it postulated that epidemics were due to exposure to miasma, this bad air or night air. And it explicitly implicated place as the dominant determinant of disease risk. So what they observed was that people who lived in certain areas had higher disease risk, and they attributed that link between place and disease as being related to the exposure to bad air. The germ theory emerged with advancing scientific and laboratory methods and the discovery of microscopic pathogens, or what were called germs. And then this became a very strong emphasis in public health, and it postulated that many diseases arose from exposure to germs, even if they hadn't identified what those germs were. It started to move away from this idea of place as the cause of disease and more towards the exposure to microscopic agents as the cause of disease. So we have these competing paradigms that were emerging. And you can see this reflected in some of the way that people depicted disease at various points in time. So here's an old drawing that depicted cholera as something that was in the air. Of course, we know that that's not how cholera is spread today. But essentially, what the idea was that whole armies were being defeated by cholera, and they ascribed this to miasma, or the bad air, as you can see depicted in this diagram. So it says the cholera tramples the victor and the vanquished both. So it was really a notion that cholera was spreading through the air. So they hadn't really figured out the causative agent there and ascribed it to bad air. Now, many of us go back to John Snow as sort of one of the really important influencers of public health. But what many of us don't recognize or don't remember is that there was a very strong competition and contestation of ideas around the cholera epidemic in London. And on one side of the debate was William Farr, and on the other side was John Snow. Now, Farr came from the anti-contagionists movement. He supported the place or miasma theory of cholera epidemics. And he used very persuasive statistical analysis to draw conclusions. And I'll illustrate that. Snow integrated sociological, biomedical, and statistical principles and insights to investigate the epidemic. So he wasn't satisfied with this idea that it was just about the miasma. He wanted to think a little bit more about a more causative way of thinking about the cholera transmission and the cholera epidemic. Now, interestingly, both of them came up with very persuasive evidence. If you see in the table here at the top left and in the red square, what you can see is that William Farr did a detailed analysis of cholera rates based on how elevated people's place of living was. And you can see that, for example, people who lived under 20 feet above the high water mark of the Thames River had a cholera rate of 100 per 10,000. And then as you went higher and higher above the water, the rate of cholera was lower and lower, all the way down to 8. So more than a 10-fold difference between those who were living in the low areas and those who were living in the high areas. And he thought that this was very persuasive evidence that the elevation of where you lived and therefore the exposure that you had to bad air was really the driving force behind cholera. So a careful use of data, complete with statistical inference and what have you. Now, John Snow, on the other hand, back in 1854, 2 years later, he actually looked at things not with respect to how high people lived, but how they were clustered. So he was looking at the geographic distribution, but from a bird's eye view. And you can see here, he mapped out household by household where people lived. So he wasn't just thinking about how elevated they were, he wanted to see where they lived and what conditions. And John Snow ultimately used this as a way of coming up with a hypothesis and testing a hypothesis that ultimately won the day. So who was right? Well, statistically, Farr and Snow were both correct, even though they came to different conclusions. But Snow arrived at the most efficient public health solution. He relied more on inductive processes. So he was thinking a little bit beyond just the one theory or the one concept of miasma. And he drew from different knowledge domains. So he used statistical approaches. So he looked at the clustering of disease by geography. He looked at the sociological, how people lived. He tried to think about what was similar among the people who got cholera and what was different, and found that it had to do with where they accessed and how they accessed their water supply. And then he also thought about disease mechanisms and how it could be spread. And here's this sort of apocryphal picture of him breaking the handle off of the water pump as a way of stopping the cholera epidemic, which he had shown was being transmitted at certain common water pumps in London. So it's interesting that we can see that that both had plausible mechanisms and plausible thinking about it based on what was known at the time. They had statistical approaches, but Snow arrived at the most efficient public health solution at the time. Now, as we move forward into the early 20th century, we're now moving into some really important changes. So I titled this, the early part of the 20th century, the move between germs to social medicine, and finally the epidemiological transition, which Dr. Mahipal had talked about, the epidemiological transition. It's something that was really an important part of the last century. So if we think about from germs to social medicine, the early part of the 20th century, the germ theory, which had become really dominant, this idea that everything was caused by an infectious agent, started to become challenged by the discovery of other disease causes. So diseases that had previously been thought to be infectious in nature, like beriberi and pellagra, were seen as, were ultimately discovered to be deficiencies of vitamins, so vitamin B1 and vitamin A for pellagra. There was also a big rise in the non-infectious disease epidemiology in the United States, focusing on individual risk factors. So looking at smoking and sedentary lifestyle and diet and obesity as relations, as individual risk factors for non-infectious diseases like coronary artery disease and stroke. Meanwhile, while in the US, there was this increasing focus on individual risk factors and lifestyle-related diseases, Great Britain was moving much more towards social medicine, and it was really becoming dominant. In many ways, moving back towards the direction of the anti-contagionists from a century earlier. And if we look at this definition of social medicine in 1948, we can see that the idea around social medicine is it's concerned with a range of diseases, everything from rheumatic heart disease and peptic ulcer to the chronic rheumatic diseases, cardiovascular diseases, et cetera. And the important thing here is the correlation between these diseases with social and occupational conditions, and eventually considering them to be preventable through changes to the social and occupational conditions. So not focusing so much on the individual factors, but more thinking about the social conditions in which people live. So this was a very important movement in Great Britain, which differed from the increasing emphasis on individual risk factors in the US. Now we move from there into what some of us in the who are epidemiologists might call epidemiology's golden age. This was highlighted by the epidemiological transition from more non-communicable and chronic diseases, from communicable diseases to non-communicable diseases. And so a big shift towards non-infectious disease epidemiology, particularly looking at cancer and ischemic heart disease. One of the big reasons for this big transition in epidemiology was the emergence of analytical techniques and tools, the growth of analytical epidemiology and regression modeling. So now we could not only collect data, we could tabulate data efficiently, and we could develop statistical analyses and mathematical models to assess the association between risk factors and outcomes. And epidemiology's golden age had racked up some remarkable successes. So they came up with groundbreaking discoveries like the link between smoking and lung cancer and the various risk factors for ischemic heart disease. And the major successes of epidemiology during this stage were founded on the individual risk factor associations with disease and the causal inference, the ability to say that smoking is a causal risk factor for lung cancer, or high levels of low density lipoproteins it has a strong causal inference or a causal relationship with cardiovascular disease. So these were major successes and really drove a big emphasis on the use of analytical epidemiology and non-communicable disease epidemiology in 5 or 6 decades ago. As we move into the late part of last century, the late 1900s, we're now moving into a mix of public health approaches and disciplines. So it's really the bringing together of these different traditions. So we are looking both at risk factors, but also thinking more about the determinants of health, and really moving into what some have described as being modern public health, which is sort of a synthesis of the different traditions. So here we can think about modern public health as two rivers merging. So we have the traditions of social medicine and the thriving non-infectious disease epidemiology converging, and they created dominant themes in public health and epidemiology. So it was discovering and confirming risk factors for chronic disease, but also tracing those risk factors back to the underlying social determinants and linking them to the proximal risk factors for disease. So thinking about risk factors as not just being present as behavioral constructs, but also being linked to social determinants, so that people who had higher risk factors for disease also had aspects of their social conditions that were linked to those risk factors, the so-called causes of the causes that some have described. And so we can see how they're bringing together the individual risk factors along with the social determinants was a really hallmark of modern public health. And we can see this as being framed by looking at the whole area of inequalities becoming a really dominant theme in modern public health. So thinking about the social determinants of health, leaders of social epidemiology like Michael Marmot started to show the really strong social gradient in health and health outcomes. And then thinking about how those social determinants were reflected in the more proximate determinants of health outcomes over time. And you can see here this 1984 summary of child survival by Mosley and Chen, which is a really, really early description of the link between social determinants of health and the more proximate determinants. So you can see here in the Mosley and Chen framework, you start with the underlying social determinants at the top of their framework, leading to maternal factors, environmental contamination, nutrient deficiency, and injuries that then influence who's healthy and who's sick, and then who gets treatment and prevention services, and ultimately affecting who's sick and who dies. So you can see that this model that Mosley and Chen came up with was linking together those social determinants or the social epidemiology along with the, or what the British called the social medicine, along with the more individual level factors. And this was sort of the hallmark of what has been called modern public health. But as we moved into the 21st century, we started to see a reprising of the contrasting paradigms for public health. So what started to happen is that as public health disciplines started to specialize and subspecialize, you ended up with some fragmentation. So instead of the rivers merging, we now had some divergence, and we started to get more contrasting of paradigms for public health. So if we think about it, we can see that there was a very strong emphasis on health protection as one aspect of public health. And this was sort of global health security was a big issue. These were all figures that I pulled out from before the COVID pandemic. But then you can see in this Time magazine article about how the COVID-19 epidemic and framing it as when the world stops. And those of us who've lived through the COVID pandemic can see that in many ways it really stopped things. But you can see that this framing of public health has become dominant. It's about reacting to pandemics and health emergencies in the public health domain. But it's not the only way that public health is being viewed and framed. There's still a very, there's still emerged a very, very strong contagionist construct. So we could see that in the left-hand side, you can see somebody on a ship, but way back in the 1700s, or maybe the early 1800s, the whole concept of quarantine, which then got reflected in the H1N1 epidemic, where there was, and the SARS epidemic, where there was a lot of control over who could travel and who could interact with others. And then of course, COVID-19 brought in many contexts, a very, very strict quarantine construct that in some countries is still being reflected. We also have an emphasis in some domains of public health on individual risk behaviors. So you can see here a big emphasis on prevention and health promotion, looking at healthy lifestyles, smoking cessation, improved behaviors with respect to sexually transmitted infections, and even the use of the posting of calorie counts in chain restaurants, as an example, in Canada and many other countries now. So you can see that this stream of focusing on individual behaviors and risk factors still is a very strong theme now in public health, contrasting with some of the others. And of course, the social epidemiology, or the focus on social determinants of health, has not left us. You can see that there's still a very strong emphasis on the importance of action on the social determinants of health as a way of improving health outcomes and equity. So you can see here, all of these are representations of how focusing on poverty reduction and improving the living conditions is really, really important for health. So in many ways, we have gone back to some fragmentation in public health in a way that there are different streams, different paradigms, and different organizations and different specialties tend to be somewhat fragmented. And we get dominated by new activities or new events in public health, like the COVID pandemic, which can in fact exacerbate some of these contrasting views. So if we think about new horizons in public health going forward, I think there's probably an important emphasis that we have to think about reintegrating a lot of these ideas. But here are some of, what I would say are some of the really important dimensions of public health as we go forward. So the first is what I'll call magic bullets. There's really a rapid increase in biomedical interventions, new discoveries all of the time. Some of them obviously are remarkable. For example, the remarkable development of COVID vaccines. But there's in many fields, we're seeing remarkable advances in biomedical interventions, and the very strong emphasis on delivering these efficacious biomedical interventions. So we have new vaccines, new drugs and vitamins, micronutrients, pharmaceutical agents, health technologies. All of these biomedical interventions have really changed the face of public health. And there's been an increasing focus on what's called implementation science in public health to scale up interventions. So this idea of how do we translate efficacious interventions into effectiveness at the population level. And so there's a big emphasis on this idea of how do we increase coverage and how do we increase the fidelity of these interventions. So I would say that one important theme going forward is how do we integrate magic bullets into the system, or new biomedical interventions into the system efficiently and effectively. And what we can see is that there are sometimes challenges with these. How do we think about efficacy to effectiveness? One example is the effectiveness of HIV highly active antiretroviral therapy. And what we know is that it's incredibly effective at reducing transmissibility of HIV, but in real world practice, it hasn't been so successful. And here's two examples in South Africa back in 2013. Even though there is very high coverage of HIV treatment, 30% of people living with HIV who were on ART had high viral load. So clearly there was not effectiveness, even though there was an efficacious intervention. And we saw even in China, which had very high coverage of HIV treatment, there was still a substantial, there was still only a 26% reduction in HIV transmission in discordant couples. So the promise of the magic bullets is not always matched by the public health impact. And we can see that part of this is related to the social determinants of health. So the effectiveness and the impact of new biomedical interventions can really be conditioned by or modified by social determinants. So if we look just at the uptake of the COVID-19 vaccine in the US, it's really highly variable by geography and social vulnerability. So you can see here that The purple areas are places that have the places that have, the orange places, I should say. So a lot of the Southeast, these are places that have high social vulnerability as well as a low proportion of the population fully vaccinated. So you have big swaths of the US that have high social vulnerability and a low percentage of the population fully vaccinated. So you can, but the important thing to see here is how variable it is. The pattern is incredibly variable in a country where availability of the vaccine is very, very high. The means for delivering the vaccines are there, but the use of the vaccines is highly dependent on where you live and social vulnerability. Another new important theme as we're thinking about public health going forward is the whole concept of health equity, a really major component of the SDGs with a very strong emphasis on leave no one behind. But then the question becomes, what are the mechanisms for doing that? And there's a healthy debate in public health around whether we should focus on the concept of sick individuals or sick populations. And importantly, this idea of should we be putting more emphasis on reaching the high risk population or the susceptible individuals, or do we try to have broad-based solutions? If we think about it in agricultural terms, it may be the difference between drip irrigation and flood irrigation and which one is more likely to have the biggest impact. And there's been a healthy debate. I won't go into a lot of detail, but generally the idea of a population-wide intervention, as Jeffrey Rose has suggested, it really assumes a homogeneous effect of an intervention. That is, if you shift the whole level of risk exposure, then everybody benefits. There will still be people who have who are at either end of the tail of the distribution in terms of level of risk exposure, but overall everybody benefits by the same amount. But what we actually find out is that with many interventions, that there's a concentration of benefits for people who tend to be less vulnerable, and there's a concentration of risks that remain. So you get a widening of the disparities between those who are at the higher end and those who are at the lower end of benefits. The other new area that I think I would highlight is the emphasis on complexity and integration and moving more horizontally and diagonally in public health. And this is really the idea of moving away from individual disease control programs to thinking about reconceptualizing disease through the lens of syndemics. The idea of syndemics is that you get health-related problems clustering by person, place, or time because the reasons for their clustering are the same. So in the same places that you have high levels of tuberculosis, you have high levels of injuries and mental health and others. And so these are called syndemics. The concept around syndemics is that you must not only prevent or control each disease, but also the forces that tie those diseases together. And you can see that this is now re-echoing the concept of social medicine that was prevalent in the middle of the last century. And we've seen a lot of inward looking and a critique of epidemiology that had become very individually focused to start thinking about more the macro level forces. A study of the causes from a truly population perspective, not just an individual perspective, is a new dimension, thinking about the complexity. So that's kind of a bit of a historical and maybe future-oriented look at public health. But it begs the question, how can academic institutions be relevant to public health? Because as society grapples with new public health challenges, can public health institutions and academic institutions in public health be more than just the ivory towers that's doing the research or the places that are doing training, to start becoming more relevant to public health. And I think that over time, there's an increasing demand that our academic institutions become more relevant to help solve the problems that we're facing as a society. Well, there's two areas, of course, that academic institutions can be relevant. One is through knowledge generation, learning what needs to be done and setting priorities, and learning what works to improve health and developing strategies. That's the knowledge generation piece. But then the question is always, how do we close the know-do gap? How do we take what we know and make it influence what is done in public health? And this is really the challenge of knowledge translation. How do we synthesize knowledge and support policymakers and program leaders to develop policies and to help them plan and implement effective programs and services? And this is where I think academia in public health has really failed. As we focus so much on the discovery part, on the research and on the training, I think we too often have left alone the challenge of knowledge translation. And this is, I think, a challenge for the future as we go ahead. So naturally, there's been critiques of academia in global health. When it comes to research, the critiques are that academia selects research topics that are mainly based on faculty interests. So this faculty member is interested in that research topic, so that's the research that gets done. In global health, we too often see other countries as contexts for research. And very often the research is failing to answer the pressing public health questions that policymakers and implementers have. Our knowledge translation tends to be unidirectional. We tend to focus on getting our research into practice. You know, the model of a researcher does a study, publishes the study, and then tries to persuade policymakers to listen to the implications of their research. But we don't support the getting research out of programs and practice. We don't build learning into the actual practice of public health. And in education, we too often provide very superficial field opportunities. So people who are training in public health don't really understand how a program works. They don't really understand the challenges that public health faces. And very often we transplant institutional training models from the global north to other global contexts. And I think we're all somewhat guilty of that. Now, we've been working with a number of academic institutions and the CDC in the US and a number of countries on an initiative that's trying to address some of these issues. And we call it the Program Science Initiative. And the idea around program science is that it's the systematic application of scientific knowledge to improve the design, implementation, and evaluation of public health programs. The idea of program science is to really close the know-do gap, and it's to build partnerships between academia and public health. And when we think about program science, it has two aspects. It's a research domain or enterprise. So it's the building of a theoretical base for programs and methodologies for studying programs. But more importantly, we see program science as an interactive process. This is the dynamic interaction between scientists, program and policy leaders, and implementers and practitioners, creating that space to understand what the pressing questions are, and then coming up with solutions that will answer those questions using the rigor and the capabilities of academia. And so if we think about this, it's really putting science into the program. And so if we think of a program which has a number of different steps here, from goal setting, developing strategic priorities, planning and designing interventions, implementing interventions, monitoring and evaluating programs, we want science to be embedded and influencing and engaged in all of those processes. So that if we deploy science within programs, we can really come up with better insights that can influence each stage of a program design and implementation. And then out of that, we'll have learnings that can be shared externally, so outside of the program, to influence policy at regional, at national and regional and global levels. So the idea here is not that science is outside of programs and informing programs, but that science is becoming embedded within programs and it becomes an integral part of the programmatic process. This is something that our Institute for Global Public Health does. We were a center for almost a dozen years, and we were now set up as an institute with a university-wide mandate. And I want to just sort of illustrate how we're trying to articulate and operationalize a program science model through our institute. Our institute has a fairly broad geographic footprint, though we focus really on 4 countries. We focus on South Asia, Pakistan and India, and we focus on Africa, Kenya, Nigeria. And that's where we have our main offices as depicted in red here. We work in a lot of other countries in Africa and Southeast Asia and all the way up to Ukraine. But our major emphasis is on our embedded partnerships in these 4 countries. Our approach in each of these countries is we have programs with field program implementation. This is where we develop experience and innovation around program needs and program deliveries. We work through research and technical support with subnational and national programs. We provide analytical support. We engage in research to try to understand how to better influence programs. And then we have a component that looks at global and national and global knowledge translation and dissemination. Our institute also has a major integrating role for global health leadership. So in addition to our country-based programs, we are also the lead organization for the Countdown to 2030 for Women's, Children's, and Adolescents' Health. In addition, we're the lead organization for the Global Program Science Initiative, and we're a WHO Collaborating Center for Health Services and Systems Performance. So we take the experiences from our program partnerships to these global initiatives and vice versa. An important part of what we do is we focus on establishing sustainable synergistic partnerships. And what I want to emphasize here is that we see these partnerships as linking together government programs, academia, and implementing organizations, which often are in civil society sectors. And a great example of that is our partnership with the Health Services Academy in Pakistan, where we have worked on developing a global health department with them to try to really bring a strong scientific approach to public health, and then working with partners at the local and at the provincial and at the national level to try to see how the academic enterprise can help them with their planning and implementation and evaluation of programs. These program science hubs are partnerships between academia and programs, and they act as an effective center for activities across our streams. We also have a physical infrastructure and administrative support in each of our countries, and we create space for learning, and we establish strong long-term relationships with stakeholders. In Pakistan, as I mentioned, we have partnerships with the Health Services Academy. We work closely with the Ministry of National Health Services Regulations and Coordination. We've also had some partnership with Fatima Jinnah Women University in Rawalpindi. And in the past, particularly, we worked very much with the National AIDS Control Program in Islamabad, particularly in establishing the National HIV Surveillance Program there. Some final observations. I would say that we find that rapid change in capacity and expectations of country and subnational public health program leaders. There's a real readiness to innovate and iterate. We find that public health leaders want strong and sustained technical partnerships with academia, and they're open to diverse health system models. We see a substantial opportunity for the academic sector to catalyze improved programs and systems and leverage those investments. We need to increasingly think about platforms for delivery, both in terms of health services and health personnel. And we also think, as was mentioned at the very beginning of this session, in line with comstech's role, there's a really high value can be achieved by linking countries and initiatives with common themes and issues. And I could see a strong opportunity, for example, for public health institutions in Pakistan, partnering with other countries to really strengthen the use of science in public health programs. I'm going to stop there and look forward to any time we might have for questions. Thank you for your attention.
Thank you. Thank you very much, James, for very informative and knowledgeable presentations. Now we have a question answer session. We will take 2 questions from the hall and 2 questions from the online audience. If anybody have a question, please raise the hand. Please take a mic.
Thank you, James, for a very nice lecture, and I'm grateful for the intriguing talk. And I want to ask one thing, that while you started involving academia in general practice or basic health facilities, with which part of the care did you start with, or which part of the care do you advise us to start with? It should be a part of acute care, or readily remediable diseases like infections, or implementing the referral pathways, or a continuous teaching activity for non-communicable diseases. Which thing do you advise first? Thank you.
It's a great question. I would reframe it. I think what I would say is start with a public health objective. Now that could be, for example, an objective to reduce the impact of chronic diseases or mental health. There's new mental health partnerships at Health Services Academy, for example. So instead of thinking about starting with a component or a platform within the health system, I would start with a public health goal. Now, a public health goal is usually achieved by looking at the interactions between community processes, primary care, secondary care, and tertiary care. So I would think of it from a catchment area, starting at a district or a sub-district level. But my emphasis would be that instead of thinking about starting at a particular facility level, I would think about what is the public health challenge that you're trying to achieve? What are the goals? What are the pathways towards achieving that? And then thinking about how you link them together. Increasingly, we need to have this integration between community, primary care, and the different levels of hospital care together.
Well, thank you, James. The next question from the online audience, Aruj. Aruj, you have raised the hand. Have you questions?
I think he's muted.
Yeah. Hi. Thank you so much for giving me opportunity to ask a question. I'm a biochemist and food scientist. So my question is, how food play important role in public health administration? Because food is a very basic necessity in our society. So what kind of you programs are doing with public health with related to food, and that is a better interaction with the food and the infectious diseases? So we can make a better implement in our society, especially in Pakistan, where we should need to implement very basic concept with the layman, a common layman, how you can eat a healthy food to prevent yourself from diseases. Thank you.
Yeah, it's such a great point. I talked about the bifurcation between academic medical sector and public health, but perhaps even more important is that we have a bifurcation between areas like nutrition and health, or education and health. So I think with respect to food systems and nutrition, it's really such a critical thing. And I think we need to think about what is the role of programs that are supporting better diet and more adequate nutrition in supporting health outcomes. And so increasingly, we need to think about the integration of nutrition and programs at all levels. At the community level, it's about looking at food security, but also looking at educating people about good dietary intake, starting with newborns and all the way up in terms of the stages of life. But then I think also, even within institutions, it's important to bring in dietary counseling from primary care and on up. Those are areas that I think every good health system will also have a strong nutritional department. So I think that's an area that is underdeveloped.
Thanks, James. The next questions.
Okay, I have a question regarding the germ theory. Recently, Bill Gates.
I request you please ask a very precise and short question.
Yes, it's a precise question. Like Bill Gates talked about the germ team, the Global Emergency Response Team recently, and he has published a book on how to prevent next pandemic. So what's your opinion regarding the germ response team? Like there must be a global emergency response team and we will be assigning some tasks to them to prevent next pandemic, and we will be ready pre-pandemic, like we will be ready. So what's your opinion about this team? Is it a good idea to prevent?
So about a decade ago, maybe a little bit more than that, I remember having a conversation with somebody about global pandemic planning and preparedness. And one of the things that we talked about was that no country and the global community as a collective, we're preparing for the next pandemic. What I mean by that was developing the capability for developing diagnostics, developing vaccines, et cetera, because no single country could obviously have the manufacturing capability, and countries wanted everybody else to lead. And so I think that what we learned in COVID is that any delay in the availability of manufacturing capabilities for everything, everything from PPE to vaccines to diagnostics, can really affect the outcome of pandemics. So I think that there needs to be a burst capacity or a latent capacity that's there. I'm not familiar with the germ team concept. I haven't read the book, but what I would say is that I think the idea of having a latent capacity or a residual capacity for responding is necessary between pandemics. We can't just wait for the pandemic to come to ramp up our responsiveness. And I think we've learned that. I don't know that countries will come together to do that. I'm a little bit less optimistic about that, because just as people don't save money for a rainy day, it's hard to get countries to set aside money for something that might happen. And our country, Canada, is among the worst. In the months leading up to the pandemic, we completely dismantled our emergency response program in the Public Health Agency of Canada. It was a complete misstep. But it's typical of what happens. It's hard to prepare when you don't have the threat right in front of you. Thanks,
James. This is the last question. Ladies and gentlemen, we have a short time. We want to start the next sessions. So it's the last question, please.
Thank you, James, for such an informative session. My name is Architect Umar Shujat Bhatti. I'm basically a healthcare facility designer. With respect to the session and the information that you have shared, I would like to ask a question that how can the built infrastructure be a barrier rather than a source for the nosocomial diseases, specifically in respect to the post-pandemic and the pandemic situations? Thank you.
Yeah, it's a great question. I think that we're only really scratching the surface in terms of the development of infrastructure that can be preventive rather than promoting transmission of pathogens within facilities. It's interesting. There's a concept in public health of different levels of laboratory, and level 1, level 2, level 3, level 4. Level 4 is sort of these laboratories that can manage the special pathogens, the most dangerous pathogens, with containment facilities. One project that we were thinking about working on in our university was the development of a level 5 lab. The level 5 lab would be actually developing model hospital wards and testing them for airflow and other aspects that would reduce transmissibility of pathogens, tuberculosis, and of course, other viral pathogens. I don't think there's been nearly enough research in that area, but I think it's going to be an area we'll see more and more of, people actually looking at this, at structural design, airflow systems, et cetera, to reduce transmission, not just in healthcare facilities, but also in schools and others.
Thank you very much, James. Ladies and gentlemen, if any questions, please send me an email and then we will reply. James, thank you very much. We missed a lot. If you are present here, it's more better, but it's very good presentations. Now we will start.
Big applause.
A big applause for James. Thank you.
I look forward to seeing you all soon. I miss you all, but yes, thank you so much for this opportunity.
Okay, thank you.
Thank you. Ladies and gentlemen, now we'll start the next sessions. The topic of the next session is Principle of Hospital Management. Will be delivered by Dr. Vice Chancellor, Dr. Shehzad Ali Khan. Before he start their lectures, I was just already Mr. Hasib introduced Dr. Shehzad Ali Khan, but I want to tell a few more important things. That there are few doctors who had a management degree, PhD management degree, medical doctors, and as well as he's a very favorite teacher of our university, and outstanding vice chancellor, as stated by the President of Pakistan. Now I would like to request the Professor Dr. Shehzad Ali Khan come to the stage and deliver lectures on hospital management. Thank you.
Assalamu alaikum. Very nice talking on health system management and public health evolution, public health history, and a great presentation on various roles of academia in public health by our friend James Blanchard. We host the Center for Global Health in Health Studies Academy, which is supported by University of Manitoba. This is something which I'll be talking about specifically about the hospital management, hospital as an institute. So from the macro perspective of what the public health can do for the country, for the region, for nation, for state, what a small institution, which we call it as a hospital, can do. As all of you know, a very famous quote that the walls of the hospitals have heard more prayers than the walls of temple, mosques, and churches. 24/7, people are praying inside a hospital. Somebody is sick, somebody is ill, whole of the family is sitting outside the ward, outside ICU, outside OT. So 5 वक्त नमाज पढ़ते हैं, दुआ होती है, हॉस्पिटल में 24 घंटे दुआ हो रही होती है. So एक बड़ा sacred और noble profession है. People who are working in hospital, who are doing good work, they are getting prayers. और बहुत सारे लोगों की दुआएं भी मिल रही हैं और अल्लाह ताला भी खुश होता है अगर काम अच्छा हो. सो ये चीज मैं बार बार जब भी हॉस्पिटल मैनेजर्स को पढ़ाता हूँ या डिस्कस करता हूँ, मैं उन्हें ये बताता हूँ कि ये कितना अजीम पेशा है और इसको हमने किस तरह वी हैव टू मेक इट अगेन रिस्पेक्टफुल. जिस तरह से आजकल हालात जा रहे हैं, लड़ाई झगड़ा और जो हॉस्पिटल्स के अंदर जो होता है और जिस तरह के इश्यूज हैं, वी नीड मोर गवर्नेंस, मोर स्टीवर्डशिप एंड मोर ट्रेनिंग इन हॉस्पिटल मैनेजमेंट. सो ये दुआ भी है और अनफॉर्चुनेटली अगर आप गलत काम करें तो बदवाएं भी इसी तरह से मिलती हैं. ये भी ध्यान में रखें कि आप अगर गलत करेंगे हॉस्पिटल्स में तो हमारे यहाँ पे दोनों चीजें हैं, लेकिन चांस बहुत है अच्छा काम करके खिदमत खल्क करने का, लोगों को खुश करने का और अल्लाह से सवाब हासिल करने का. हॉस्पिटल से निकला है, आपने सुना होगा हॉस्पिटैलिटी. I think so. Hospitality is like, you know, a thing which is a profession for hoteling business. Hospitality, hospitable. You must have listened. Hospitable, who is very, very good in taking care of guests. So, hospital word comes from the word hospitum, a place where guests are received. So, in old ages, in historic era, Romans, Greeks, whenever there was somebody who needed a special attention, who was not being able to be treated at home, they designed a place where the physician will come, where some of his students and others, they will come to learn the art of medicine, and there will be a teacher, there will be some interns, there will be volunteers coming from the community, and most of the time the person will be inside that hospitum, that place, and he will be or she will be taken care of. So this is how the old hospital concept emerged. And since then, it has transformed into something which is very advanced and very technology driven. So now if you want to define a hospital, we have to have certain principles, certain components which you can define that this is a hospital. So not every health facility in public health, we say, not every health facility is called a hospital. For being called as a hospital, you have to have a component of preventive care, diagnostics, treatment, of course, contacts with your physicians, referral linkages, GPs, and ultimately the training of physicians. So in broader sense, when you have an indoor, when you have an OPD, when you have a diagnostic facility, these three components, plus you have trainings going on for healthcare providers, not just doctors. If it is a nursing school or a paramedic school, it still qualifies it as a training. Postgraduate, undergraduate training is there. Usually we call in Pakistan, we call any hospital which is attached with a medical college as a tertiary care hospital. But it doesn't necessarily mean that any hospital which is not linked with a medical college cannot be called as a tertiary care hospital. Tertiary care facility is usually a center of excellence, even for a cardiology or urology or anything else, a highest level facility for a problem. So if you have an OPD, if you have an indoor, if you have a diagnostic, and you have a training facility available inside the hospital, and you serve as a higher level facility for the lower level facilities. So in Pakistan, if you are linked with BHU, RSC, THQ, DHQs, and people are coming from the low level facilities to you, so you serve as a referral facility. So you provide indoor services, you provide outdoor services, you do a lot of diagnostics, but you serve as a referral facility for low level health facilities and also training of the physicians or nurses. Then we call it as a hospital. What has happened recently? What has happened now? The more we call it a modern or a 21st century hospital. We have gone into something which was a mix of preventive, curative, and rehabilitative services. Now we are more linked with curative services. So all the center of excellences in Pakistan or in other developing countries, they are serving as a curative arm. They just only worry about just controlling the condition of the patient, treating him or her, and then sending him back. So the concept of whole hospitality or a hospitum where you take care of a person as a whole, as an individual, is missing. That is a big dilemma. And there are people in the world, there are hospitals in the world who are going back to the basic, where they want a concept of health promoting hospitals, or hospitals who actually deal with something which even takes care of the patient when he or she is gone back to the community. So in Pakistan, if you send someone back to the home, his connection with the hospital is gone. So usually the hospital and the physician and the surgeon, he or she is interested in just treating the condition at the time, symptomatic treatment. Usually we are focusing on relieving the pain, relieving the fever, doing the surgery, and then when the person is out of general anesthesia, the surgeon says, I am done. This is not my job anymore. So take care of him in the ward. When the patient is discharged from the hospital doesn't even bother about that person. So that is a big dilemma of a modern hospital, and there is no single solution for that. All of you must think how we can connect public health into this more curative aspect of hospitals, and how we can create a follow-up mechanism or a life cycle approach where we, even before getting sick, we can utilize the very knowledgeable physicians over there to stay more healthy, to enhance the level of health, because the physicians are the most literate ones among all the medical providers. How inside the hospital we can take care, we can provide, we call it individualistic care. So you can't treat all the diabetics with just one prescription. If every person has a different threshold of disease, the sickness level is different, the illness he or she is feeling. Some people at a sugar level of 400, they don't have any symptoms. They say we are okay. And for some people, if the blood sugar is above 200, they feel so anxious that they start crying that this is something which will kill me. So how to create this impact of just the cure and the physician running after biomedical tests, investigations, and reports, and not the individual, we should all be thinking. And I think there are many new interventions globally. I'll just name one, and I'll request all of you, and I'll share it with the group as well as an email. I'll give it to Tariq. There is a concept which is known as health promoting hospitals. So what they do is, when the patient is coming to them, they counsel him or her that after you have done something which caused this, of course, but you are not to be blamed. We will take care of you, but when you go back, you do these things. So you take control of your own health, gain control of your own health, although it's very difficult, but still you can do something. Then they call the family, and the family is convinced, and the family is briefed about what can be done about that patient. What happens in Pakistan, the family is there to disturb the health provider and also to disturb the patient. वो जो कहते हैं ना कि यार एक ही हो गया है, तो फलाने ਨੂੰ ਹੋਇਆ ਸੀ, ਉਹ ਤੇ ਮਰ ਗਿਆ ਸੀ. They give bad news to the patient, and they usually irritate the hospital staff, and they make a nuisance out of it. The West has changed the scenario. They invite them, and there is a council room, there is a meeting room where they tell everybody that look, he was smoking, he had this problem, he was overeating, he was not doing physical activity, now he has a heart disease. What he can live with it. There is a very, very advanced level of care. We have stents, we have bypass, we will do it, but rest of you should make sure that you don't get it. So the health promoting hospital is where they use hospital as a sort of a central point to promote health of all those relatives or friends whose patients are in there. अब आप सोचें, मैं उर्दू में कुछ बातें जान के इस तरह से करूंगा कि वो जब अपनी बुराई करनी हो तो उर्दू में बोले, जब अपनी कोई घर की बात करनी हो तो हम उर्दू में बोलेंगे. ऑनलाइन बहुत सारे हमारे इंटरनेशनल ऑडियंस भी हैं. हमारे यहाँ पे you know what happens. There is a sort of a problem कि when somebody gets sick, उसके खानदान में ही 150 डॉक्टर पैदा हो जाता है कि यार तू है कर ले, खा ले, छोड़, फलाने को ना जा, फलाने को ना जा. We do health shopping. We don't go to hospitals. We do shopping at various places. इसको कहते हैं health shopping. ये बाबर शेख हमारा colleague था HSA में, उसने एक article भी लिखा है. He wrote an article that why Pakistanis do shopping in health. So I go to a GP or I go to a hospital. मुझे उसको hospital का emergency पसंद नहीं आई, मैं किसी और hospital में चला जाऊँगा. I'll go to the next hospital. मुझे डॉक्टर की शक्ल पसंद नहीं आई, यार ये बंदा ठीक नहीं, यानी वो गल सही तरह नहीं की थी. दूसरे के पास चला गया, तीसरे के पास चला गया. Because there is no system, there is no referral system, there is no eligibility. कि मेरा GP है एक, I can only go to him. Like in the West, you have an allocated GP. You go there and the GP will send you to the hospital. Relevant GP जो है relevant specialty में भेजेगा. यहाँ पे we do shopping. पसंद ना आया सरकारी मुलाजम, सरकारी अस्पताल. In the evening we will go to the private clinics. So what will happen then? This curative thing will kill us all because we will be trying one medicine in the morning, another medicine in the evening, and another medicine in the night. And on the next day, we will be talking about that the system is pathetic in this country and we can't do this and we can't do that. हम ये health shopping करके we create a lot of problem. So the hospitals in Pakistan, some of them have tried and they are now trying to become this concept of taking this concept of health promoting hospital. You know, when insurance comes, when the insurance company comes, they make sure that system is more efficient. The system is cost effective. With this health solo program and Prime Minister health program, which was launched in 2013 and 14, with this insurance thing coming here, with this social protection things coming up, the insurance company will definitely be working with public health professionals to reduce not only the cost, but also the incidence of disease. So this health promoting hospital has a very bright future in Pakistan, where this curative aspect of the hospital will be changed a little bit into, and you heard what one of the participant asked with James Blanchard. Rouge, I think she asked a question about food sciences and how nutritionists can help in the hospital. So if you have a very good diet consultant in the hospital, then you have a better chance that the patient will go back and they will have some better diet, and hopefully the diabetes and heart disease and others will get more control. So the biggest dilemma which we have nowadays in hospitals is that we are only doing this fire brigade action. We are not doing anything for the subsequent visits of that same patient. We are just treating the episode, that attack which has happened, and we are not preventing the next one. That is a big problem. Center of specialized care. Now, this is another dilemma. You know, the whole world, आप में से जितने भी मेरी एज के हैं, 50+ हैं, थोड़े ही हैं वैसे सारे यहाँ पे यंग बैठे हुए हैं, जो होंगे भी वो नहीं मानेंगे कि हम 50 के हो गए. तो जो 50+ हैं उनको ये याद होगा कि एक जमाने में there was a separate mutton meat market, there was a separate chicken market, there was a vegetable market, there was a grocery shop. So there was a separate shops for everything. And if you remember, you will not get meat or mutton from the same shop or chicken from the same shop. So there were different shops and the markets were whole. The puri ki puri gosht ki market hai, chicken ki market hai, sabji ki or grocery ki. Now you see super malls. You see malls where everything is available under one roof. And you see that you can buy a car or motorcycle and you can buy eggs and you can buy different kind of groceries. Chawal bhi lenge, aata bhi lenge, you get everything. So what is happening? The world has transformed itself into disintegrated into an integrated model where you don't have to travel much. What we have done in health, we have disintegrated hospital into multiple small units, which each of them operating separately, distinctly. So this principle of integration and harmony and unity has spoiled the whole comfort level of the patient. मैं आपको मुख्तलिफ hospitals के आप example ले लें. You can take the examples of Center of Excellences in Pakistan. You go to an MCH center, they will send you to some other and then some other. So if there is a heart patient and he or she gets a urinary problem, they will send the call to urology. So there is another Center of Excellence in the name of urology. वो कहेंगे इसको इधर भेजो. The heart patient उधर जाएगा सिर्फ कैथीटर डलवाने के लिए, ठीक है ना, सिर्फ कैथीटर इन आउट करने के लिए, उसका ब्लॉकेज खत्म करने के लिए the heart patient will go there, or they will send a team to your. इतना भी नहीं है कि कार्डियोलॉजी सेंटर के अंदर या यूरोलॉजी सेंटर में किसी को चेस्ट पेन हुआ, कुछ मसला हुआ, कॉल भेजेंगे FIC में, हालांकि उन्हें पता है कि एंजीसाइड देनी है, एसोडिल लगानी है, ट्रीटमेंट देना है. They will not do it because they are specialized care for kidney or specialized care for liver or specialized care for surgery or burn or anything. So what we have done, in the name of specialized care, we have disintegrated the whole hospital into small, micro, unitary places. And the patients, they usually don't have the only one problem. Above 50, above 60, you will find that people may have multiple problems. For each of that problem, and even for each of the symptom of the same disease, they have to go to some other shop. And that shop is maybe across the building, or maybe 500 meters away in the same hospital. So the specialization and then super specialization, you can see there was a gastroenterologist, now there is an hepatologist, now there is an endocrinologist, and there are so many super specialties coming up. What we are doing is we are creating solitary confinements of the patients. There is no universal care, there is no hospital, there is no proper creation of a place where most of the needs are met under one roof. We are within under one roof, we have separate departments. So that transformation is not only, it has not only increased the cost of doing business, because every center of excellence, every specialized center will say, I will have my own lab. So cardiology वाले कहेंगे जी हमारी cardiology unit के अंदर अपनी lab होनी चाहिए. Urology वाले कहेंगे हमारी भी अपनी lab होनी चाहिए. Pediatrics वाले कहेंगे and ICU वाले कहेंगे. So everybody will have their own diagnostic, their own some test हमने खुद करने हैं. What will happen then? The cost of doing investigations will multiply. The HR will multiply. So everybody will have an administrative structure. So if you have a center of excellence of urology or heart disease or any other specialty, what will happen then? You will have an administrative structure as well. So there is a clinical and there is an administrative structure. You can't have all such with such little money. So that super specialization has disintegrated health into something, or sorry, the hospital into something which has become a problem for every patient. So patient goes there with a problem. We diagnose him with some other problem and we send him away. तो पहले वो वाला करवा लो. गया मैं एक मसले के लिए था, वहां पे I get another problem because test में निकल आया, यार ये पहले चेक करवा के आओ, इसको पहले डील करो. जो मेरा प्रॉब्लम है जिससे मैं तंग हूं उसको नहीं ठीक करना, जो उन्होंने निकाला है पहले उसको ठीक करना है, और वो patient will be lost. So the patient, they move in circles inside the hospital, and if you go to the one of the best hospitals in Pakistan, tertiary care hospital, you will find people running between departments. Just next time when you go, or just take an observation, you will find people बैग पकड़ा हुआ होगा हाथ में, यूरिनरी बैग होगा, या ऑक्सीजन का मास्क लगा होगा, छोटा सिलेंडर साथ होगा, या व्हील चेयर पे जा रहा होगा. Just imagine these things. It wasn't the case maybe 20 years ago. What we have done is the medical technology and the technology invasion and the super specialization created by our own leaders. एक जमाना था जनरल सर्जन used to do a lot of surgeries. अभी सवाल ही पैदा नहीं होता कि वो कोई जनरल सर्जन हो. There is no general physician or a general surgeon nowadays. हर किसी की कुछ स्पेशलिटी है और वो ओवरऑल पेशेंट को नहीं देखता. सो बहुत बड़ा इशू. क्यूरेटिव के बाद नेक्स्ट बिग थिंग कमिंग अप एज अ कर्स ऑन द सिस्टम, कॉस्ट के ऊपर, एफिशिएंसी के ऊपर, क्वालिटी के ऊपर, और पेशेंट का तो बेड़ा ही गर्क है. पेशेंट तो दरवाजे से दूसरे दरवाजे, वो कहते हैं ना एक से दूसरे दरवाजे पे धक्के खा रहा होता है. और वो क्या करता है, एक जगह उसकी बारी आती है, वहां पे उसको वो लिख के देते हैं, वो दूसरी जगह पे जाके सबसे लास्ट में होता है. So he came first, but because he had something else, he is sent to some other OPD or some other place. He is the last one over there, and there is a queue of 100 people in front of him. So what will he do? He will pay 500 rupees or 1000 rupees in the evening, and वो किसी एक GP से या किसी से वो टोटका करवा लेगा, और उसकी जो डिजीज है, वो जितनी डिजीज थी वो सारी की सारी एडवांस हो जाएंगी. So this transformation of a modern hospital into super specialties just is supply driven. It is not demand driven. ये हमने डॉक्टर्स ने खुद क्रिएट किए. पेशेंट ने नहीं कहा था कि मेरे लिए अलग से एक होना चाहिए, राइट किडनी का और लेफ्ट किडनी का अलग होना चाहिए. अब तो शायद ये भी लेवल आ गया कि राइट किडनी का स्पेशल अलग होगा, लेफ्ट का अलग होगा. यार मुझे राइट से नहीं, मैं लेफ्ट वाला अच्छा काम करता हूँ, तो वो फलाना जो है वो राइट किडनी अच्छी करता है. लिवर का अलग होगा, स्प्लीन का अलग होगा. इट इज समथिंग विच इज कमिंग अप, ब्लड का. सो देयर आर सो मेनी स्पेशलाइजेशन. एक मार्केट बनी हुई है जिसकी वजह से हॉस्पिटल में, अच्छा वो कमरे भी अलग मांगते हैं. मैं एक हॉस्पिटल में एमएस था, तो वो जब सुपर स्पेशलिस्ट बना कोई बंदा उसी डिपार्टमेंट के अंदर ही, वो कहता जी मुझे अलग कमरा दें, मैं ओपीडी भी अलग करूंगा, सारा भी अलग. एक कॉस्ट ऑफ बिजनेस बढ़ गई ना. उसके 4 मरीज आएंगे दिन में, ही नीड्स अ सेपरेट रूम. इसी तरह पीडियाट्रिक्स में आप देख लें कितनी स्पेशलिटीज हैं, मेडिसिन में देख लें, गायनी में देख लें. सो यू हैव स्पॉइल्ड द होल कॉन्सेप्ट ऑफ, और दुनिया उलट जा रही है, हेल्थ वाले उलट जा रहे हैं. So what is happening? The whole world is coming under one roof where you can buy a chicken and an egg and a Toyota एंड होंडा CD70 उधर से आप ले सकते हैं, लेकिन आप हेल्थ में जब जाते हैं तो आपको हर बीमारी के लिए एक अलग दरवाजा खटकाना पड़ता है और हर जगह पे अलग, वो टेस्ट भी अपना करवाएंगे. दैट इज अ बिग डायलेमा ऑफ अ मॉडर्न हॉस्पिटल. बेसिकली ये सर्विसेज होती हैं, लेकिन हमारा जो एक चीज मिसिंग है जिस पे आज मैंने बात करनी है, मेरा ये प्रीएम्बल इसीलिए था, कंड्यूसिव इन्वायरमेंट की बात करनी है. दैट इज व्हाट इज द मोस्ट इंपॉर्टेंट, द बिगेस्ट, आई थिंक the best principle of hospital management is you provide a conducive environment to the provider and the patient. वो क्या है उस पे हम बात करेंगे, and then we can have discussions overall. We can have question answers as well. थोड़ा सा आप ये देखें कि एक हॉस्पिटल है हमारा जिसको लोग कहते हैं कि दुआएं देते हैं बुजुर्ग के, अल्लाह तेनू थाने कचहरी ते अस्पताल को लोग बचावे. आप सब सुनते हैं, ये बदवा है अस्पताल में होना. क्योंकि जो होता है हॉस्पिटल में वो आपने भी देखा है, मैंने भी देखा है, कभी आप दाखिल रहे हो, आप में से जो लोग कभी दाखिल हुए होंगे, अल्लाह ना करे कोई बीमार हो, लेकिन अगर हो जाए तो जो उसके साथ होता है वो वही जानता है, और जो थाने कचहरी में होता है हमारे साथ वो भी जानते हैं. तो ये एक ऐसा इन्वायरमेंट बन गई है कि जिसको हमें हॉस्पिटल क्यों चाहिए था, हीलिंग इन्वायरमेंट. व्हाई वी वांटेड हॉस्पिटल, बिकॉज वी वांटेड टू गिव समबडी सच अ केयर कि वो VIP फील करे. वो घर में ठीक नहीं हो सकता. If he or she is not able to get relief at home, he should be sent to a place where uska itna, he is taken care of so much in much better way that he himself starts having something which is known as a willpower to survive. So what is a healing environment? I'll take few moments on that, and if you can recall your experiences in the hospitals, you can understand what healing environment is. Healing environment is something which actually is when the patient feels that this environment will actually heal me or cure me. So that is a perception of the patient. So all of you must understand that somebody gets an emergency, he's on the road, what his or her biggest or maybe the most important aim is to reach a hospital. हम सबको इमरजेंसी जब होती है हम क्या करते हैं, हम कहते हैं किसी तरह अस्पताल पहुंचा दें. जब अस्पताल पहुंच जाएंगे तो रिलैक्स हो जाता है बंदा. So everyone who has an emergency or who is sick, who is having pain, who is having fever or any other symptoms, chest pain or even an injury or bleeding, the person tries to reach to a hospital. Why? Because he thinks I will get healing in that place. So जब सबसे ज्यादा स्पीड पे जा रहे होते हैं, सिग्नल तोड़ते हैं, and they do a lot of things and बड़ा कुछ करते कराते they reach the hospital. What happens when you reach the hospital? Is it a healing environment? So the principle of hospital management says when you enter into the gate of a hospital, the person should feel relaxed. That thanks Allah, I am inside this hospital. Now I will be safe. So ये किसने create करना है? This notion of healing environment, who is to be blamed for not creating such thing and who is to be requested to create a healing environment? The hospital manager. It is the hospital manager, it is the health manager whose responsibility is कि जब गेट के ऊपर एंट्री हो, एंट्री के अंदर ही उसको ऐसे रिसीव किया जाए पेशेंट को. The system should be like this, that the patient who was expecting healing after reaching the hospital should start actually feeling that healing as well. हमारे यहाँ क्या होता है, गेट 4 होते हैं हॉस्पिटल के, 3 पे ताला लगा होता है सिक्योरिटी के नाम पे, उसी पे एंट्री है, उसी पे एग्जिट है. So all of you must understand that there should be a separate gates for entry and exit. There should be a separate gate for emergency. Principle of healing environment ये है कि एंट्री इतनी इजी हो कि जब हॉस्पिटल तक पहुंचे, हम यहाँ पे हॉस्पिटल के गेट पे आधा घंटा इंतजार कर लेते हैं, पर्ची कटाते हैं, टोकन लग रहा होता है, पार्किंग में गाड़ियां खड़ी होती हैं, इमरजेंसी तक पहुंचता ही नहीं बंदा. आप सोचें अपने अपने सरकारी अस्पतालों को, बड़े अस्पतालों के बारे में. जस्ट थिंक ऑफ अ हॉस्पिटल, इवन मैं नाम नहीं लेना चाह रहा किसी भी हॉस्पिटल का, ये लाइव भी जा रहा है, रिकॉर्ड भी हो रहा है, वो सारे मेरे दुश्मन बन जाएंगे. तो अगर आप पाकिस्तान के किसी बड़े हॉस्पिटल का नाम ले लें, उसकी एंट्री गेट पे क्या हालात हैं अभी आप जाके देख लेना. So what is happening? A person is thinking that he or she will get healing the moment he enters into a building. और बड़ा अच्छा उन्होंने built environment का सवाल किया. This and no one takes care of this in Pakistan. I think you are more hard won than me because we don't think that built environment of a hospital is so important. So entry बिल्कुल स्मूथ एंट्री होनी चाहिए. पहुंचे, ओपीडी है, उसकी एंट्री फर्क हो. देयर शुड बी अ सेपरेट एंट्री फॉर ओपीडी, देयर शुड बी अ सेपरेट एंट्री फॉर इमरजेंसी. डेड बॉडी कैरियर और डेड बॉडीज भी उसी से आ रही हैं, आप भी उसी से आ रहे हैं और बंदे अंदर भी आ रहे हैं. वो जो अंदर जा रहा है साथ डेड बॉडी बाहर आ रही है, उसकी हीलिंग एनवायरनमेंट किधर गई? What will he or she think? एक डेड बॉडी को देखते हुए हॉस्पिटल से बाहर निकलते हुए, हीलिंग एनवायरनमेंट तो गई हवा में, हो गएगा यार ये तो इस अस्पताल में आया था तो ये तो मर गया, तो मैं तो चेस्ट पेन है, मुझे तो पता नहीं क्या होगा. एंड वी आर यू नो एज ए नेशन वी आर पेसिमिस्ट, हर वक्त रोते रहते हैं, डिप्रेशन में रहते हैं. वो कहेगा यार ये तो बड़ा गलत जगह पे मैं आ गया हूँ. सो जो हीलिंग एनवायरनमेंट का कॉन्सेप्ट है, इसको जो मेरे डॉक्टर भाई हैं, दोस्त हैं, they can understand that there is something which we call it as hormones, जिनमें एंडोर्फिन्स होते हैं, सेरोटोनिन है, डोपामीन है, बहुत सारी हमारे ऐसे हार्मोन्स हैं, ऑक्सीटोसिन है, which create something which is to be considered as a willpower and a healing in by the body itself. हम विल पावर से जो ठीक होते हैं, वो क्या है, उसमें साइंस है. उसमें साइंस ये है कि वो केमिकल एक्चुअली दे डू a lot of reaction in the body and they create a fight inside the body and they attack the cells which are damaging the organs and they cure you from inside. ये दुआ का जो असर है, ये इंटरनेशनली प्रूवन है. सूरह यासीन का, दुआ का, किस तरह से विल पावर बढ़ती है ना इंसान की, और वो विल पावर बढ़ती है तो देयर इज अ एंडोक्राइनोलॉजी, देयर इज अ सॉर्ट ऑफ न्यूरोकेमिस्ट्री. द हार्मोन्स आर रिलीज्ड, they fight and they kill that disease cells and they actually recover you. So there is a very strong science and evidence available that increasing the willpower actually heals you. वो विल पावर कैसी होगी, चाहे वो किसी दरगाह पे जाके दुआ मांगने से आए, कोई चीज बांधने से आए, यहाँ पे विल पावर है ना, यकीन की बात है, सिजदे करने से आए, सूरह यासीन पढ़ने से आए, या किसी बंदे की, किसी डॉक्टर की थपकी से आए कि यार तू ऐसी परेशान है तो बिल्कुल ठीक हो जाएगा, डोंट वरी, यू आर इन सेफ हैंड्स नाउ. आजकल कोई कहता है हमारे सरकारी हॉस्पिटल में ऐसे एमरजेंसी में आप जाते हैं, कहते हैं पहले कितने मरे, सो जो मरण लगे कितने ले आयो, जो तो मरण लगे तो इतने ले आयो इसनू. वो बंदा खुद उठ के खड़ा होता है, यार मैं मरने लगा हूं. मतलब इज इट ट्रू? आई नेवर एक्सपेक्टेड आई हैड सच इमरजेंसी. दिस इज द वेरी कॉमन फ्रेज ऑफ आवर डॉक्टर्स इन इमरजेंसी. Where were you say few days ago, or अब क्यों आयो? और बाबा जी के बारे में या बुजुर्ग के बारे में, गायनी में हमारी खवातीन जो गायनी में काम करती हैं, दाइयों के पास जाती हो, जब मरने वाली होती हो तो हमारे पास आ जाती हो. This is a very common phrase by. So healing environment vanishes the moment you listen this word, listen to this word के आप तो तुम बिल्कुल एंड पे आ गए हो. डॉक्टर कैसे खुदा हो सकता है? आप कैसे कह सकते हैं ये मर जाएगा? नहीं कह सकते आप. How can you say भाई अब उनके बस कुछ नहीं हो सकता, आप इसने मर जाना है, उन्हें बचना. This is what usually doctors say. वो माइंड बना रहे होते हैं कि ये अगर मर गया हमारे हाथ, तो मारना उन्होंने नहीं होता है, तो वो कहते हैं कि किसी तरह हमसे गलती हो गई तो ये ना हो कि ये हमारे मत्थे लग जाए, because they know ये उन्होंने क्या करना है इसके साथ. There is a very big dilemma that this healing environment vanishes when you see your entry gate and there is a blockage over there. You cannot get into the hospital although you are there, but you are not there. So you have to be inside emergency, and within emergency, even if you reach within emergency, just go and see. I have most of my MSPA students have done assessments of quality of care in OPD, quality of care in indoor, quality of care in emergency. One of the most common finding in Pakistan was the emergency people don't come to them. They have to go and seek कि यार कौन है emergency वाला बंदा, इधर कौन डॉक्टर कौन है, नर्स कौन है, ओवरऑल नहीं पहने हुए, यूनिफॉर्म नहीं पहना हुआ, ढूंढ रहे होते हैं कि किससे मिलना है. इमरजेंसी आई है, वो जी मेरी माँ आई है, मेरा बाप आया, प्लीज. प्राइवेट में आपने देखा होगा, प्राइवेट में वो खड़े होते हैं रिसेप्शन के ऊपर, वो व्हील चेयर भी लेके आते हैं, दे ब्रिंग इन द स्ट्रेचर, दे ब्रिंग इन व्हील चेयर एंड दे जस्ट कैप्चर एवरीथिंग एंड दे टेल यू टू रिलैक्स एंड दे. सो दिस इज अ डिफरेंस. व्हाई कांट दिस बी डन इन अ पब्लिक सेक्टर? It can be done everywhere, but we don't have trained managers who understand this concept of healing environment. It's not just the injections and the tablets and IVs which cure the person. It is the perception and the willpower which actually heals the person from inside. So what happens is when you go there, so within this healing environment, remember one very important rule which I always emphasize, and whenever I go even to the bureaucracy or SMC hoti hai unki MCMC mid career management course hai, senior management course hai, I go there and I talk to them and I tell them, please train the person who is the first responder. First responder is the most important person in any service area. सर्विसेज की बात करें ना, टेलीफोन है या बिजली है या थाना है या कचहरी है, जो भी है, the first point of contact is always the most important person. हॉस्पिटल में कौन है फर्स्ट पॉइंट ऑफ कांटेक्ट? पीएन होगा, सिक्योरिटी गार्ड होगा बाहर दरवाजे पे. इमरजेंसी में आएंगे तो कौन होगा? डिस्पेंसर, टेक्नीशियन और नर्स. हमने कभी उसे ट्रेन ही नहीं किया, वी नेवर ट्रेन्ड हिम. डॉक्टर बदनाम होगा, मार डॉक्टर खाएगा. तंग किसने किया होगा? ख्वार किसने किया होगा पेशेंट अटेंडेंस को? उस फर्स्ट रिस्पॉन्डर ने। सो द फर्स्ट पॉइंट ऑफ कॉन्टैक्ट इज अ वेरी इंपॉर्टेंट प्रिंसिपल्स ऑफ मैनेजमेंट, दैट द फर्स्ट हॉस्पिटल मैनेजमेंट, द फर्स्ट पॉइंट ऑफ कॉन्टैक्ट इन द हॉस्पिटल शुड बी द मोस्ट ट्रेन्ड वन। चाहे वो नर्स है, चाहे वो पैरामेडिक है, चाहे वो जो भी है, इमरजेंसी में जिसने पेशेंट को जाके, या रिसेप्शनिस्ट है इमरजेंसी के रिसेप्शन पे जो बंदा बैठा है, दैट इज द मोस्ट इंपोर्टेंट पर्सन। क्यों? उसने जो कह दिया ना, वो जब तक वो बंदा ठीक नहीं होता या खुदा ना खासा डेथ हो जाती है, वो याद रखेंगे कि उसने तो ये कहा था। तो उसकी ट्रेनिंग बड़ी जरूरी है। सो व्हाट वी नीड टू अंडरस्टैंड इज in order to create a healing environment, the first point of contact inside the hospital must be the most gentle one, the most polite one, and the most humble one, and he should be taught how to talk nicely. जैसी शक्लें आपको नजर आती हैं सरकारी अस्पतालों में, कैन यू इमेजिन कि अच्छा खासा बंदा जाके उनको जब देखे तो कहना यार की ये तुसी अगे जेड़े जगह जिथे मिल रही है पै जाओ लंबे, तुसी भी अगे ढेर लगा हुआ है, अंदर इमरजेंसी में जगह नहीं होती है, दे डोंट टेल यू वेयर टू गो, किसी भी बेड पे लेट दे। मेरे अपने एक्सपीरियंसेस हैं, मैं शेयर करना शुरू करूं तो शाम हो जाएगी हॉस्पिटल्स में एज ए पेशेंट अपने रिलेटिव या अपने लोगों के साथ, और वो ऑब्जर्वेशंस देख के मुझे लगता है इट्स अ कल्चर नाउ, इट्स अ नॉर्म। We don't talk nicely to the patients. We don't welcome them. We in fact feel threatened कि यार ये किधर से आ गया, यार एक और अजाब आ गया, पहले वो ढेर लगा हुआ अंदर, एक और आ गया नवा, आलू आ गया, या जो भी नाम रखे होते हैं हमने, नवा पोटैटो केस आ गया, फलाना केस आ गया, अजीब अजीब से आपस में कन्वर्सेशन करते हैं, और वो इतने फेमस नाम है कि वो बाकी सबको ही पता होते हैं। So healing environment starts when you have a very good reception at the gate, and then you reach into the emergency, and when someone talks to you very nicely. मैं आपको अपना एक एक्सपीरियंस दूं। मेरी एक्सीडेंट हुआ बड़ा सीवियर, आई वाज इन कोमा फॉर 4 days, मेरी आंख खुली तो आई हैड एमनीसिया, मुझे आई डोंट रिमेंबर कि मैं कहाँ पे हूँ। मैंने राइट साइड पे देखा तो शीशा था, और शीशे के बाहर ना पूरा मुझे लश ग्रीन दरख्त नजर आए दूर दूर तक, बिल्कुल ग्रीन बेल्ट पूरी। तो जो पहला ख्याल मेरे जहन में आया, आई फॉरगॉट व्हाट आई एम एंड हु आई एम। जब वहां देख के ख्याल आया, मैंने कहा शुक्र है यार दोजख नहीं है, दिस इज नॉट हेल, यू कांट हैव ग्रीन ट्रीज इन हेल। सो ये मेरा रिलैक्सेशन थी, मैं ऐसे हुआ। फिर मैंने अपने आप को देखा, एंड आई डोंट रिमेंबर हु आई एम एक्चुअली, हु आई एम एंड मैं यहाँ पे क्यों हूँ, क्या हुआ, आई फॉरगॉट एवरीथिंग। देखा इधर साइड पे तो नजर आ रहा है, खूबसूरत लाइटें नजर आ रही हैं, बड़े एम्बियंस है, बड़ा प्यारा, एक आईसीयू था सीरियस किस्म का। इतने में एक सफेद कपड़ों में, हुरें भी सफेद कपड़ों में होती हैं, लेकिन वो भी एक सफेद कपड़ों में आई। उसने मेरी जिस टांग पे प्लास्टर चढ़ा हुआ था और मेरे मुंह पे बैंडेजेस लगी हुई थी और हेड इंजरी भी थी, जिस जोर से मुझे ऐसे करके लाया, होश आ गया आपको? तो मैंने कहा जन्नत भी नहीं है मैंने कहा दिस इज नॉट हेवन इवन। सो मुझे फिर होश आ गया, एंड देन आई फेल इन कोमा अगेन। उसके बाद जब मैं दोबारा आया तो मैंने ये सवाल दोबारा पूछे थे। बात ये है कि अगर इफ यू हैव अ गुड मेमोरी एज एन पेशेंट, if your first interaction is like good, you feel comfortable, your willpower improves, and built environment actually makes it much more better. So the first point of contact in case of emergency, or in case of OPD, or in case of health seeking behavior is the most important one. So you have to train your first responder. अगर नहीं train कर सकते, उनको first response से हटा दें. Remove the people who are blunt, who are not good. And actually they have to be multilinguistic as well. अब शिफा की मिसाल देख लें, उन्होंने पश्तो, फारसी, दरी, पंजाबी स्पीकिंग बंदे रखे हुए रिसेप्शन पे, इमरजेंसी में भी, ओपीडी में भी। they can talk in any language. The patient feels so healing environment उनकी बन जाती है ना। वो जो बिल आता है तो हीलिंग खत्म होती है वैसे, लेकिन उससे पहले बिल आने तक हीलिंग ही होती है उनकी। तो सरकार में we can do that because we have multilinguistic people in the hospitals. They can speak Pashto, they can speak, so we can train them. So the first level of contact is the most important person. Why? Because this is something which is which in emergency will relieve them or grieve them. So आपने अगर किसी को relief देना है या किसी को grief देना है, वो जो पहला contact है, that will be the most important person. Then you get in mission and there are investigations and all these kind of things. Just remember, as a healing environment, बिल्ट एनवायरनमेंट हो गई, आपका एंट्री कैसे हुई, व्हाट इज द इंटीरियर, बाहर कोई दरख्त नजर आ रहा है कि नहीं। हमारे अक्सर अस्पताल जो हैं, एंड आई अगेन सेइंग इन उर्दू, ऋषि साहब को पता है अपनी बुराई उर्दू में करनी चाहिए, गोरों को तो नहीं बताना हम इतने बुरे हैं। ये जो हमारे कई सरकारी अस्पताल हैं, टर्शरी केयर, उनके साथ ही कब्रिस्तान है। बंदे की आंख खुलती है, बात पूरी कब्रें नजर आ रही होती हैं साइड पे, वो वो कहता है यार ये मतलब यहाँ पे करीब मुझे इसलिए लाया गया है कि यहाँ से मैंने वहां जाना है, हीलिंग एनवायरनमेंट कहाँ गई? A lot of health facilities in Pakistan are in the vicinity of a graveyard. BHU, RSC, TSP को छोड़ के बड़े बड़े हॉस्पिटल के साथ भी ग्रेवयार्ड नजर आते हैं वहां से। क्यों? क्योंकि शहर से बाहर बनाया हमने अस्पताल, और कब्रिस्तान भी बाहर होता है। सो पेशेंट की जो साइकी है, जस्ट इमेजिन कि अच्छा खासा ठीक पेशेंट, वो उसको कितना प्रॉब्लम बनेगा। एंड इट इज प्रूवन, क्लिनिकली प्रूवन दैट द परसेप्शन, द विल पावर, it affects healing. Definitely it affects healing. It can kill you and it can save you, the anxiety and tension which creates. So when you are inside the indoor inpatient department, then what is the principle of making you, so first point का contact हो गया, the first point आपका आया, उसने अच्छी तरह से आपको देख लिया, admit हो गए आप through emergency, through OPD, you are inpatient. What about, and hospital is all about inpatient. Remember, hospital is all about inpatient. It's not about OPD. In fact, globally, the best hospitals, the best tertiary care facilities, they don't have any OPD. They don't have any OPD because OPD का काम ही नहीं है tertiary care में. OPD का तो काम है GP के पास या first level या second level के पास. Why would a tertiary care facility will have an OPD? Walk-in facility होगी, क्यों? There will be filter clinics. The referred cases will be filtered by those कि यार इन्हों रखना है या वापस भेजना है. So filter clinic का concept होता है for referred cases. It cannot never be a OPD. ये आपने, whoever has a history sort of interest, just check कि PIMS hospital when it was made, there was no OPD block in PIMS hospital. जब लग साहब ने इफ्ताह किया, उसका घूमते रहे, चक्कर लगाया, उन्होंने कहा यार OPD किधर है? उन्होंने कहा सर, जापानी हैरान हो गए कि यार ये जापानीज ने बनाया, जायका ने बनाया था ना। उन्होंने कहा OPD का क्या मतलब? Why OPD? GP हमारी यहाँ डिस्पेंसरीज थी इस्लामाबाद में बहुत सारी। So they said कि यार ये tertiary care facility है, इंडोर की फैसिलिटी है, डायग्नोस्टिक्स है, स्टेट ऑफ द आर्ट फैसिलिटी है, ओपीडी क्या करनी है यहाँ पे? वो बड़ा गुस्से हुआ, वापस गया एंड दोबारा PC1 बन के लदा ओपीडी बनी थी, ओपीडी ब्लॉक लदा बना था। सो ये एक चीज ध्यान में रखें कि ओपीडी भी अपनी जगह है, इंडोर भी है, बट हॉस्पिटल्स आर फेमस फॉर गेस्ट्स हु आर एडमिटेड इनसाइड। सो हॉस्पिटल की सबसे बेस्ट सर्विसेज क्या होनी चाहिए? IPD, डेफिनेटली प्रोसीजर्स, OT, ICU, क्रिटिकल केयर, ये सब इसी में आ जाएगा। तो इंडोर सर्विसेज में इमेजिन अनदर प्रिंसिपल, मैंने पहला कहा एंट्री, जो फर्स्ट रिस्पॉन्डर है उसके ऊपर मेहनत करो, फर्स्ट रिस्पॉन्डर को ट्रेन करो। जरूरी नहीं है उसको आप HSA भेजें या अमेरिका भेजें या इंग्लैंड भेजें, उसको खुद बिठा के समझा लें, प्यार से उसको थोड़ा समझाएं, उसको तमीज सिखाएं, तो फर्स्ट रिस्पॉन्डर भी ठीक हो जाएंगे। वो थोड़ी सी बात करने से जो है ना वो बेहतर हो जाता है। आप में से पता नहीं कितने लोग हैं जिन्होंने मुन्ना भाई MBBS देखी हुई है, उसमें क्या थी, सारी कहानी क्या थी? इट इज बेसिकली पैच एडम्स, ये कॉपी है ना पैच एडम्स की। So I will strongly suggest all of you to go back and watch Patch Adams. And what is Patch Adams? It's actually such a hospital which has healing environment and which creates such an environment that the patients feel more in control and they feel motivated and they heal themselves and they heal others as well. So Patch Adams एक movie है, उस जिसकी कॉपी थी ये मुन्ना भाई में। और Patch Adams is a reality, आप गूगल करेंगे, उसकी टॉक्स आप सुन लें। वो लुईविल या लुजियाना अमेरिका में एक जगह है जहां उसने पढ़ने कितने एकड़ पे ये हॉस्पिटल बनाया हुआ। एंड दैट इज अ रियलिटी, कोई गपशप नहीं है, वो इसी तरह ट्रीट कर रहा है। एंड पीपल ऑफ कैंसर एंड सीरियस डिसऑर्डर जिनको डॉक्टर ने कहा है कि ये तुम बस मर जाओगे 1 हफ्ते बाद या 1 महीने बाद या 3 महीने बाद, उधर से ठीक होके वहां वॉलंटियर बन गए, क्योंकि 5 साल हो गए मरे नहीं, डॉक्टर ने झूठ बोला था। तो वो दिस इज समथिंग which is there. So for inpatient, what are the critical moments where a manager should intervene? क्लिनिशियन को इस बात का नहीं पता होगा, या आप मैनेजर बन रहे हैं, आपको ये पता होना चाहिए। सो यू शुड नो व्हाट आर द क्रिटिकल टाइम पीरियड्स इन एनी हॉस्पिटल पेशेंट के लिए। सो जो सबसे क्रिटिकल टाइम होता है ना, हमने जब रिसर्च किया, दिस इज अगेन प्रूवन बाय रिसर्च, मेरी ऑब्जर्वेशन नहीं है, हमने रिसर्च में लोगों से सवाल जवाब किए तो ये रिसर्च में एविडेंस आया, द वर्स्ट टाइम फॉर अ पेशेंट हु इज एडमिटेड इन द हॉस्पिटल इज जब सुबह की शिफ्ट लीव जारी होती है। When the morning shift is going, the patient is looking at them because they are, और ये है भी, हकीकत भी है, people think that the professionals or doctors or nurses who work in the morning shift are the most intelligent ones, are the most qualified ones. ये शाम को आएगा ये लूजर होगा, ये शाम को आएगा नलायक होगा, बिल्कुल इसको इसलिए मॉर्निंग में नहीं लगाया कि इसको आता कुछ नहीं है। डॉक्टर, ये पेशेंट की परसेप्शन है कि अच्छा लायक बंदा होगा, स्पेशलिस्ट होगा, वो तो 8 से 2 ड्यूटी करेगा, ये शाम को तो फिलर आ रहा है बस। This is what patients perceive, although it's not right. It is absolutely against any system which we have. But the patient perception is like the most intelligent one, and those who can save him or her those who can cure him or heal him, they are now going back. 2 बज गए हैं, ये जा रहे हैं सारे, नर्स भी अच्छी वाली जा रही है, डॉक्टर भी जा रही है और बाकी सब भी जा रहे हैं. और एक चीज you will understand that in most of the government hospitals the morning is a huge rush. You have multiple nurses, doctors, specialists, paramedics, and whole ward is full, and it looks lively, and the people and the patients they feel very happy. Yeah, there are so many people, if I get an emergency they will save me. In the evening there is one nurse, one doctor, and many cats and a lot of dogs inside the hospital. शाम को खुल जाता है अस्पताल, कुत्ते बिल्लियां भी अंदर आ जाते हैं. एक डॉक्टर आता है, वो अपनी कपड़े शपड़े चेंज करता है, उसके बाद सिगरेट पीने चाय पीने बाहर चला जाता है. He leaves the ward empty. नर्स आती है, वो सुबह वाली को रिलीव करके, बाजी को रिलीव करके, सुबह वाली को जी मैं चेंज करके आती हूँ, वो भी चली जाती है. Now patient को सोचें जरा. Now think about the patient who is there and is watching everything. All the people who were his savior or his healing करनी थी, they are gone, and now according to him all the loser club is here. एंड वो सोच रहा है ये 2 बजे से लेके सारी शाम सारी रात इनके मथे मैंने लगना है, ये मुझे बचाएंगे, ये तो नहीं बचा सकते, तो नलायक हैं सारे. और सुबह 8 बजे वो लोग आएंगे. सो मोस्ट ऑफ द टाइम आप इसको रिसर्च करना, मोस्ट ऑफ द टाइम हॉस्पिटल्स के जो एक्सीडेंट्स होते हैं ना, इंसिडेंट्स कह लें, इंसिडेंट्स होते हैं जिनमें डेथ्स होती हैं, पेशेंट कॉम्प्लिकेट कर जाते हैं, वो सेकंड हाफ में होते हैं. सुबह को डेथ नहीं होती. पेशेंट इतना एंशियस होता है, कुछ पेशेंट इतने एंग्जाइटी का शिकार होते हैं कि वो सीरियस किस्म का दिल पे ले लेते हैं, एंड दे एक्चुअली फील अ लॉट बैड. So in the evening and the night the mortality is high. So एक तो ये टाइम है कि जिसमें मॉर्निंग की शिफ्ट इवनिंग में कन्वर्ट होती है और मॉर्निंग का रश इवनिंग की लोनलीनेस में कन्वर्ट हो जाता है. What to do about it? You have to balance the rotation, balance the number of people in the morning, evening, and rotate them as well, and make sure that the patient is counseled by the morning doctor. जाने से पहले पेशेंट्स को बताए कि यार ये जो आ रहे हैं ये मेरे से भी ज्यादा लाइक हैं, आप फिक्र ना करना, आपको बड़ी अच्छी केयर मिलेगी. और नंबर एटलीस्ट सेम हो. ये नहीं है कि सुबह को मेला लगा हुआ है और शाम को खाली. पेशेंट फील्स लोनली बिकॉज देयर इज नोबडी इन द इवनिंग इन द वार्ड. और वो भी आके शाम को देयर इज अ चैट, देयर इज अ क्लब, मोबाइल और गपशप और जो होती है आपकी द नर्सिंग स्टेशन, इट बिकम्स अ सोशल प्लेस एंड एवरीबॉडी इज एंजॉयिंग ओवर देयर, एंड पेशेंट्स वहां पे लेटे होते हैं, इंतजार करते हैं कि सुबह. सो द बिग वर्स्ट एक्सपीरियंस for patients is the changing time when the morning shifts converts into a very lonely evening shift. ये patient की healing environment को damage कर देता है. The patient doesn't feel comfortable और उसके हार्मोन्स दूसरे secrete होंगे, not endorphins और oxytocin और जो आपके dopamine और ये secrete ये नहीं होगा. Adrenaline secrete होगी, noradrenaline secrete होगी. His condition will become worse. वो कहते हैं सुबह ठीक ठाक छोड़ के आए थे, इन्होंने शामी की हो गया. अगले दिन आके पूछते हैं यार वो पेशेंट किधर गया? आपने कहा यार कल शाम को दिल पे ले गया, शाम को फारिग हो गया. This is a common thing which happens everywhere in most of the hospitals. Why? Because of that perception which patients have, with serious patients. दूसरा टाइम जो सबसे सीरियस होता है वो अर्ली मॉर्निंग होता है. This is the second worst period of all the admitted cases in the hospital. Is early morning, जब सूरज तुलू हो जाता है. और गर्मियों में बहुत जल्दी तुलू हो जाता है, 4:30-4 बजे. और कितने बजे आना होता है मॉर्निंग के मसीहाओं ने? 8 बजे. सो वो जो टाइम है 4:30 से लेकर 8 बजे तक का, वो एंग्जाइटी का टाइम है. इट इज वन ऑफ द वर्स्ट टाइम अ पेशेंट कैन पास थ्रू. यू एज ए मैनेजर हैव टू मेक समथिंग अम्यूजिंग फॉर देम. ये वाला टाइम जो चेंज ओवर था उसको बेहतर करें, आप उसको इस तरह से करें कि वो फील ना हो कि सारा कुछ खत्म हो जाए, अचानक वार्ड खाली हो जाए. डोंट डू दैट. और मेरा ख्याल है प्राइवेट में इट डजंट हैपन लाइक दिस. प्राइवेट में सुबह वाला, शाम वाला, रात वाला सेम ही होता है. But I'll tell you one more thing. The cupboard of the morning is very beautiful. It is filled with all the necessary equipment and everything. And the cupboard of the evening is empty. There is nothing in it. The evening nurse will come and he will open and there will be nothing. No adrenaline, no dopamine, no atropine, कुछ भी नहीं. गाज भी फजूल से. सुबह वाली क्यों रखी होती है? राउंड कराना होता है हमने. So in order to get the round done, we have a very beautiful morning cupboard. And all the resuscitation material is there. Endotracheal tube भी है, सारा कुछ है. शाम को कुछ भी नहीं है. वो दूसरे वार्डों से मांग रहे होते हैं. बंदा मर रहा होता है, एंडोट्रेकियल ट्यूब लेके आ, फ्लाइन नंबर दी, एनजी ट्यूब लेके आ, भाग रहे होते हैं, पीएनबी और कोई इमरजेंसी हो जाए, देयर इज नथिंग इन द इवनिंग. इन द सेम हॉस्पिटल, इन द सेम वार्ड, दिस इज हैपनिंग इन द मॉर्निंग एंड इवनिंग. व्हाई? मैं एक हॉस्पिटल में एमएस बना, तो मैंने जब राउंड किया शाम को, तो ने कहा जी चादरें भी नहीं है, कुछ भी नहीं है. मॉर्निंग वाला ताला लगा हुआ है. क्यों जी? बाजी देखने जाती. वजह क्या है? कि जी शाम वाली चोर होती हैं. Why would somebody think कि जी मैं मोमिन हूँ और शाम वाली चोर होगी, चोरी कर लेगी बेडशीट्स, इंजेक्शन मिसयूज कर लेगी. Can somebody misuse adrenaline, atropine? आप खुद सोचें, solocative. Why would they do that? But the common mindset of a morning matron or a morning ward in charge nurse is I am the most noble and the honest one, and evening night are all chore, thieves. So they don't hand over the same things which is available in the morning to the evening shift. And even the patient can see that this cupboard is now locked. If something happens to me, I will not be resuscitated because everything is locked now. And there is another वो टूटी पची सी एक होती है, शाम वाली जो कबर्ड है ना, वो पहचानी जाती है. आप जब जाएंगे ना किसी वार्ड में, now you can go and you can see, you can observe the difference between the morning cupboard and the evening cupboard just by the look of it. जैसे उनकी शक्लों से फर्क पड़ता है, पता चलता है ना मॉर्निंग इवनिंग के स्टाफ का, ऐसी कबर्ड भी ऐसी होती है. So आप the patient feels dejected because it is early morning, the sun is up, and the patient, and they know that their Masiha, their protector, their savior, they will come at 8. And in Pakistan, most of the hospitals of the government sector, no one comes at 8. So what happens? कि 4 बजे से उनके 8 बजे, अब 8 बज गए हैं घड़ी में और वो देख रहे हैं कोई भी नहीं आया. वो 8 बजे आए हैं, उन्होंने गाड़ी पार्क की है, सिगरेट पी रहा है, वो आई है दूसरी, वो अपनी चेंजिंग रूम में चली, कैंटीन में चले गए, नाश्ता कर रहे हैं. 8:30 9 तक एमएस ने उनको रिलैक्स किया होता है कि 8:30 तक आ जाएं, 9 तक आ जाएं. वो बंदा जो इंडोर में, the patient in the indoor is waiting by seconds, by minutes, and no one is there at 8 AM. बल्कि 8 बजे वो स्वीपर आता है सफाई मारने वाला, वो मिट्टी फेंकेगा आपके ऊपर, आप पहले ही परेशान है, मजीद आपको मिट्टी फेंक के चला जाएगा. So this is something which you can understand that the time of the morning, is the shift starts, and it doesn't start, it creates a lot of problem for the patient. Third worst experience, anxiety period, I can say, for the inpatients is the round of the specialist, where they are talking to each other and no one is talking to the patient. Yeah, just next time, just do a sort of observation of how the round is taken in a government hospital or a private hospital. The consultants are there, the whole mob is there, PGs, house officers, medical officers, nurses, and the professor is there, associate and assistant. They are standing on the foot side of the patient and they are talking to each other. They will pick a test. Test ho gaya, oh ho. They will do some exclamatory remarks bhi nikalenge. Oh ho, this, that, and patient is not, the patient has no idea what is happening. And they are just each other, and the patient is becoming anxious and anxious because he knows some new reports have come. And very few time is dealt with the patient. The professor is teaching the PG, the professor is teaching the house officer, they are teaching the students, medical students, and they are not talking about the patient. What will happen if someone is talking about you in a mob and the whole mob is least concerned about you? Your anxious period will be very high. So anxiety is at the highest level when there is a round taking place and the patient, they are there in their own circle. In West, we have seen they create a round around the bed. So instead of making a round of your own, you just stand on the side of his bed or her bed. So he can see everyone and you just counsel him. And whenever you are talking to each other, you also tell the patient that this is something which we have found and it is a good thing. Please be careful. Or hope dilana. The most important thing in healing environment is creating a sense of hope among the patients. We create a hopelessness, helplessness, and hopelessness. So in a hospital, principle of hospital management is you have to create hope into it. So whenever you are doing a round, talk to the patient most of the time. Don't talk to each other. Go to your classroom and then discuss this patient. वो उधर ही डिस्कस कर रहे होते हैं. मॉब पूरा खड़ा होता है, बारी बारी पीआर भी कर रहे होते हैं वहां पे. You have seen that medical students का, उसको खड़ा करके एक ही बंदे के ऊपर प्रोस्टेट का, जिसका स्टोन शेप्ड इसका प्रोस्टेट है, तो ये पीआर करवाना है सबको, लाइन से पीआर करवा रहे थे. पेशेंट क्या फील करेगा? जस्ट इमेजिन, ही इज अ कैंसर प्रोस्टेट. व्हाट विल ही थिंक? फीमेल है, उसको कोई प्रॉब्लम है यूट्रस का या किसी का, परवजाइनल एग्जामिनेशन हो रहा है, पूरे हाउस अफसर, मेडिकल अफसर जो हैं वो उस पर बारियां ले रहे हैं. दिस इज कॉमन. This is how we train physicians. This is how we train PGs. Is it healing environment? It is such a hurting environment for all of them. बगैर इसके सोचे, बगैर, और कंसेंट भी ऐसा ही लेता है कि तुझे, और जो नहीं देगा कंसेंट उसको बाहर फेंक देंगे, उठा देंगे, यार तुम अजीब बदतमीज आदमी हो, निकल जाओ. So just imagine that this round area is also very important. So And then there is another thing. Healing environment में equipment and their sounds की बात करते हैं. So staff की बात हो गई है, attitude की, setup and design की बात हो गई है, build environment की, equipment and their sound. We have seen that the patients who were taken into CCU, they were stabilized, they got better. When they are sent to a normal general ward after CCU, shift करते हैं ना आप. So you shifted somebody from coronary care unit or a cardiology unit to a general medical ward, they start having symptoms because they feel कि जब ऊपर हम रह रहे थे वो जो यहाँ पे chest tubes लगी हुई थी और वो जो leads लगी हुई थी chest leads और वो जो beeping sound थी और जो एक aroma था, CCU का अपना एक खौफ भी होता है और अपना एक image होता है. Patients के attendant नहीं आ रहे होते. So you have an isolation inside a CCU. The nurses ratio is 1 bed to 1 nurse. And you have doctors all the time there, 24/7. Shift change होने का इतना feel नहीं होता. Many patients are very sick, so they don't make any noise. They don't tell you anything. So when the CCU or ICU patient gets better, and you shift him down the ladder or some general ward, this setup, design, and equipment sound vanishes. So they start blaming. They come to MS, medical superintendent के पास आते हैं और कहते हैं जी हमारा patient अभी ठीक नहीं हुआ है, इसको निकाल दिया ICU से. हालांकि you need more serious patients over there. You are stable. You should be in the medical ward. But what is happening in the medical ward? I just told you. There's a huge difference between the CCU environment, lights and design, everything, and the medical ward. एक nurse, 30 patients और शोर शराबा, वो बंदा ICU से CCU से निकल के आया. He will again start feeling chest pain, again arrhythmia हो जाएंगे, again उसको hormonal imbalance हो जाएगा. दोबारा उसको लेके जाएंगे. Okay. So this is something you must understand, that this image of setup and design is very critical. So और हमने एक experiment किया. You know what we did? CCU patients were reluctant to get into any medical ward. We said झूठ बोला लेकिन अब क्या करें, patients के लिए कुछ समय करना पड़ता है. हमने जो उनको यहाँ से लीड तो हटा दी, लेकिन वो जो चेस्ट की लीड की यहाँ पे नहीं लगी होती, वो जो लीड्स लगी होती हैं वो नहीं उतारी. हमने कहा इनसे आपका दिल चल रहा था, मॉनिटर पे नजर आ रहा था, ये लगी रहेंगी, आप मेडिकल वार्ड में चले जाए. जरूरत क्या आपको उस वक्त उतारने की? उस लीड के साथ पेशेंट को भेजा. पेशेंट वाज वेरी कॉन्फिडेंट बिकॉज दे थॉट कि ये जो लगी हुई है ना यहाँ पे इमेज से, कि इसी से हमें वो केमिकल जा रहा है जिससे हमारा दिल चल रहा था. तो जब तक ये तब उतारेंगे जब हम बिल्कुल ठीक हो जाएंगे. डिस्चार्ज करने से पहले उतार दें आप. तो आपको जरूरत है इन एन ICU CCU दैट यू स्टार्ट प्लकिंग, वो उसकी थ्रेडिंग करना शुरू कर दें, बंदे की पूरे बाल रिमूव करें उसके. जिस तरह उतारते हैं लीड, जी आपको पता है चेस्ट की लीड खासतौर पे मेल्स के ऊपर से जो उतरती हैं, तो ये तो साथ पूरी की पूरी जो है ना हेयर रिमूवल पूरा चेस्ट का हो जाता है. साथ 6 लीड्स लगाई होती हैं और ऐसे से खींचते हैं और नर्स तो बकायदा एंजॉय करके खींचती है. जलील किया होता है पेशेंट ने कि जी ये पेशेंट हमें तंग किया है बहुत. If the patient is cured, you should send him home. You are sending him downward facility with all this kind of fuss. So why not just take care of it? So ये जो principle हैं, अच्छा smell एक जमाने में थी. I don't know why they have changed everything. Smell nice Savlon की या spirit की या किसी भी chemical की smell is healing. ये जो smell free डिटर्जेंट आ गया ना, बकवास है ये बिल्कुल. हमारे यहाँ पे पाकिस्तान में ये नहीं चलेंगे, क्योंकि हमारे यहाँ स्मेल फ्री डिटर्जेंट तो आप इस्तेमाल करेंगे, वो जो स्मेल बाहर से आ रही है गटर की और बकवास इर्द गिर्द एनवायरनमेंट की, उसे कौन रोकेगा? दिस जो स्मेली डिटर्जेंट था, इट वाज टेकिंग केयर ऑफ दैट बैड स्मेल एज वेल. हॉस्पिटल में आने नहीं देता था. सेवलॉन की, बाकी सारे जो केमिकल्स आप यूज करते हैं ना, अभी ये उन्होंने कह दिया जी कि अरोमा फ्री है, फलानी फ्री है. ये पाकिस्तान के लिए नहीं है भाई, वो तो उन डेवलप्ड कंट्रीज के लिए. आप यूज करें डिटर्जेंट जिसकी अच्छी स्मेल हो, वो पेशेंट को फीलिंग आती है. हम जब बचपन में छोटे बच्चे थे हमारे, तो हम जब हॉस्पिटल जाया करते थे वापस, तो हमारे पास बच्चे नहीं आते थे कि आप में से स्मेल आ रही है हॉस्पिटल की, अपने कपड़े चेंज करें, ओवरऑल चेंज करें. आजकल तो ये चीज उन्होंने फैशन में एक चीज आ गई है कि स्मेल फ्री आप ये करेंगे. दिस इज इंपॉर्टेंट. पेक्यूलियर डिसइंफेक्टेंट स्मेल ऑफ हॉस्पिटल इज अ पार्ट ऑफ हीलिंग एनवायरनमेंट. सो जस्ट टू रिकैप, इक्विपमेंट्स आर देयर, स्टाफ, attitude, setup and design, disinfectant, smell, every and surrounding, like I told you, this graveyard thing, available space, equipment and staff. This is something which makes a healing environment. So all of you should start working on how to create a healing environment for the patient, and start from the outside gate, entry gate. It should not be one gate. It should be 4 or 5 gates. एंट्री एग्जिट फर्क हो, इमरजेंसी का फर्क हो, ओपीडी का फर्क हो, डेड बॉडी का फर्क हो, सप्लाईज का फर्क हो. स्टोर की सप्लाई आ रही है, ट्रक ने रास्ता ब्लॉक किया हुआ है, खड़ा हुआ है, ओपीडी बंद है, इमरजेंसी बंद है. कॉमन हमारे यहाँ पे रूटीन में. और कई पेशेंट्स हमारे, आपने नहीं सुना डिलीवरीज हमारी रिक्शा में हो जाती हैं, अस्पताल के बाहर टैक्सी में डिलीवरी हो जाती है, क्यों? कि वो जो टाइम था वो खत्म हो गया, अंदर एंट्री में भी टाइम लग गया. So these are some of the things which are very, very important. We need to have actually create something which is important for all of us. So just to recap, remember that the basic principle of hospital management is hospitum. Take them as a guest, give them protocol. इस पे कोई पैसे नहीं लगते. You don't, it doesn't cost money when you are talking nicely. It doesn't cost money. Nice talking is cost effective. It is very cheapest intervention which can have. आपने सुना नहीं है कि डॉक्टर के अच्छे तरीके से बात कर देने से आधी बीमारी खत्म हो जाती है. ये बचपन से हम सुने आ रहे हैं कि अच्छे तरीके से बात कर लें, पेशेंट की आधी तकलीफ खत्म हो जाती है. हम उलट करते हैं इसका. मैंने आपको पहले बताया कि we do exactly the opposite. So all of us should strive how to do this. There are so many things. आप सारे रजिस्टर्ड हैं. तारिक साहब, आपको जो रीडिंग मटेरियल है वो मैंने अभी ये जुबानी बोला बहुत कुछ, but there are so many things, reading material which I can share with you. The email is here, the cell number is here. You are all free to text, WhatsApp, email, any material which is needed. And I hope we had a good start for this training. हमने health system से शुरू किया, अभी hospital management के ऊपर सिर्फ just healing environment की बात की है. जनरल आसिफ सकेरा जो सन जनरल रहे हैं पाकिस्तान आर्मी के, लंच के बाद उनका सेशन है. जनरल सलाउद्दीन कासिम का लेक्चर है, मिनाज साहब, मतलब there are very renowned people who have done great job in Pakistan in the hospital management. Very few, but they are available and they can share experiences with you. Thank you very much.
Thank you very much, Dr. Shahzad. Just I'll take only a few questions, 2 or 3 questions. First.
डॉक्टर शहजाद साहब की हुई बातों को मैं क्या आगे वहां बयान कर सकता हूं, अगर आप मुझे इजाजत दे दें.
Please, sir.
मेरा ख्याल है देंगे तो आई विल बी बेटर टू टेल द ऑडियंस.
Thank you very much. Well, you have a very चले हमें तो इसलिए कह रहे हैं माइक दे दे नेक्स्ट थोड़ा
जी. अस्सलाम वालेकुम. मेरा नाम डॉक्टर बशीर है. आई एम प्रोफेसर ऑफ एनाटमी. आई हैव बीन टीचिंग इन निश्तर मेडिकल कॉलेज एज वेल एज हैविंग रजिस्ट्रार इन ICU. तो मैं आपको 4-5 बातें जो यहाँ करने के लिए मैं आया स्पेशली इसलिए हूँ कि हमारी यंग जनरेशन इस वक्त जिस हालात से गुजर रही है उनको हम क्या बताएं. नंबर 1, मैंने 4-5 पॉइंट लिखे हैं कि डॉक्टर शहजाद साहब लगता ऐसे है कि इन्होंने अपनी आंखें और दिमाग खोल के रखा है. जितनी देर ये हॉस्पिटल में रहे हैं एज MS या जो कुछ भी इन्होंने बातें बताई हैं, होना ऐसे ही चाहिए हमें. नंबर 2, मैं बात करूंगा कि आगे, क्योंकि मैं पोस्ट ग्रेजुएट का भी सुपरवाइजर रहा हूं और हूं और PDR का भी हूं. मैं अपने PDR, मेरे बहुत सारे सैकड़ों स्टूडेंट्स हैं, बल्कि हजारों कह लें. टीम्स में भी बहुत सारे स्टूडेंट्स हैं, वहां निश्चय में भी था. तो एक दिन मेरा अजीज बीमार हुआ तो मैं गया उनके आउटडोर में, वहां उसे रिक्वेस्ट की कि भाई ये मेरा मरीज दाखिल करा दो. द पेशेंट वाज कार्डियक पेशेंट. वहां उन्होंने उनका JVP देखा, हार्ट देखा, चेस्ट देखी, वही पेशेंट दाखिल हुआ. अगले दिन मैं सुबह गया हूं, वही PDR मिला और बेड उसको अलॉट हुआ था. मैंने कहा बेटे आप बताओ पेशेंट का क्या हाल है, इसकी इन्वेस्टिगेशन हो गई हैं? तो कहने लगा सर इस पेशेंट का तो मुझे पता ही नहीं है. ये PGR जिसे उस बेड का कल जो उसने पेशेंट की फाइंडिंग ली थी, अगले दिन वो कहता है मुझे ये पेशेंट नहीं पता. ये बच्चा 5 साल के बाद FCPS करके आ जाता है और कंसल्टेंट लग जाता है. कैसे? आप मुझे ये बताएं. फिर यही हाल हुआ. मैं पूरे राउंड के दौरान रहा, 7 रात 40 PGR से उस वार्ड में. जो ही खत्म हुआ मैंने कहा किसी और स्टूडेंट को कहूं कि बेटा इसका हाल देखो. इसके बाद मुझे एक PGR नहीं मिला. अब ये सारे पीडीआर गायब हैं, ट्रेनिंग कैसे हो जब बच्चा ही वहां नहीं है? जो पेशेंट कल उसने देखा, जिसका वो जेवीपी देख रहा है, उसकी कार्डिक मॉनिटरिंग कर रहा है, ईसीजी करवा रहा है, ये अगले दिन इन्वेस्टिगेशन तो नहीं है, वो पीजीआर को पता नहीं। अच्छा, मैंने कहा आपका कौन सा पेशेंट है? कहता सर मेरा यहाँ पेशेंट था, वो आज नहीं है, शिफ्ट हो गया। मैंने कहा किस चीज का पेशेंट था? मेरी आदत है क्योंकि हम पढ़ाते हैं तो यस, तो दैट वाज ही वाज अनएबल टू टेल मी sir, I don't know about this patient and this patient and this PGR, how he is going to be trained. In this way, if we are going to train our young ones, then the result will come in that way the Shahzad is telling. Next patient. I was present in the ward ICU and I got a call from labor room. Please come and there is an emergency. I went there, got the baby, I gave respiration mouth to mouth and then get that baby. There was no instrument to, endotracheal tube was not present, embo bag was not present. So I have to give respiration mouth to mouth breathing and I got that a small baby with my hands giving respiration to his mouth and got to the ICU. Then I intubated him and then after that, that baby was saved. But on another day, I was entering into the theater. I was seeing that patient is perspiring. पसीना ही पसीना आया जा रहा है पेशेंट को और मेरा वहां पे जो एम्बो बैठा है बैग एम्बो बैग किए जा रहा है मैंने कहा डॉक्टर साहब प्लीज सी योर पेशेंट, देयर इज प्रॉब्लम विद योर पेशेंट, ही इज टेलिंग सर ही इज ओके. आई आस्क्ड हिम प्लीज फील हिज पल्स, देयर वाज नो पल्स. सर्जन वाज ऑपरेटिंग जस्ट फॉर फिस्टुला 18 years age. There was perianal fistula 18 years age. Anesthetist is there, patient is with huge excessive perspiration. Even the surgeon does not know and the anesthetist does not know. The patient has gone. So that is due to the lack of proper training and proper interest in our young ones. And now the older ones are also going to lose their interest. There are many factors why they are losing their interest, I don't know. Number 3. मेरे अपने चचा 40 years age, renal stone, admission in the urology ward. He was catheterized in such a way that catheter was not in the bladder, but it was in the urethra. और उसने कैथीटर डाल दिया है, पेशेंट वो कहता है जी डॉक्टर साहब यूरिथ्रा डाल दिया है, कहां पड़ा हुआ थोड़ा सा यूरिन आ गया है. Patient was crying with the pain. The doctor was not present, nurse was not present, and they were telling him that after some time you will be all right. There was so pain that after the attack of a bout of pain, he went on the floor and got head injury. After ये सारा कुछ हो रहा है, मैं ये कह रहा हूं जो नई हमारी नस्ल आ रही है, हमारी नस्ल दरअसल इन सब चीजों को खुदारा ट्रेनिंग, अभी ये कह रहे हैं कि अभी जेनिटो यूरिनरी पे एक और एफसीपीएस की आ रही है, तो ये एफसीपीएस जो आई जा रही हैं ये बढ़ाए जा रहे हैं. मकसद ये है कि आप इतनी सुपर स्पेशलिटी बढ़ाते चले जाएंगे तो क्या उसका रिजल्ट हमें सही मिल पाएगा. अब मैं ये कह रहा हूं कि इसका इलाज क्या है. इसका इलाज ये है कि हमारे पास जो इदारे हैं, हायर एजुकेशन कमीशन, पाकिस्तान मेडिकल काउंसिल, पंजाब पब्लिक सर्विस कमीशन और दूसरा हेल्थ सेक्रेटेरिएट, जब तक ये बैठकर कोई यूनिफॉर्मिटी पैदा नहीं करते, इसके लिए मैं थोड़ी सी मिसाल दे रहा हूं. हमारे एक साहब थे, उन्होंने एमफिल किया बायोकेमिस्ट्री में, उन्हें कहा जी आप बीएचयू पे जाएं, आप नौकरी करें. एक साहब थे, उन्होंने किया एफसीपीएस पीडियाट्रिक्स में, उसे कहता है जी आप चले जाएं फिजियोलॉजी डिपार्टमेंट में. वो पीडियाट्रिक्स वाले का फिजियोलॉजी डिपार्टमेंट में क्या रोल है? हेल्थ सेक्रेटरी को नहीं पता। तो बहुत सारी ऐसी प्रॉब्लम्स हैं जिनकी वजह से हमारे यंग वंस कहीं तो प्रॉपर ट्रेनिंग की वजह से फंसे हुए हैं और रिजल्ट सही नहीं आ रहा, और कहीं सेक्रेटरीट के प्रॉब्लम से फंसे हुए हैं, प्रॉब्लम आ रहे हैं। तो इन चीजों को मैं फिर रिक्वेस्ट करूंगा डॉक्टर शहजाद साहब से कि आप जिस जगह बैठे हैं इन प्रॉब्लम्स को आप इन इदारों के साथ बैठकर डिस्कस करें कि अगर आप रिजल्ट चाहते हैं तो अपने डॉक्टर पे फोकस करें। ये आपकी सबसे ज्यादा कमाई बड़ी, डॉक्टर जो बना रहे हैं अगर ये सही तौर पर ट्रेंड होगा, इसके दिमाग के लिए अगर आप एनवायरनमेंट सही पैदा कर सकते हैं तो और इसकी प्रॉपर ट्रेनिंग कर सकते हैं तो तब आपको सही रिजल्ट मिलेंगे। अदरवाइज हम आएंगे, लेक्चर सुनेंगे, खाना खाएंगे और चले जाएंगे।
Thank you very much, Dr. Saab. Everybody has its own bad and good experience, but I don't want to go into detail of these experiences. Just focus on the 2-day sessions. If anyone have a question, please.
मेरा नाम डॉक्टर अहमद है और शाह शहजाद का जबरदस्त लेक्चर हमेशा बड़ा सिंपल और बड़ा याद रहने वाला लेक्चर होता है, आज भी ऐसे ही था। सर इसमें ना दो चीजें मैं आपसे पूछना चाहूंगा, एक लेक्चर के लिहाज से और एक अदर देन लेक्चर ना। पहला तो ये है कि आपने कहा कि जो हमारे पास मॉडर्न हॉस्पिटल्स आ गए हैं जहाँ पे कि सुपर स्पेशलिटीज हैं, बिल्डिंग अलग-अलग हैं, लाइक वी हैव इंस्टीट्यूट ऑफ फलान, इंस्टीट्यूट ऑफ फलान, बहुत सारे ऐसे हैं। इसका हल क्या है? मतलब आप क्या समझते हैं कि इसको कैसे इसको ओवरकम किया जा सकता है? जो क्योंकि ये तो डिमांड ऑफ द डे है, शायद ये बनते जाएंगे और हर हॉस्पिटल उसी लाइन पे चलता जा रहा है। तो मतलब आप क्या समझते हैं कि इस प्रॉब्लम को ओवरकम कैसे किया जाए?
सिंपल सॉल्यूशन।
Yes, I want to ask that we have an international audience. I request for all of you, please ask question in English.
So solution is teams. You have to create teams in each of that unit. You don't rely on someone else's cardiology expertise, someone else's urology expertise. Within your center of excellence in cardiology, you should have the team which can respond to some of the things. So you can send complicated cases, of course, later on, but the concept of even sending a call for just urinary retention and chest pain or something like that, it is discouraging. You need to create a philosophy of, again, we need generalists now. The solution is, if you ask me, we don't need specialists. In Pakistan, we need generalists, a person who can treat multiple diseases with his basic experiences, and only few super specialists are needed. We are producing super specialties just like a wholesale market, and they are not getting jobs. They are not getting patients because the problem is minimal. We need to create more generalists, not specialists, general surgeon, general physician, something like that. And then our system will improve.
Thank you very much. Ladies and gentlemen, thank you very much. Please, I request you, all of you, please, Dr. Shahzad is here in the lunch with you. And if you have a question, you can ask with him. Thank you very much. Okay. Lunch ke liye aap hain.
Everyone, the lunch break is till 2:30. So let's try to be back here on time, please.
Bismillahirrahmanirrahim. Welcome again. Now we start the session 3. Topic of session 3 is managing human resource in health. Ladies and gentlemen, it's our players. We have a very renowned medical and health professionals, public health specialists, as well as he's a very kind teachers. Lieutenant General Asif Mumtaz Khera, retired. He's a former surgeon, General Pakistan Army, and a member of HEC. And he's also working as VC, Vice Chancellor, Muhyiddin Islamic University. It's my pleasure now General Asif Khera with us. I would like to invite General Asif Mumtaz Khera to deliver lectures on managing human resource in health. Thank you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good morning to especially our those overseas students or participants from Africa and other countries. It's a privilege to be here on this very intellectual and highly professional forum where we see doctors all around and they are here attending this session since morning. I'll be talking about human resource management in health. Generally in Pakistan, even in the public sector, human resource management or human resource departments, they are still not established in most of the hospitals, especially in public hospitals, once we talk about the healthcare. Healthcare again is divided into two entities, the public sector and the private sector. So I have been on the board of Faisalabad Medical University, and our previous health minister from Punjab, Dr. Yasmin Rashid, she was the chair of that board and she used to attend all the meetings. And I used to travel from here to Faisalabad to attend the meetings. So it was a good privilege and learning to be a part of that board, especially under her chair, because we all know her. She is a very dedicated professional, an outstanding gynecologist, and there are so many gynecologists and students trained by her, and especially her dedication, and that we saw during her tenure as the chief minister, health minister of Punjab, the biggest province of Pakistan, where she managed the healthcare infrastructure and healthcare ministry in an outstanding way. And especially during that period, she underwent treatment for breast cancer, and with all that chemotherapy and that turmoil, she still kept on doing her duties and performed outstandingly. So what I want to say is that in one of the meetings, she urged the Vice Chancellor of Faisalabad Medical University and the MS that we should have a proper functional HR department in the hospital, because this is how the modern organizations they work. And because we all are old timers, even in the army, we don't have a proper HR department in the civil side or in the army side. In the public hospitals, what we learn and we have seen is we call it as the establishment branch or the establishment office, which takes care of all the enrollments, employees and everything. And then the HR functions, which are in the modern age and the modern HR management concepts, which are organized under one umbrella and in one office, that is not the concept. So I'll touch upon that in my subsequent slides, that how HR management is being done in the army. Just a brief definition that what is HR management? It is basically practicing how to manage the human resource, how to make best use of it to achieve the organizational progress or best outcomes. It is the most critical management area, of course, because human beings, they are very complex. And I always say that out of millions and billions of human beings that have come to the earth and will come up to the day of judgment, every individual is different from the other. And we all know that. We talk about the thumb impression, but I also always say that even the physical chemistry, the behavior, the emotions of every individual are different from each other. So that is why it is most difficult to manage human resource in any organization, because that is the basically challenge, how to bring everybody under one roof, targeted on one goal, and to have the best outcome for that organization. As I said, the human resource is one of the three principal healthcare components. The other one are the infrastructure, the money that we put into any organization. But the main thing, the main resource is the human resource. It's a saying that clients do not come first, employees come first. We are always said, while working in the public hospitals, that you need to take care of the client. You need to have a pleasant smile on your face while attending to the patients, whether it is a first patient at 8 o'clock in the morning, or it is 150th patient at 12:30 in the afternoon. We should have the same emotions, and we should greet every patient with smile and with good gesture, which is humanly not possible. So that is why, and in the private sector, they always say that the client is your most important asset, because whatever you are earning, that is because of your client. But in the human resource management, they say that your employees are most important, because if your employees are satisfied, they will take care of your employee, your organization, and they will be very dedicated and honest to you and themselves. Human beings, they are the nucleus of the universe or the earth, whatever we say. And this is, as I say, it is the ultimate capital. There is no cost. You can talk about any human beings, whether it is in millions or billions. If we talk, it's a famous example that if somebody says that I'm very poor, and somebody asks that, okay, you are poor, then you donate me one eye for just 100 rupees. So nobody is ready to do for that. So human body and human being is very, very expensive, and there is no cost that you can measure with it. Since the time this earth was created and the human societies they developed, there has always been a struggle and an effort to put the system right, how the human beings they are going to manage themselves. But on that context, the most important things on which every society and every organization and every country has worked on are these four things. That is, how to put the judicial system right, because they say if the justice is not there, you can't survive in that society. Second thing is finance, that they say that money makes the mayor go. So if you have money, then even if you are mad, you are wise. If you don't have money, even if you are wise, you're known to be a madman. The third thing is governance, that how you manage your system, your country, your organization, and everything. And finally, during the last few decades, the technology has come in. The most technical, latest technology that you have, you will access, and you will be, that is a guarantee of your success. But I have a different view. I believe that these four categories are how to put the systems right. But we haven't worked on how to put the human being right who is going to run all these four systems. And this is what the prophets used to do. They used to work on the hearts of human beings. That if the human beings are changed, if they are honest, they are on the right path, then you hand them over any organization that will work on the right path. But if the human beings are spoiled, then whatever you hand over to them, it is a country, it's a rule, an organization, an academic institution, or a hospital, they are going to ruin it. So that is very important, that how we manage these things. Just a brief, you all must have read during your courses that some of the 7 basic things that we see in the human resource management. First of all is how you hire a human being for an organization. That is what we call as hiring and recruiting. The second is the performance management, that once you bring everybody in, then you give them the task, train them for that, and then you manage how they progress and how they deliver it. And the third thing is the leadership and governance, that you teach them that, in every organization, the human resource capital is divided into different tiers. It is, the baseline worker, then we have the managers, the floor managers, the senior managers, then the managing director, and the higher leadership. So you need to train everybody with the passage of time that how they are going to assume the higher role. In this context, I would like to share which probably might have been touched in the morning session also, that is leadership and governance in healthcare. What I have seen in my experience in the army for about 35 years, that everybody can't be a good leader. So there are very few who are born with leadership qualities. And that is because of certain, their placement or their exposure to certain organization that they learn leadership. Otherwise, this is something that you learn through an structured program or through your experience. Brigadier Wasim is sitting here, and I always say in the army also, that army, we have two streams. Number one is everyone is inducted as a GP in the army in the rank of captain. And then over a period of time, then they are given the option whether they want to specialize in any field. They go for fellowship part 1 exam, then they clear that, then they enter into the specialty stream, and they undergo 3 to 5 to 7 years training, whatever the program is. And then they qualify the exit exam. And after that, once they have the fellowship degree, they enter into the specialist pool. And those who don't enter into that or who opt to remain as a GP, they remain in the healthcare administration pool in the army. So these two pools, basically they are working in the Army Medical Corps in Pakistan. And almost same is the case in other organizations and other countries also. But here what we do is, what I've seen the Turkish model, that there even the specialists, they are at places, they are brought into command of an institution and other things. But my observation is that those who entered into a specialty and then at a later stage, they opted to come back into administration, they are never good administrators. Because that is the time of your service from 5 to 15 to 20 years of service, that if you remain as a healthcare administrator or as a GP, you learn administration through your experience, through your appointment at different administrative placements, and then you grow and in confidence how to manage different organization at the management, senior management, and the leadership role. And if you miss that 5 to 10 years of exposure, and you are then concentrating on your specialization in any subject, then you don't carry that experience. And even if you are appointed as an administrator or head of an institution, you are never that confident, which a hardcore healthcare administrator is. So that is very important, that it is not only the qualification, the training, it is the years of experience that ultimately matters and which makes you a good leader or a senior manager. Then, of course, come the compensation of benefits, what we call is the salary or the allowances or honorarium, whatever we say, which is part of a, as I mentioned, a well-structured human resource management system. HR information system, this has lately come in where there are proper softwares and applications where everything is managed on the internet, on web, and then you move on. In the Pakistan Army also, we have a hospital management information system, but somehow that is LAN-based. That is purely on, fiber optic or cable network, and it is not web-based. So that is a challenge in this country, whenever you have power breakage, then you are off from the network. You can't attend to that patient. You can't feed the data in that. So these are the issues. In advanced countries, what they have done is that most of the HMIS or hospital management information system, they are web-based. Because for that matter, even a surgeon or a radiologist sitting at his home, he's connected from his home through the web with the portal of the hospital, and then he can report the lab or the radiology reports even while sitting at home. And similarly, he's in touch with the hospital, whether he's working in the ICU, what is the condition of the patients, and what are the imminent calls that he's likely to get, and then he rapidly responds. Once he knows this patient is serious, he can go there. So that are the advantages of having a HMIS, which is web-based, that you are linked all the time to that system. And finally, the HR data and analysis, which ultimately is the crux. How you judge the output of human resource management, how many patients a team of 5 surgeons have seen from morning till in the afternoon, how many surgeons they have operated, because this is again, as I mentioned, part of the human resource management, that you have an equal distribution of duties to all. In our culture, you have seen that some people, get a knack of writing or publishing articles. So what we say is in Punjabi that jab chaka khul jata hai, so then they, keep on concentrating on that, because somehow we have tagged the promotions of the specialist faculty with the publication of articles. So for that matter, some of them, they evade their duties. They're not seen at the place of their duty, and they're busy in the library or other places, working on their articles that they're going to publish with others. So that is very important, that you have an even distribution of workload on all the people. If somebody is interested in research, then the bigger organization, they have separate slots for research in OIC, in other organizations, where then they don't have to do the clinical work. Or the other option is that we see in America, that some fellowship student or an internee is given that for these 2 weeks you are going to do your clinics. For these 2 weeks you are going to work in the indoor, and for next 2 weeks you have to go for the research into the lab or to the data center, and then you have to work that what is the performance of this hospital in terms of number of patients seen, the variety of patients that you get, what is the outcome of the patients. So these are, but then you need a lot of money for that, to have separate slots for research people and the clinical clinicians. I'll not go into the detail of what human resource management is and how the modern human resource organization they work, what is the infrastructure, because that is a completely separate subject. I'm just going to touch the outline, how you manage human resource management in a healthcare organization, and especially in the backdrop of Pakistan scenario. So what is the benefit of having a strong human resource management system? First of all is that the organization develops a capacity to retain the staff. Now, again, as I mentioned, that these human resource protocols, management protocols are basically practiced in private organizations. And as I mentioned, in the public sector, we don't have regular offices for that. So in that context, the organization, it's very important for them that whatever person they hire, over a period of time, they train them and they make them understand and orientation with their environment. And once they are trained to manage your organization, then there are always chances that that person may be picked up by some other organization on a better salary, and he may leave you. So that is very important, that if you keep on having an eye on every individual, that what is their performance, then you can keep on compensating them, giving them more benefits. That is important to retain them. That is very important. In the public sector, as I mentioned, there is no concept of that. Anybody posted in PIMS, he doesn't have the option, to go to district headquarters hospital, Jhang, or to any other place. He's happy in Islamabad, he has to stay here, he's working in the federal ministry. So that is not the option. But in the private organization, it's always the money. Any other organization shows a better salary to anybody, and they can pick them, take away your people. The second benefit is, of course, the employees' performance, that you gauge them regularly through a monitoring system and performance evaluation. The third thing is that you can make the organization more efficient. To this, to some extent, other tools are being used. That is the attendance system, which is the thumb impression or the face impression that has been going on for some time in different organizations. in our medical colleges, this is part of the PMC, inspection also, that they want to know the regular attendance, that how much of your faculty is regularly employed and they are attending your college. Because, at times they, in the past, they used to book people on papers only, pay them monthly nominal salary, and they used to show them that they are part of their faculty. So, but through this system, you have a regular record of their attendance, their performance, how they are doing, as I mentioned, number of patients seen, number of operations done, and so on. And that also saves cost, because if you don't have this system, then you have to employ more people to monitor the performance of your employees. And then it also helps in managing the change, because you have the data in the background. As I mentioned, that if you have a strong human resource management system, you have the complete data. That what was the workload on the lab, how many number of tests in hematology, chemistry, or microbiology, or other departments they were performed. And accordingly, then you can manage that, what different specialties you need to have there, how many technicians you need to have there for these number of tests, how much phlebotomy was done from morning till evening or in 1 month. And accordingly, you can manage your lab human resource, that whether you have overemployed or underemployed people. Generally, in the human resource in health sector, we have these 3 categories of people working with us, which are the GPs and the specialists. Then we have the nurses and the allied workers. And then we have the supporting staff, or the lab or the pharmacy staff. So in any hospital, the last category makes the bulk of, any organization. But generally their salaries are far less, and the human resource at number 1, they excel in the major capital and your salaries that you go on that. So these are the 3 categories that you are generally managing in any organization. The other important thing about human resource management in healthcare is that healthcare industry is human resource intensive. In other places, if we say about landscaping, gardening, or other things, with modern tools, and grass cutters and machines and other things, where we used to have, say, 50 malis working in a hospital, maybe now 5 would suffice with that machinery and tools, whatever is available, the gardeners. So from 50, they have been reduced to 5. But once we talk about the healthcare, you can't replace a doctor. Whether you have, the robots performing surgeries. I visited Beijing University, and there I saw the robot surgery, and that was being done by a distance, place where somebody was operating, a doctor, of course, sitting, and the patient was lying here and the surgery was being performed. But again, although it is being performed by a robot, but it is being operated by a doctor, by a specialist. So a doctor cannot be replaced in healthcare industry. It can never be. The computers, the data that you have, the artificial intelligence, you must have read recently that they have now devised an app through which they, picked up, say, 1,000 X-ray of chest, and then they divided different categories, numbered them, and according to the findings, finally what happened, that the software would tell you that this image is likely to have this tuberculosis or a mass or a tumor or lung cancer or so on. So, but again, you can't subtract the doctor from that. Ultimately, at the bottom of every lab report or a radiology report, it is always written correlate clinically. And that is to be done by a doctor. And this is what we have seen in our setup also. With the modern gadgets, we have brought the hospital management and information system. Every doctor in his clinic has a laptop in front of him where he enters the data of the patient, examines the patient, feeds the data, and then sends the patient. So generally, the complaints have been in the army also that the doctor never looked at me. He has all the time been looking at his computer and talking to me, and he just examined me for a minute or so, and he has given me the diagnosis. So the patient is never satisfied. We are human beings. We need a human touch for our satisfaction, that some human being who has compassion or passion has examined me. That is the ultimate in patient care. And that makes a lot of difference in the outcome of the disease. The doctors or the human resource in the health sector carries a very high development cost. You can see, with this present tuition fee that medical students are paying in the private sector. Overall, in Pakistan, we have about 22,000 seats in MBBS every year. And out of the public sector, private sector. And then thanks to the previous PMC, they have done another wonder that they divided the hospitals into different categories. So a C-class hospital or a medical college would charge, 10.5 lakh rupees per student per year. And an A+ category can charge more than 17 lakh rupees per year. And I would not name, one of the private hospitals is charging even 26, 27 lakhs. I heard about it, but once one of the microbiologists whose daughter was studying in that college, she told me that, yes, I am paying 26 lakh rupees per year. So with this capital cost that we are training a doctor, this isn't even in case of pilots that we say, they abandon the machinery and they, eject from the aircraft when it is about to crash, because the pilot is more important than the aircraft. But I would say that the doctor is equally important, if not less important, than a pilot. The other thing is that the healthcare industry is very, very expensive. It's a huge industry. In America alone, people say that the healthcare industry is rather more stronger than the defense industry. $8.5 trillion is 1 year budget for the healthcare industry only. $8.5 trillion in 1 year in USA alone. This is the revenue of the healthcare industry. So you can see in every place, in Pakistan or every place, this is the major share that the government pays in treating the patient and managing the hospitals and so on. So that is very important, that where you are pumping in so much of money, you should have good people managing this human resource so that they can deliver to the optimum and to the best reward for the money that you are putting in it. With the changing trend, of course, this is a new scenario developing, that is, technology is coming in. So those who are more savvy in technology, they are doing better, of course. But I say that now technology should not be a problem now, because even a Aya or a maid working in the house, she's more, literate on managing a smartphone than even a good professor. So for that matter, thanks to the mobile phone, that they have made the things easy for us, and everybody, once anybody is good literate in managing a smartphone, they can manage the computer also. Gender reshaping, this is what I want to bring to your notice, that for the last about 10 years, our healthcare industry has reshaped. I graduated from Qaeda Medical College back in 1982, and mine was the 5th batch. And just to share with you that Qaeda Medical College was established along with 4 or 5 other colleges in Pakistan. The previous one was, especially in Punjab, previous one was King Edward Medical College and National Medical College. And then these 5 colleges, Allama Iqbal Medical College, Rawalpindi Medical College, Qaeda Medical College, Faisalabad Punjab Medical College, and so on. These about 5 medical colleges came up. So in that batch of 1982, we graduated with 250 students of class. And out of those 250 students, we had only 30 girls. And then came the ruling from the Supreme Court of Pakistan that entry into the medical college will not be, seat or gender based. It will be on open merit. Those who have higher merit, whether they are girls or boys, they will get admission into that. So for the last about 10 years, the output from all public medical colleges generally is about 60 to 70% girls graduating every year. And out of those, according to reliable statistics, about 40 to 50% did not practice medicine after graduation because they get married and then they have to look after their family, their in-laws or their kids. So this is what I want to say is that once we talk about human resource management in health, this is a very important factor that we need to keep in mind. We experienced that in the army also. I was a brigadier and I was commanding Combined Military Hospital, Quetta. And there, in our times, old times, most of the people in administration, they were almost 100% male. But with more induction of females, gradually the females, they also started coming in administration. So in the administration block, a problem came to me one day that we now have about 4 lady medical officers working with us in the administration block, but we don't have a separate female toilet for them. Similarly, the same situation emerged in the field medical units. For the boys or the male, they used to have a tent pitched somewhere about 50 yards away from the field hospital, and they can use that as a toilet. But then the girls came and then they had to have a new system all around. So this is just an example that I'm quoting. Same is the case for their working hours in the clinics. You need to have a daycare center for the children, for those who have, small kids. They can't leave them at home with the maids or with their families. So they bring them along, and now almost every hospital has a daycare center where the kids, they are looked after. So these are the changing scenario that I'm talking about. This is how things are shaping. And for the last more than a year, you see the first Surgeon General lady of Pakistan, Lieutenant General Nigar Johar. So this is how things are changing. The first lady Major General was promoted, say about 10 years back, General Shahida Malik. And then we currently have about 4 to 5 Major Generals and 1 Lieutenant General who is heading the Medical Corps, and that is Lieutenant General. Coming again to the healthcare scenario in Pakistan. Pakistan has one of the lowest densities of healthcare workers in the region. The professional density of 1.4 per 1,000 population. In Pakistan, the demand for and size of HR is forecasted to grow substantially. Why? That is because of the huge population explosion. I remember I was a student in Kaiser Medical College, and that was back in 1979 or 80, when a delegation from the army visited college. And that was the time that army used to have forced conscription from the graduates coming out of the civil medical colleges. Army didn't have its own medical college at that time. So every graduate from a civil medical college had to work in the army compulsorily for 2 years. At that time, the army launched a new program, and that was to visit different colleges, address the students of 4th and final year, and tell them that you have the option to join the army now. We'll pay you for about 5 years of your education in the college, a reasonable honorarium, and then immediately after graduation, you will be given the rank of a captain and you will be commissioned in the army. So I was in 4th year when I joined the army, and that was impressed with their presentation in which they highlighted that currently the country has so many medical colleges, and after about 5 years there will be so many graduates, and out of them so many good reasonable percentage would be unemployed. So this we have been hearing for, say, since 1980, that there will be unemployment of doctors in the country. But thanks God to our seniors or our elders, that with the rate the population explosion has come up, this demand is falling short every year, although we are producing about 22,000 doctors every year. So with this population of 220 million, there is still more demand, and with the present population growth rate, this is going to keep on increasing every year. Imbalanced geographical distribution, poor job satisfaction, again, the same old thing. Why we say that this healthcare system in the civil is not working? Because this is the recommendation of WHO, of all international organizations, on UN, that is to strengthen your primary care system. We had established a good primary care system about 15, 20 years back in the form of basic health units, rural health centers, Tehsil headquarter hospital and district headquarter hospital. But somehow that didn't work because the doctors, they were not willing to go into far-flung areas, serve in the basic health units, because, of course, because of the obvious reason that the basic health units at most of the places, they are in villages, in remote areas, where the doctor, if he is married, he doesn't have a school to, educate his children. He doesn't have proper accommodation for that. Then he has to, suffer the, what I can say, harassment of the local feudal lord or the police officer and so on. So these are various reasons because of which that system is not working and is still didn't work and is still not working. In the army, why it is working? Because they have a very good system. Every officer, every doctor who joins the army immediately after graduation, once he joins, he is exposed to about 6 months basic military training, and then he is posted to a hard area, whether it is the Siachen Glacier, it is Kashmir, it is Waziristan, it is Balochistan or any other place. So they go there for 2 years tenure. So that is the time when the doctors, usually they are not married, or even if they get married, they don't have kids. So they can easily, stay there for 2 years. Their spouse would stay at their parents' home or with their in-laws, and they can fulfill that 2 years hard area tenure and stint. Once they come back, then because of the recent war or terror that was going on, this deployment from hard area to hard area, that has been going on for at least 2 or 3 postings. But since it is the army, you have to obey the order, so people have been going in. And that is the reason our primary care system and the secondary and tertiary care system has been working flawlessly for the last 15, 20 years. And it is likely to work more because we are now increasing the strength of doctors, nurses, and paramedics, increasing the vacancies for the human resource. And then many of the hospitals, they have been now converted into teaching hospitals. So we have a reasonable number of trainees or fellowship trainees who are basically managing our tertiary care system. This healthcare challenge, human resource, is not only in Pakistan, it is also everywhere. In the National Health Services of UK, the normal 1:1 nurse to patient ratio is now working on, 2 to 3 patient ratio. And in that even, the one nurse is supported by a paramedic or a patient assistant to help her. That is from 1:1 ratio. Now the nurse is working 1 nurse against 3 patients. I visited America for the first time in 2005, and I happened to visit a hospital in Philadelphia where my class fellow, he was a pediatrician there. So he took me to the hospital, and there I visited the nursery because he was a neonatologist. So there I saw a different scenario as compared to our nurseries. The nursery, once we entered, was almost pitch dark, and there were very glim lights at any place. So I said, where are the babies, where are the patients? Then I went closer and I saw that there was a baby in every cot or incubator. So they say that here the protocol is that they keep the environment dark so that the children, the babies, the infants, they can sleep. You need not to keep them awake through, hard, fast lights and so on. And then they have spotlights over every bed. And if the nurse has to conduct a procedure, then she can put it on, do the procedure, and then put it off. So this is how things were working. And there I saw against one baby, one nurse. This is how they were working. And here I can share with you that I was a brigadier back in about 2008. And in military hospital, MH Rawalpindi, which is our prime pediatric center, the nursery, which comprised of about 80 beds or cots or incubators, what you will say, they had only 2 nurses. So how can you, imagine that she takes the vitals of every kid and every neonate, conducts the treatment, and you know it that every patient or every baby admitted into a nursery is usually on injectables. So it is humanly not possible for those 2 nurses to manage those 50 babies or infants. With 2.8 doctors per 1,000 compared with an average of 3.5 doctors across Organization of Economic Cooperation. This is an organization which has about 35 members, all advanced countries from Europe and USA. So in these, the standard is to have 2.8 doctors per 1,000, whereas in UK there are, 3.5 doctors per 1,000, whereas in UK there are 2.8 doctors. The shortfall in the number of GPs is so serious that cannot be filled at all. So this is a scenario again which has further complicated after COVID. You may be in knowledge of that in UK and in USA. The nurses, the trained nurses, they have stopped joining the service. They are sitting at home. The doctors, they have declined to work in the hospitals. Why? Because they say that it is a one-time life that we have got. Why to sacrifice this life against an epidemic and for that salary which you can manage by other resources? And the other thing is that these advanced countries, whether it is UK, Europe or USA, they have been compensating all their employees during the COVID. Every lorry driver used to get about $2,000 to $3,000 per month. So what happened? That once they kept on getting this money for 6 months to 1 year, they thought that why to rub off yourself in trucks and have long distances, put yourself in danger. Better to suffice on these $2,000 to $3,000 and sit at home. So that was the reason of shortage of fuel in UK and Europe, that the logistics all over the world that failed. And that is the reason that the cost of logistics all over the world increased. And that is one of the main reasons of inflation all over the world. Some of the key facts, specifically about Pakistan, that Pakistan faces a critical shortage of healthcare workers, significant shortage of nurses, physicians, and so on. And this nurse to doctor gap is further widening because we are concentrating more on producing doctors than nurses. I was part of a meeting in the Planning Commission where I was deputed by the Higher Education Commission. And there it was being discussed that in Pakistan, we have a requirement of 900,000 nurses. And can you imagine how many we have? 150,000. So 750,000 nurses we are short. And this is a, investment that if we do in our human resource capital, there is a huge demand in UK and Europe and America and everywhere. So this is what we need to work on. If we talk about human resource management, we have to see what are the challenges and what we need to work on. Only about 5% of nurses have an education at the level of BSc or above. The old system of diploma that was still working on, although in the army, what we have done is that we have about now 6 colleges of nursing. where the basic BSc nursing generic program is being working, and they graduate after about 4 to 5 years, and then they further specialize in different specialties, about 9 or 10 of them, including anesthesia, intensive care, nephrology, peds, and neonatology, and so on. A significant number of female physicians do not get into labor force that I already talked about. Out-migration accounts for a higher number of experienced professionals. This is a trend, in most of the bigger medical college, public medical college. We talk about Allama Iqbal, we talk about King Edward Medical Colleges. I talked to the Vice Chancellor of King Edward Medical College, and we were discussing that what is the number of absentees, say in final year class. So there it came to my knowledge that most of the students, they do attend, but the absentees are generally those who are, preparing for their steps. They haven't qualified the final profession, but they are now working parallelly for the steps. And my daughter recently got married, and my son-in-law is working in New York. And he told me that after graduating from King Edward, he quickly qualified the USMLE, and within 3 months of starting his house job, he got a placement there and he went there. So this is the drain, in the investment in the capital that we are facing now. And same is the trend everywhere. Now even the nurses, they are thinking about that, because there are organizations in UK and other places who are approaching here our healthcare industry. And they are offering nurses that if you are trained, we guarantee you a job in USA, in UK, say about 3,000 to 4,000 pounds per month. Why? Because that intermediate recruiting agency gets 500 pounds for every nurse that they recruit from here and then sent to NHS. So this is the situation that we are training our human resource, and most of them, they are going out. The flight of brains. 19,910 lady health visitors and 87,820 lady health workers have ensured some basic prevention. I was part of that planning or all these things, the issues that came up with the lady health worker. At one time, their salaries were stopped. You must have seen them. They were, doing agitation or processions in outside Parliament because their wages were not being given. At that time, I told the Ministry of Health that even if they're not working at their place, please keep on paying them, because they are sort of a trained human resource worker. Even if they are sitting in their villages, even if they are not doing the duties at the government expense, even if they are doing private practice, taking fee from this other villagers, even then that is acceptable because they are saving human lives. So that is very, very important that these lower tier healthcare workers which are trained, they are the stopgap measure for the drain or absent of skilled workers. The physician, dentists, nurses, LHVs, and so on, they are being monitored by the different regulatory authorities, whether it is the Pakistan Medical Council, Pharmacy Council, and now we have the Allied Health Council also. The challenges in healthcare industry, again, as I say, the turnover. You will be surprised, or it may be to your knowledge. In this country, we have about now more than 170 medical colleges. About 105 of them are private medical colleges. Now, what has happened is that during the process of establishment of these private medical colleges, the basic challenge is to have the basic sciences faculty. So what they did was that they approached the faculty of public medical colleges. They hired them at exuberant rates and salaries. So minimum salary that they are getting now is about 4 lakh to even 7 lakhs in newly established colleges. Whereas from the government side, they get hardly 150,000 or 200,000 rupees. So that is one of the reasons that this trained human resource, which was supposed to train the students of public medical colleges, They have taken long leaves from there, 2 years, 3 years, civil में आराम से मिल जाती है. There's no concept in the army. So they are now working in the private medical colleges, whereas they are public employees also. Employee burnout, again, as I mentioned, that if you overburden your doctors, nurses with a workload, then there's going to be a burnout, and there are going to be near miss or complications with the patients, or the patient satisfaction that is going to suffer. Training and development is, of course. If you talk about the human resource management, you must have heard about two terminologies, that is the performance management and the other is performance appraisal. So briefly, I would say that performance appraisal is that how you monitor and gauge the performance of every employee. As I mentioned, the number of duties performed, number of surgeries performed, and so on, the feedback that you get from the patients, these are some of the things. But performance management is basically one thing, and that is once an employee comes to your organization, how you carry him along. You interact with him, see his capability, his or her capabilities, find the training needs, develop them, train them for the new responsibilities, and then keep on interacting with them. What are the challenges that they are facing or the problems they are facing in performance, in optimum delivery? So that is the challenges or the hurdles that you keep on removing, facilitating the employee to deliver the best to their abilities. And that ultimately helps in meeting the goals and objectives of the organization that you're doing. So basically, performance management is how you connect the individual performance with the goals and objectives of the organization. कि हर इंडिविजुअल को साथ लेके चलना, उससे बार बार इंटरेक्ट करना, and that is the reason in good organization they have now established counseling cells where any employee who has any problem, whether it is harassment, whether it is salary problems, whether it is domestic problems, they can just walk in, have a consultation, and then they can find answers and support from the organization to address their personal or domestic issues. They said that there are 6 key steps that you need to take in performance management: set out duties and responsibility, ensure that the right person is hired, ensure that the employee knows the role and requirements, have monthly formal performance meeting, address issues of non-performance, implement structure improvement plans. Now, this luxury is available only in the private organizations. In the public organizations, if some of you is appointed as a MS of a hospital, do you have the authority to fire all the previous employees and hire new employees? Whatever the team has been given to you by the ministry, by the concerned department, you have to work with them. So that is the issue, that is the challenge. So for that matter, as I mentioned, human resource management cycle to be performed in a public institution is a very hard uphill task. Again, these are almost same things, that you document all the performance, have a regular appraisal design with them, ensure integrity of the system. ये बड़ा important है, the organizational behavior. This is what we learned in the army also, that once you are sitting in the, say, a tea room where you are having a break after your clinic, the male and the female sitting together, then you need to be very cautious that the way you are sitting, the way you are dressed, whatever comments you utter, that is going to make a lot of difference, and that may be taken as personal comments by a few of the employees. So that is very important, that we need to teach our organization the organizational behavior, that this is what is good here, this is what is wrong here. That is very important. I have seen in different organizations that my son, he is working in Toronto, in Canada, and he is working in one of the top 4 consulting companies in the world, that is Accenture. And he shared with me that he switched over job this January. And he said that the best thing that I found in this company was that when I asked for a place of prayers, they showed me that they have a proper prayer room where they have a place for the wuzu also for the Muslims. So that is very important. And the university that he was studying in, that had one place, the religious place, where they had the synagogue, they had the mosque, they had the church. So all things, and even for the Hindus, there was a place for worship. So this is important. This is organizational behavior, that you respect the race, religion, gender, or of every employee that you have in your organization. Somehow we are very callous on that. Being a Muslim, this is the first thing that we are taught in our religion that we need to practice. Performance evaluation then again is usually rated according to the excellent, good, or acceptable, unsatisfactory scale. फौज में भी एक ACR annual confidential report system है, and they say that you work the whole year for that one report. In human resource management, this is not the concept that you gauge the performance or performance appraisal is done after 1 year. It is done usually every month, if not every week, or at least every quarter. But in the army, again, is the same old system going on. As I mentioned, the components of human resource management. First one is recruiting. You will be surprised that the doctor or the nurse that we recruit in the army is not at the disposal of the Army Medical Corps head. It is at the disposal of another organization, which is the Personnel Administration Directorate, where usually this portfolio is headed by an infantry general. And he is, recruiting human resource for whether they are engineers, whether they are technicians, whether they are doctors, whether they are nurses, whether they are infantry soldiers, whether they are armored corps personnel. So that is what I say, that in the public organization, the human resource management system is altogether different. It is time old. They say that we are good with it, we are very perfect, so let them enjoy that. But generally, the modern human resource management system, that is under one roof, and that has to induct and recruit individuals, train them, develop them, gauge their performance, and then even hire and fire them. And then even the payroll is generated by the HR department. Whereas in the public sector, it is generated by the finance department. If you talk about the army, it is neither generated by the Surgeon General nor by anybody else. It is generated by the Pay, Pension and Regulation Directorate. So that directly comes into your account. So these are different systems that are working along. Employee must have a thorough knowledge of the performance management system. This is how you plan that, how you are going to work with it. Set these SMART goals and objectives, what results you are expecting from them, what behavior you expect from them, and what are the development plans for that individual. ये इवन सिविल में या आर्मी में भी नहीं होता कि आर्मी में आके आपको ये बताया जाए कि जी after so many years you just learn from your peers. When I'll be getting a chance to specialize, when I'll be getting a chance, to go on a secondment abroad or something of that sort. So this, the objectives should be, SMART, that is specific, measurable, attainable, and realistic and timely. वो कहते हैं ना कि अल्लाह ताला भी उतना बोझ डालता है जितना आदमी बर्दाश्त कर सके. So the human resource management system should also be realistic, that what we are expecting from the employee, but usually what we expect is, this, that we expect the employee to be working from both hands and both feet. I'll not go into the further details. Shared responsibility, manager's responsibility. I've already touched these things to some extent. These are very important performance management skills for the leaders, because you are, I believe most of you are at your seniority and service where you are usually a manager or a senior manager role. So these things are very important. Communication with your employees, their coaching, giving them feedback, empathy. ये किसी का कभी जाके कंधा थपकना, किसी की वाइफ बीमार है उसको जाके विजिट कर लेना and helping him. Anything that we can do for your home, where are your kids, who is making the food, how things are going on, and similarly so on. If somebody has a emergency, any close family relative has died, they are going to travel, just ask them, do you have money to travel for your fuel and anything? Can I help you? I think these small things can make a lot of difference. Communication is very important. लोग मुझे कहते हैं कि जी आपकी सक्सेस की क्या वजह है, तो मैं कहता हूँ एक पहली बात तो कि अल्लाह का करम है, सीधी बात. Second thing is that I have been good in communicating with everybody. Even as a surgeon, if a soldier approached me for anything, I never snubbed anybody. What to talk of a captain or a major, कि उसको मैं कहूँ कि मेरे अंडर जो फ्लॉम ब्रिगेडियर है या जनरल है, talk to him and then talk to me. I listen to everybody. कितने लोग हैं जो आपको कॉल करते हैं इस तरीके से? बहुत थोड़े होंगे. But if you start listening to people and solving their problems, the system is set right. Why people directly approach you? Because the system doesn't allow them to approach them. Those who are managing the system, they are shunning them away and they are doing injustice to that person. Or at least if he's wrong, they don't have the courage to tell him that you are wrong. They are not listening to them. So that is one important thing that if you have a good communication system, you can do wonders. In the hospital, there are many people, patients, attendants, after discharge from hospital or other way, they would like to visit you. So keep your doors open. Listen to them. They would talk to you for hardly 3 to 4 minutes. And they would complain for something. You listen to them patiently. And once you listen to them and you start telling them or giving your side of explanation, with your patient listening to them for those few minutes, this is my observation. Many of them said that you have listened to us. This is enough for us. Whether things are put right or not, we are thankful to you. तो बहुत सारे मसले सिर्फ बात सुनने से ही हल हो जाते हैं, लेकिन हम सुनते नहीं हैं, इसीलिए वो मसले बॉयल अप होते रहते हैं and then there is an explosion somewhere and then there are inquiries and so on. Similarly, if there is a death in the ward or somewhere, just approach them. Give a pat on the shoulder that, we have been trying, but this is something that the outcome is not in our hands. So they would then come to you and thank you that your doctors have been doing, the best to their abilities, but it was God's will that our patient didn't survive. But if you So this is, I've already talked about that in the public sector, there is no formal HR system. Managers have no choice in selection. There are tedious governmental procedures for award and reward. एक बंदे को आप अपनी organization से निकाल नहीं सकते हैं. Especially in the civil side, they go to the court and then he comes back after 4 or 5 years, get all the previous salary and so on. The politicized governmental institutions. About 15 years back, I was told by the Punjab Public Service Commission that they have stopped recruiting regular doctors because of the interference by the political governments. कि जी मेरा डॉक्टर रख लें, मेरा बंदा रख लें, उस वजह से they have stopped this. Poor governance again, that is, and then rampant corruption. These are some of the very critical issues that we are facing in our system. That's it.
Thank you very much.
Any questions? I'm sure after this 1 hour long talk, there will be no questions. But if there are any, yes, please.
Thank you.
There was one case that was started in 1984. At that time, Abdul Batul very well, he was major and retired from army as a RP hospital as a major general. The case was this, that your institution has to have physicians, nutritionists, and pharmacists as a commissioned officer in the uniform. As far as my information is concerned, the physicians and nutritionists they have joined the army as a commissioned officer, but the case of pharmacists, can you throw some light on it?
Thank you.
What is the reason that has been issued? I started my career in 1984. I finished my career 6 months before. So still the case is on.
Very much.
The problem is that the other two categories were involved. The pharmacists were also, it was approved, but the problem is that while approving these three categories of, healthcare workers, their service structure was not outlined. Because if a statistician joins the army, then they used to say that what is our career progression after 5 years, after 10 years, what promotion we would be getting. And same was the case with pharmacists and dietitians and so on. So that is still, working on, because in the army, they generally say that if the doctor can do a job, why you are hiring that person for that matter. So these are one of the main reasons. And secondly, that now in the army, previously, the dispenser class who are trained in, dealing with the medicine and all that, they think that they are doing a good job, but I think still the pharmacist cannot be replaced by any of the skilled worker or anything.
Thank you. Thank you. Ladies and gentlemen, just I want to add one thing about General Asukera. As everybody knows, it's a very difficult to get a promotion in Army Corps, Medical Corps. There are few, आपको पता है मैं बहुत से मेडिकल में फील्ड के अंदर आर्मी के अंदर सिर्फ चंद एक लोग हैं 3 या 4 बंदे हैं जो जनरल रैंक तक पहुंचे उनमें से वन ऑफ देम जनरल आसुकेरा जनरल निगार का नाम सबने सुना हुआ है ये सेकंड ये 4 और भी 2 3 4 बंदे और हैं बाकी मोस्टली आपने देखा ज्यादातर वो ब्रिगेडियर तक या कर्नल तक होकर रिटायर हो जाते हैं तो it's a pleasure. Now I want to take only 3 or 4 questions. Can we want to start the next sessions? जी, आप सब वो पूछना चाह रहे हैं कुछ?
आपका क्वेश्चन था रेडियो से कोई?
Here days ओ माइक चलन दे दे. One by one ले ले 3
क्वेश्चन. सर मेरा क्वेश्चन ये है कि why you have classification board after FCPS part
2? Basically, it's again as I said that वो आईने नौ से डरना तर्जे कोहन पे अड़ना फौज अपना वो सिस्टम चला रही है दूसरा एक रीजन ये हुई है कि since I have been a part of this and I have been dealing with the training of army for many years, I would say from the rank of major to brigadier. Previously in the army, the specialization system was only 1 year training in that clinical specialty, and we used to call it grading course. Then subsequently came in the fellowship program, and then this grading course was turned into 2 years course. And at that time, even the fellowship was for 2 years. Gradually now, the fellowship program that has gone from minimum 4 years to 5, 7 years. But the grading course is now basically an entry into the part 2 program. The first 2 years, they are still calling them a grading course. In the army, they have a scoring system to gauge the performance. मैंने performance appraisal की बात की. To gauge the performance appraisal of every doctor, they have a system that they call it as OEI, Officers Efficiency Index. Now this is divided into further 3-4 components. That is the annual reports, performance reports that you earn during your service. About 60% weightage is given to that. The outstanding report would be, say, given 10 marks. Well above average would be given 7.5, and average report above average would be about 5 marks, so on. Similarly, for every course that you do in the army, that carries a weightage, because they say that ensures that whatever course you do in the army, you are serious in doing that, because that would matter in your future career progression. So that is good for other arms and services. But for this fellowship program, this is conducted under the College of Physicians and Surgeons. And we know it is a very structured and flagship program in the country, and we should trust that. But they are still, continuing with the first 2 year service as a grading course, and then they take a test exam of that and then grade the individual for that. And you will be surprised that anybody who gets a B grade in that, he hardly gets a chance, to get promoted beyond colonel, right? And you need to have a minimum B+ grade. So what does that have to do with the fellowship program? So you are right. It's just the army old way of doing and carrying on with the things. Second thing is that even after qualifying FCPS, once the main, higher level regulatory or the controlling authority in the country has judged the individual that he is fit to practice that specialty, who are we now to further endorse that he? The army already gives him the status, him or her, as a specialist in that specialty. But why classification? Because a classified specialist in the army is generally the ultimate authority to write opinions, whether they want to declare anybody unfit for the army. Because there is a tendency, some people, would like to leave the army with all the skills that army has equipped them. They find a better career for them outside. So that is the reason that they make sure that only classified specialist writes that opinion. So that is one reason. Second thing is that 5-10 years ago, what happened was that first 2 years training in fellowship, then the individuals were sent to the hard area for 2 years, then brought back again for the 3rd and 4th year training. So that was done away with. Because of those few individuals, they were not very strong, whether he's a surgeon, his surgical skills, of course, were not that strong as compared to the one who has done in continuity. So these are few reasons that it is still continuing.
Thank you. The next question.
Sir, Dr. Ahmed, sir, mashallah, it was a great presentation on HR. But I wish you can guide us regarding HR in public sector as well. As you said that there is a great resistance to HR management system. So my question is, as a Surgeon General, you are on a leading post in Army Medical Corps, and of course on a decisive post as well as. What efforts you put that there is change in the system and HR management system can be incorporated in Army? As you see, most of our friends and fellows, they are the consultant specialists, they got retired as a colonel. So it means that you are losing very capable and very experienced doctors, and then again hiring new doctors, and again then trying to train them. So do you think it's not that fair? मतलब डॉक्टर्स के साथ थोड़ी एक्सेप्शन हो सकती है जो होनी चाहिए.
You are right, it's a good question. जैसे मैंने कहा कि जो आर्मी में the HR system is not under one roof, and as I mentioned that as a Surgeon General of Pakistan Army, you don't have the liberty to enroll and recruit individuals. I mean, I used to chair many boards for selection of doctors for induction into the army, but ultimately that was being conducted by another branch, which is non-medical. Similarly, the posting and transfer, ये जो reward or award and reward का system है, where to place one individual, where to place the other individual. Again, this is not in the hand of surgeon. Army has its own system. That is because, and I think उसकी अपनी strengths है. इस वक्त मुल्क में हम अभी तक, although with the recent scenario, फौज फिर थोड़ा सा बदनाम हो गई है, लेकिन generally we place army at a very high pedestal because army has, salvaged countries in many disasters and so on and so forth. So why? Because the army is a national army. यहाँ पे वो नहीं है कि ये सिंधी है तो जिस तरह हेल्थ केयर जो इंफ्रास्ट्रक्चर है, what we have done with the 18th amendment, that is the biggest disaster that has happened to the healthcare, because it has gone into the hands of the provinces and they don't have the capability and the capacity to improve it. So that is the main thing. I have attended many meetings of Ministry of Health and different forums. I was surprised that all those meetings were conducted by international donors. अगर वो न्यूट्रिशन पे है, किसी चीज पे भी है, तो इंटरनेशनल डोनर्स वो कर रहे हैं, होटल में अरेंज कर रहे हैं, सारा खर्चा उनका है, मिनिस्ट्री का सिर्फ नाम है आगे. मिनिस्ट्री के पास रिसोर्सेज हैं, दे कैन डू इट, बट वो शुरू से हमने एक अज्यूम कर लिया है कि ये लूली लंगड़ी इसी तरह चलेंगी, हेल्थ मिनिस्ट्री, इसको बाहर की डोनेशन से ही हमने चलाना है, इसलिए हमने उसका बजट भी कम रखा हुआ है. एंड दैट इज द रीजन कि ये जो हमारा पब्लिक सेक्टर परफॉर्म नहीं किया तो प्राइवेट सेक्टर आगे आया, क्योंकि लोगों की हेल्थ केयर नीड्स तो हैं, यू हैव टू एड्रेस देम. सो द प्राइवेट सेक्टर जाम्ड हिम. बट व्हाट हैपेंड, द प्राइवेट सेक्टर is addressing that healthcare needs, but at what cost? With every healthcare challenge, so many, about 20% population goes below the poverty line every year because of the healthcare challenges. And that is because of our system that the individuals pay out of their pocket. So as a surgeon, I tried for all these things. I have been fighting at different forums. लेकिन फौज अपना एक कहती है कि नहीं, हमारा एक डिसिप्लिन है, हमारा एक सिस्टम है. अगर Balochistan, for example, we have hardly any representation of any nurse from Balochistan. So if you have to send, nurses to work in 5 CMHs in Balochistan, Zob, Loralai, Sibbi, Huzdar, and Quetta, in these hospitals, if you don't have any local nurse, then any nurse from Mardan, from Sargodha, she has to go there. So that is the reason that the army has a system of posting, and they call it zones. This is now the Balochistan or Sindh zone. This is the northern zone. This is the Punjab zone. This is the KP zone. So that is the main reason that they keep on rotating them. But why I say your question is very interesting, that we doctors, some of the very super specialists, very talented specialists, they took it to their heart. उन्होंने कहा जी हमारा इस्तेकाक मजरू हो गया. I was the best. I was the first vascular surgeon. I was the first plastic surgeon in the army. मुझे आपने पिंडी से उठा के खारियां पोस्ट कर दिया, तो ये मेरे साथ जाती हुई है, तो मैं नौकरी नहीं करता, वो छोड़ के चला गया. I'll not name them. That fellow is now sitting in Shifa International. Since that time, he was a colonel, and his profile was so strong that he was a short general. ठीक है, लेकिन वो उस जज्बातीपन में, वो 2 साल के लिए उसने जाना था, उसके बाद उसने दोबारा पिंडी आना था, लेकिन वो छोड़ के चला गया. अब वो एक प्राइवेट प्रोफेसर है, पैसे कमा रहा है, ठीक है, लेकिन आर्मी में होता है तो प्रोफेसर ही होता है, लेकिन एक जर्नल भी होता है साथ. तो वो मैं कहता हूँ थोड़ा सा सब्र के साथ इस सिस्टम के साथ आप चलें, इट रिवॉर्ड्स यू ऑल्सो. quite a lot.
Thank you, General Asif Square. Thank you very much.
Sir, there is a question, last one.
No, sorry, I don't want to take questions.
Okay, just last question, please.
Sir, you already told in the your presentation that there are a lot of the females now in the medical colleges and the pharmacy, also in the MLT as a nurses and also from the human diet and nutrition. But when it comes about the job, that the most of the girls just leave the job. But there are some issues that should be addressed. For example, there is no female toilets in the most of the departments, in the most of the institutes, and there is no daycare centers, so they have to leave their children at home. There is usually the maternity leave of the 90 days, and after there is a complication, they are also said, okay, you are irresponsible. If most of the women have the more regular and even take the less leaves. But whenever they take leave, they say, okay, you have the kids and you are like that. So if these problems wouldn't be solved, then no female will work as a professionally. Don't you think that these are the major issues, or how can we solve it?
These are the issues because I am father of two daughters. One is a doctor, the other is a dental surgeon. I know them. My elder daughter, she recently qualified FCPS pulmonology part 2, and she's not working. इसी वजह से जो आप प्रॉब्लम्स बता रही हैं. She has two daughters. उसका मियाँ सर्जन बन रहा है आर्मी में, वो मेजर है CMH लाहौर में. तो she says that once they get their new posting, वहाँ जाके देखेगी हालात कि कैसे मैंने काम करना है. And this is exactly what I discussed with Vice Chancellor Nams also, the Medical University of the Army. I told him that we need to seriously work on how to engage our female workers, whether doctors, nurses, or paramedics, how we need to create an environment for them. And being a vice chancellor, I told him that every doctor, 70% girls, as I mentioned, graduating every year from medical colleges. इनमें से 50% घर बैठ जाती हैं. जो जॉब करती हैं उनमें से हर कोई फेलोशिप नहीं कर सकता. It's a very tough training and difficult job with looking after your kids and so this is what I told him, that we need to start university qualification, intermediate or higher level at the universities where they can enter without this, fellowship, part 1 exam and so on. We need to create a stream for them so that our healthcare industry keeps on growing and we have all these requirement of specialties met, whatever our present and future needs are. तो आप बिल्कुल ये ठीक कह रही हैं कि ये सिविल में, मिलिट्री में, दोनों तरफ ये चैलेंजेस हैं और हमें इसको आगे बढ़ के अभी से फेस करना चाहिए. आंखें बंद करने से काम नहीं होगा.
Thank you very much, General Asif Skera. He's a very busy man and I'm highly grateful to give the time. Ladies and gentlemen, now we move to the next session, session number 4. The topic of session 4, component of hospital rapid appraisal tool. But unfortunately, Dr. Minaj cannot come here. He's stuck in Ahmedabad due to rains. Hopefully he will come tomorrow and deliver the lecture. Now we replace this lecture with a drug management cycle. Now the speaker of this topic is here, Dr. Abdul Rashid. He is an ex-director of pharmacy divisions in Darab Drug Regulatory Authority, Pakistan, and he did a PhD in pharmacy more than 30 years ago, and he had a 30-year post-PhD experience. And he's a well-renowned pharmacist, and now he's a consultant advisor in health at Comstech. I would like to request Dr. Abdul Rashid to deliver the lectures on drug management cycles. Thank you.
मेरी ये खुशी की बात है कि इस आफ्टरनून में भी तालियां बज रही हैं. आप लोग you have taken the lunch, this afternoon time, and also the last presentation, so I can assess what is your condition. So I will not take much time because, and also I have to talk about the drugs, about medicines. और आपको पता है मैं डॉक्टर साहब की तरह मैं उर्दू में भी नेशनल लैंग्वेज में बात करूंगा. आप पाकिस्तान में दवाइयाँ ऐसे खाते हैं जैसे पकोड़े, समोसे, बिस्किट्स और चॉकलेट्स होती हैं, तो ये आपके लिए कोई नई बात नहीं होगी। इंशाल्लाह मैं आपको बोर नहीं होने दूंगा और मैं क्विकली आप गो थ्रू करूंगा, ये चीजें आप सारी जानते हैं। This is the plan about the drug management cycle, but as per Pakistani law we call it drugs, but as per Drug Regulatory Authority Act 2012, which I have made alhamdulillah as a technical person, we call it therapeutic goods, and therapeutic goods included, except food, all the things. I give the examples: the human medicines, the veterinary medicines, biological vaccines, sera, medical devices, homeopathic, herbal, biochemic, Chinese medicines, blood and blood products, medicated cosmetics, they all are therapeutic goods. या आप उसको उर्दू में जो दवाएं कहते हैं या therapeutic goods कहें या आप drugs कहें, जो भी आपकी मर्जी है. The first thing is when you want to purchase the medicines either at the public health hospitals, at a private hospital, or for Hajj medical missions, which I purchased 11 years as the chief pharmacist for Hajj medical missions, or any nurse for any nursing home, you have to plan what you are going to purchase. The second thing is procurement. As per Pakistani law, you have to purchase the medicines. Pakistan Procurement Regulatory Authority, that is PEPRA rules. All rules are mentioned in this agency's act. So you cannot deviate during purchase of medicines. I will discuss in detail because next presentation will be the same. After purchasing the medicine, you have to receive the medicine and store in either the medical stores or the hospitals or the distribution level or whatsoever you have the premises. You have to store it. In the hospital, I come to hospital because this is hospital management training course. In the hospital, you have to distribute it either to the OPD or the indoors or the operation theater. You know better than me. And after that, after distribution, this is daily practice. You know, you have daily these things. And the final, when you at the end of the year, you have to review that in the last year what we have purchased. Either the quantity of medicine was correct, either we missed any medicine during purchasement. You have to review the procurement plan. This is the whole cycle. And during the purchase, during the procurement of the medicines, you have to see the different, the chief executive of the organization, the financial assistant. You know, in Pakistan, we spend 0.7% on the whole sector. What about the percentage of medicines for whole country and for one hospital? So this is just like peanuts. Mungfali ke barabar hai 0.7% for the whole GDP. Mostly the private sector is coming into Pakistani healthcare system. The public sector is not working so efficiently. So the investors, the money makers, they are earning money, they are coming to private sector. In Pakistan, we have Shafa International, we have Aga Khan Hospital, we have Quaid-e-Azam, we have Maroof Hospital, and many others. They are earned in clinical trials more than 20 billion rupees Pakistan. So the selection of medicine is very important. You have to select the medicine for a whole year. So this is selection of the medicine very important. During Hajj, if we miss one medicine, we suffer whole Hajj medical mission during the year. Dr. Masood Ghani, he was there, maybe he has gone. So you have to, during the selection of medicine, during the procurement of medicine, selection of the medicines and about this medicine is very important. If you have one dosage form, either capsule, tablets, injectable, passage vaginal, ointment creams, and any other dosage form, you have the strength to 125 milligram to 250 milligram, 500 milligram, 1000 milligram, or any other dosage form, different dosage form. If you miss one suspension for children, you will suffer all the year. So selection of the medicine is very important. But unfortunately, what I see in Pakistan, because I remain in Ministry of Health, I remain a member of the 3 years for Ministry of Health Procurement Committee. We remain a member of polio or EPA. We have purchased 50 billion Pakistani rupees medicine in one consignment. I remain also a member of the procurement in Drug Regulatory Authority Pakistan. So if we miss one medicine, so you will lose for whole year. Communication is very important. When you purchase the medicine, you know who is the distributor, who is the manufacturer, who is importing the medicine. In your hospital, this is very, very important that you have a strong communication collaboration with those people which sell the medicine, which distribute the medicine, which give the medicines to you. Communication is very, very important. Otherwise, you don't know this from where this medicine or medical devices or herbal medicine, nutraceutical we have to purchase. Participation is very important. You know this one. Prescribing trends. This is very, very important. I must say. You know, every doctor, early healthcare professional in every hospitals, they have different trends. Some I don't want to into details. डॉक्टर शहजाद साहब कहते हैं कि कुछ ऐसे लोग होते हैं कि वो कहते हैं स्पेशली इसी कंपनी की ओर they recommend that the medicine should be from the medicine should be from GSK. It is not essential that on the recommendation of the one prescriber or two prescriber you have to purchase. You have to see the prescribing trend, but not on the individual, but on cumulative basis. This is very important. Otherwise, you will suffer whole the years. Local purchase, majority is purchased in bulk, but some of the medicines you need on daily basis. That is, you have to select one pharmacy from where you can purchase. But we have seen in Pakistani system, healthcare system, that they earn million and billion now rupees from local purchase, and they purchase the medicine at a high cost. This should be prohibited in Pakistan. We are the healthcare providers who all are involved with them. So we should prohibit these things that which are going to be done in Pakistan in local purchase. The determined quantities needed. This I already mentioned. Dr. Shahzad always said the minimum is the optimum. So we should go on this formula. जितनी कम दवाइयां खरीदेंगे, जितने कम दवाइयां इस्तेमाल करेंगे, उतने ही कम बीमार होंगे. जितनी दवाइयां ज्यादा इस्तेमाल करेंगे, उतने ही ज्यादा बीमार होंगे. Because हम misuse बहुत ज्यादा करते हैं. Tools available. Some medicine are there, the life-saving. They must be purchased wherever, in which premises you are, in which health setting you are. Essential medicines. There is no any definition of essential medicine as per WHO and other international dictionaries and essentials. You must buy which you need, essential medicines. And don't purchase those medicines which are not essential and save the budget. So the main thing is that you must purchase the life-saving medicines and you buy which is essential. Otherwise, there is no need. Don't go on any recommendation or the preference. During purchase of medicines, you have to relate what is the quality of the medicines. This is my subject. I remain as my colleagues are here, Dr. Shahid, and I remain as a chairman quality control for 8 years. पाकिस्तानी में आप हेल्थ केयर प्रोफेशनल, अगर आप लोग ये कहते हैं कि पाकिस्तान में ये मेडिसिन काम नहीं करते हैं, ये इस कंपनी की दवाइयाँ अच्छी हैं, इस दवाई कंपनी जो असर नहीं करती, तो मैं उसका रिस्पॉन्सिबल हूँ. और इस सेशन के बाद, क्योंकि मैं देख रहा हूँ, मैं टाइम में कभी भी ख्याल रखूंगा, क्योंकि आप लोग भी आफ्टरनून में यहाँ थके हुए हैं, तो इस सेशन के बाद जो क्वेश्चन होगा मैं आपको जवाब दूंगा. 8 साल में चेयरमैन क्वालिटी कंट्रोल रहा हूँ, तो यू हैव टू सी द क्वालिटी ऑफ मेडिसिन. बट कीप इन माइंड those medicines, those manufacturers which are approved, which are licensed, which are approved, are given registration by the Drug Regulatory Authority of Pakistan. These are the quality medicines. But if you have any observation, please write a letter to your CEO of the Drug Regulatory Authority of Pakistan. Give WhatsApp to Drug Regulatory Authority of Pakistan about if you have any observation on the quality of medicines. On-site quality control arrangements. When we see this is very. I must say this slide is about pre-qualification of the manufacturers. KP have very good system of the pre-qualification of the pharma industry. They inspect every premises, then they qualify them. This should be done, but mostly in small organization. I must say in railway hospital, Wabda hospital, and other, they don't inspect the premises of manufacturing units. But KP, they have the very strong system. In Punjab, I have not very less. They've seen this. They inspect the premises. They inspect the pharmaceutical units, But KP, they have very good system for inspection of the pharmaceutical units. We should physically inspect and pre-qualify the firm. There are 650 pharma industry in Pakistan. I remain as a chairman Central Licensing Board. Pakistan की जितनी pharma industry है, मैं उसको लाइसेंस देता रहा हूँ, मैं उसकी इंस्पेक्शन करता रहा हूँ, मैं उस इदारे का हेड रहा हूँ, उस डिवीजन का हेड रहा हूँ. तो ये सारी चीजें जो होती हैं, आप उसमें आर्मी के in inspection, the army personnel, in service, major general, retired major general, professor of surgery, professor of medicine, they all expert pharmacology, they remain our team of inspections. So any medicines which come to the market, we say that this is quality medicines. And capacity, you must see the capacity of the pharma industry. If you have to purchase 4 lakh bottles of paracetamol suspension, and that industry cannot give you within 15 days. So you have to see that whether this is the capacity of the pharma unit or not. This is very, very important, because in Lady Atharka programs, we have in crores, we have quantity, we have a large quantity of the in units of the medicines. Some of the firms, they don't have the manufacturing capacity, but they come into tender documents. Suitably qualified, this trade references, also we have to see the different business references that about the organizations, and also the experience of the customer. जो हमारा customer कौन होता है? Patient होता है. Customer in hospital is a patient. Customer of industry, medical stores, healthcare professionals, उनका जो customer होता है, and you know that is a patient. The patient safety is very important. WHO is giving priority to the patient safety. Before it was not given the priority. Patient was not giving the priority in the hospital. But WHO from 2021 to 2030, they give the priority to the patient safety. Also, they either the supplier, they can give the medicines at a specific time or not. This should also be considered. Otherwise, sometimes they have the bulk quantity given the order by you, but he have to import large active pharmaceutical material, but it's not possible for him to supply that medicines after importing the active pharmaceutical ingredient. A routine criteria is that you have to physically, when you give the tender document, this is open, PEPRA rules are very open. I think the next slide will come. You have to see which medicine is costly. If you purchasing the paracetamol, you have to see the cost. I tell you, when we purchase the Calpol manufactured by Pakistani firm, what is the product of GSK? Calpol is manufactured by GSK, but Panadol is manufactured by Pakistani company. But the product is both of GSK. The patient prefer the Panadol, not Calpol. Calpol is manufactured by multinational company GSK, but Panadol is manufactured by Pakistani company, which Pakistani company, this is Pharmatech or any other name, and that is the product of the also GSK. So you have to consider all these things. Also the service liability of the suppliers, and also the promised delivery date, whether he can be able to deliver that one, and also the product which is going to be supplied by manufacturer, it is as per specification. देखिए जो tender document में specification दी जाती है, every supplier, they have every manufacturer, distributor, authorized dealer is bound to supply the medicines as per specification. He cannot change. Also, there is some special criteria. For example, narcotics, you have to obey the rules of narcotics. Ministry of Health, Drug Regulatory Authority, they have no more power to give the authorization for use of narcotics in the hospital. There is only anti-narcotic force. We DRAP have meetings with the anti-narcotic force and allocate the quota to the manufacturer, and that quota is manufactured in the pharma industry and then supplied to the different hospitals. We feel even the consumption in civil hospitals, in public hospital, in private hospital, even AFSC Pindi and other hospitals, that which quantity have been, which was allowed, which quantity has been utilized, which is the balance. We all see as a special product for that. Also, some of the donors, they give the restrictions to the when they fund. So we have to consider all these things. लॉजिस्टिक साइकिल ये मैंने पहले ही आपको बता दिया है, मैं उसमें डिटेल में नहीं जाऊंगा। प्लान में क्या है, कई चीजें होंगी कि उसमें रेपिटेशन होगी, तो मैं उसमें क्विकली आगे जाऊंगा ताकि आप लोगों का टाइम जो है बचा सको। जब आप प्लान करते हैं तो रिसोर्सेज, फंड्स, विच इज वेरी इंपॉर्टेंट थिंग्स, आपकी प्रायोरिटी क्या है, आपके हॉस्पिटल में कौन सी दवाई ज्यादा इस्तेमाल, दिस इज वेरी वेरी इंपॉर्टेंट। आपने सब, ये नहीं है कि कमीशन के लिए इकट्ठे परचेज का लेनी है और फिर सारा साल पड़ी रहेगी और एक्सपायर होती रहेगी, और जो आपको जरूरत है वो मेडिसिन आपको मिलेगी नहीं। प्रायोरिटी जो है बहुत ज्यादा इंपॉर्टेंट है। डिजायर्ड बैलेंस, टाइम, ऑर्डर, डिले एंड सप्लाई, दिस इज वेरी वेरी इंपॉर्टेंट। Procurement, I have already told you that we have the PEPRA rules. There are many methods for purchase of the tender document में 1 envelope होता है, 2 envelope होता है, टेक्निकल डॉक्यूमेंट होते हैं, फाइनेंशियल डॉक्यूमेंट्स होते हैं। इन तमाम चीजों का ख्याल रखना पड़ता है और उसमें इन चीजों को जो है हमारे लिए तो रूटीन प्रोसीजर है, हर साल हम हज के लिए भी करते रहते हैं ये सारे जो 1 envelope मेथड, सेकंड 2 envelope मेथड्स, और इसी तरह ओपन टेंडर, रिस्ट्रिक्टेड टेंडर, नेगोशिएटेड प्रोक्योरमेंट और डायरेक्ट प्रोक्योरमेंट जो है। आप खुद अगर आपने एक दफा टेंडर डॉक्यूमेंट एक दफा दिया, किसी ने कोड नहीं किया, यू हैव गिवन in one tender, then nobody quote, then you give us another attachment, and then nobody quote, then you can directly purchase from the market, but as that price should be to the as per the local market. ये नहीं है कि 1,000 की दवाई तो आप 10,000 में खरीद लें, this is not allowed. Ordering the drugs, this is very very important. What is the stock level? What is the supply period? Normally we give that you should supply in 15 days, 1 month, even 3 months, because it depends upon the quantity. If you purchase a central level in Punjab and a central level in KP, so you have to give the timeline so that manufacturer, the gas, the GSK, Novartis, Aventis, any firm that is allowed by us, that is allowed by me at that time, they are all bound to supply in specific times. मिनिमम स्टॉक लेवल जो आपके पास होना चाहिए वो जरूर होना चाहिए कि किसी वक्त भी आपकी for running of the hospital, minimum stock level should be available at any time. Emergency medicine should be available in each hospital, in every ward, in every premises. Storage, this is very important. In Pakistan, as I told you, that we take medicine just like pakoda, samosas, and biscuit and chocolates. You must avoid where you store the medicine. There should be temperature control, there should be humidity control, there should be light, and it should be ventilated places. If you see in the hospital, you can see, you visit all the hospital, then you visit canteen and you visit medical store. Canteen and medical store will be equal premises. Medical store is the most neglected place in the hospital. If you have any observation, you just go with me and I will give you proof. So it should be not like cafeteria, it should be the hospital, just like other hospitals. Medical store should be not like cafeteria. It should be like other hospitals. And the priority should be given to medical store and pharmacy. Temperature, mostly the dispensers, the Surgeon General was saying that they are doing very well. मुझे कोई बता सकता है कि इस वक्त दुनिया में कितनी तादाद है दवाइयों की, सिर्फ फिगर बता दे, any healthcare professionals. What is the number of medicines available in the world? सिर्फ फिगर चाहिए, कितनी तादाद है, कितनी जी? 10 लाख। पाकिस्तान में शायद बताओ 1871 टोटल दुनिया में मेडिसिन है और पाकिस्तान में 2000 से ज्यादा है। जो हमारे पास well registered medicine, we have more than 80,000 in Pakistan. We have the same different number with same medicines. In Pakistan, we give different numbers in different dosage forms and different strengths. We give separate numbers, so we have 80,000. But in the world, total is 18,071. So this is, if we don't know the number of medicines which are available in the world, what to talk about the other expertise in medicine? This is an ocean, every field is an ocean. So it is not possible the pharmacy technician or dispenser to work as a pharmacist. Otherwise, my request will be that if pharmacists, if dispenser can work at the place of pharmacist, then dispenser should also work at the place of registered medical practitioner. So this is the difference. FIFO is very, very important. Fast entry, fast out, and fast expiry and fast out. When you purchase the medicine which you enter into your premises, it should be out fast. And also those medicines which are expired fast, it should be dispensed fast, so that there should be no expiry in the premises. And moreover, the most important, the rodents, the insects, they should be not available in pharmacies, in the hospitals. Organization of the drugstores, I don't go into detail. This has been same as FIFO, so I go ahead. Distribution, because मैं इंशाल्लाह टाइम से पहले खत्म करूंगा ताकि जी बिल्कुल मैं सेकंड लास्ट है जी मैंने आपको कहा था मैं आपको बोर नहीं होने दूंगा अभी तो डॉक्टर शहजाद साहब की तरह मैं अभी बातों में नहीं आया क्योंकि आप लोग थक चुके हैं और मुझे आप लोगों का एहसास डिस्ट्रीब्यूशन दिस इज डिस्ट्रीब्यूशन मैं सादा से अल्फाज में कहूंगा दिस शुड बी from main pharmacy to the OPD to indoors to OPD and all to operation theaters and other places and emergencies and other premises. It should be distributed. All should be documented. All should be documented. Without this, I have worked in a hospital in Fauji Foundation Peshawar. मैंने देखा है कि वो झोली के अंदर जो है वो माई जो है दवाइयां लेके जाती है तो अगर if billion of dollars are can spend in hospitals, then for medicine at least you should take one tray, plastic tray. The review is the last slide, the review. At the end of the year, when you are going to purchase next medicine, first review the last purchase which we have done, which medicine you have purchased in accurate quantity and strength and dosage form and like that. Which medicine you should not purchase in next year. You have to review all the spectrum. Until unless you don't review, you will repeat the same mistakes which you have repeated, which you have done last years. So review of the purchase of medicines is very, very important. With this, thank you very much. Questions जो है मैं वेलकम करूंगा एनी क्वेश्चंस और इस सेशन के बाद भी क्वेश्चन हो तो मैं हाजिर हूं रिगार्डिंग क्वालिटी ऑफ मेडिसिन फार्मा इंडस्ट्री इन पाकिस्तान anything about quality of medicines I am responsible. Any question? Yeah, Dr. Shahid is doing question, who is my colleague and I also my subordinate, he remained my subordinate and also I recommended him for PhD for us in Australia. Yes, sir.
recent past, we have seen that there are shortages of medicine and for example, paracetamol or something. Give your suggestion how we can avoid these shortages at the time.
I think along with the quality of medicine, availability of medicine was also my responsibility. Before that, when there was one Askari Pharma in Bhai Peru, it was under the Fauji Foundation. Sadar General Mushtaq Sukhera Sahab, he was also the head of that institution as a Medas. He has started, you know better. Paracetamol is manufactured in Bhai Peru and sold to the private investor. I was chairman of Central Licensing Board. I went there because it was a basic manufacturing. So I give him license and also take some risk. And paracetamol raw material is manufactured in Pakistan. It is purchased for Calpol and Panadol and all the pharma industry. I give the number more than 200 pharma industry they are purchasing from. That is new name is City Pharma by Peru. So all raw material is manufactured in Pakistan, in Bhai Peru. there is no shortage of paracetamol in Pakistan. The reason was that we were increasing the price of paracetamol. The pack of paracetamol tablet is maybe 200 in one box. So the chemist, he don't want to sell in 20 rupees per pack, per strip, because price was increasing and there was no retail price on individual strip. So he keep it with himself. This was the reason there was no shortage of paracetamol in Pakistan. This is the bad habits of our retailers.
Sir, my question, as you remain as chairman, quality control board, as well as chairman, licensing authority, can you comment on these net item medicines that are available in the market? I mean, what effort you put to, of course, everybody knows, from licensing authority to quality control board to pharmacy person to doctor. What effort you put to stop this malpractice?
What do you mean net
items, sir?
What are net items?
So I would like to explain it. There is an injection of a pharmaceutical company, Axone, with the name of Axone. Okay, there is price written on it for 1 gram. It's 300 something, and they are providing it on the pharmacies on 100, 150, wherever they have the mutual. So
I must say, you have Rosifen, maybe his price is more than 600 per injection.
Sir.
Actual cost is 30 rupees. So
actually, they are not.
I am manufacturer, I can sell at 50,
Sir,
100,
actually, they are
150,
providing it on the
200.
retail-
So there's no
retail
problem.
price,
This
sir.
is business. This is business.
Sir, actually, Rosifen, they are providing it on retail price. However, the others are providing it on less price as compared to the mentioned price on that.
फिर भी हमें मुनाफा है, फिर भी हम अमीर हैं। 2 साल बाद जिसको मैं लाइसेंस देता हूँ, वो मेरी बात नहीं सुनता।
Dr. Sheed is here tomorrow. I want to take a question from online. Eyes Kashkari. Can you hear me, Eyes?
अयाज खास के लिए जी आपको आवाज आ रही है?
जी आ रही है, आप सवाल करें।
थैंक यू डॉक्टर साहब, मैं अयाज खास के लिए कराची से बात कर रहा हूँ। आपकी प्रेजेंटेशन माशाल्लाह बहुत अच्छी थी, लेकिन एक चीज आपने जहाँ ड्रेप का जिक्र किया, तो एक ड्रेप पे 4 सूबे हैं और चारों प्रोविंसेस में डिफरेंट ऑपरेशंस हैं। जैसे आपने अभी मिसाल दिया कि जब हम मेडिसिन प्रोक्यूर करते हैं तो केपी के बहुत स्ट्रांग है, वो फैक्ट्री विजिट करता है, इंडस्ट्री विजिट करता है, उसके बाद डिसीजन लेता है। पंजाब का में, सिंध का में या आजाद कश्मीर और इस्लामाबाद, वहाँ पे ये मामला नहीं है। तो क्यों कानून मतलब सबको ड्रेप एक जैसा क्यों नहीं, मतलब वो फॉलो क्यों नहीं होता?
तो मैं बता देता हूँ कि when we are a clean environment, so every province is legally competent enough to purchase medicine as per their provincial rules.
Thank you very much.
Every provinces, they have their own systems. Any more questions? Thank you very much. So nice of you.
Thank you very much.
मेरी एक रिक्वेस्ट है कि कल आप वक्त पे आइए। Also from those attending virtually, they should also join this session tomorrow and time. Thank you very much.
We will start the session sharp 9:30. Please.
आपकी पेशेंस का शुक्रिया।
बहुत शुक्रिया।